Good morning all. So how was the day yesterday? How was the workshop? Good. Yes. So basically thanks all of you for attending the yesterday's marathon session. We have received few feedbacks also regarding the course. Like many of you are interested to have some similar hands-on experience on ECMO. So we'll definitely promise that we'll definitely try to a similar kind of event on the ECMO and extracorporeal therapies soon, and also on the transplant critical care that we are working on. So not to delay further, so today also will be a very hectic day for us, so let not delay it, and again the session will start from our nephrologist Dr. Ashwathi. So she is our consultant nephrologist, transplant physician. She had done her MD DM, and she was previously working with KM Hospital. Now she is working in Apollo Hospital since 2019. She has a vast experience in the field of nephrology, and I welcome her to deliver a talk which is Hyponatremia, Challenges, Evaluation and Management. As you know, hyponatremia is one of the most common electrolyte abnormality, and rapid correction is dangerous, and also to diagnose and treat hyponatremia is always a challenge, particularly for intensivist and both for the nephrologist. So that is the reason. So this talk is going to be eye-opener, and I think we have to adopt the protocol what she is going to talk, definitely. So welcome Dr. Ashwathi, and let's start the session. Thank you.
For the introduction, sir. Good morning, everyone, and a very warm welcome to all of you on the second day of our Nephrocritical Care Conference. So today I'll be talking about hyponatremia, challenges in its evaluation and management. So this is a very vast topic, and I'll be limiting my talk to acute hyponatremia and chronic severe symptomatic hyponatremia. Hyponatremia is the most common electrolyte abnormality seen in hospitalized patients. It is defined as a serum sodium below 135 millimoles per liter. So even though hyponatremia can be caused by a decrease in total body solute content, the vast majority of hyponatremias or any dysnatremias occur from a primary imbalance of electrolyte-free water intake and loss. So dysnatremias are mainly a water problem, and clinicians should develop this reflex to, whenever they approach a case of dysnatremia, to look at what is wrong with the electrolyte-free water intake and loss. So these are all familiar terms: osmolality, and tonicity. Are they interchangeable? So osmolality is the concentration of osmoles dissolved per kilogram of plasma water. So for all intents and purposes, it is almost the same as osmolarity. They can be interchanged. Usually in scientific discussions, osmolality is used. Tonicity is something different. This denotes the concentration of osmoles which are effective osmoles that do not freely cross cell membranes. So tonicity is what drives water transport across cell membrane. Sodium and glucose are obligate extracellular solutes. They are effective osmoles, and they contribute to both osmolality and tonicity. However, urea, which is membrane permeable, would contribute only to osmolality without affecting tonicity. So if you have hypotonic plasma, this would cause water going into the cells and cause cell swelling. On the other hand, if you have hypertonic plasma, this would cause cell shrinkage. It's very important to remember, not forget potassium, because there are a lot of therapeutic implications also. This is the principal intracellular cation, and it also contributes to overall body concentration and tonicity, as we know from the Edelman's formula. So now you may ask me a very good question. So if urea is an ineffective osmole, why do some patients develop dialysis disequilibrium? So is everyone familiar with dialysis disequilibrium? So what happens in dialysis disequilibrium is that there is a urea lag. So the rate at which dialysis removes urea is lower than the diffusion rate. That is why you develop brain swelling in these patients. And patients with chronic kidney disease, they have increase in aquaporin channels in their cells and decrease in urea channels in the cells. So we can look at this case. A 65-year-old woman presents with productive cough, shortness of breath and fever. She's taking hydrochlorothiazide daily for hypertension. Physical examination reveals temperature of 38.5 degrees Celsius. She's slightly hypotensive. She has tachycardia, tachypnea. She's hypoxic. She has dry mucous membranes, left lower lobe crackles. This is her electrolyte panel. Sodium is 128, which is low. Serum urea nitrogen is high. Creatinine is 3.4, and the osmolality is 280. So this patient's serum is correctly described as, is it A, hypotonic hypoosmolar? So the osmolality is normal. Is it hypotonic and isoosmolar? Is it isotonic and hypoosmolar, or is it D, isotonic and isoosmolar? So the patient's osmolarity is within the normal range. It was 280, and her effective osmolality or tonicity is 256. So tonicity cannot be directly measured. You can measure osmolality, and from tonicity, for tonicity you need to subtract the contribution of urea. So urea does not contribute to tonicity, therefore she is isoosmolar and hypotonic. So what is pseudo-hyponatremia? One thing is there is actually no hyponatremia and the patient is not hypoosmolar. It is a measurement artifact which is caused because of a discrepancy between measured serum sodium and the true sodium concentration in plasma water. And this is because usually when we measure sodium in our labs, we use indirect potentiometry. So this can occur in patients who have hypoproteinemia because of multiple myeloma, IVIG, infusion, and typically the serum protein is more than 10 grams in these patients. Hypertriglyceridemia, hypercholesterolemia. So the most practical way to overcome this is to use blood gas analyzer because direct potentiometry is used. So we use it in these following circumstances. One is if it's an overtly lipemic sample, and if there is a discrepancy between measured osmolality and calculated osmolality, and in patients with severe hypercholesterolemia. So it's important to remember that this does not represent true hyponatremia, and even the serum is not hypoosmolar. So clinical manifestations of hyponatremia, one is it is divided into either acute or chronic hyponatremia. So this 48 hours cutoff is not arbitrary. 48 hours is the time the brain takes for adaptation to chronic hyponatremia. But for all intents and purposes, if you have a patient presenting to the hospital and duration of hyponatremia is not known, it is to be assumed that the patient has chronic hyponatremia, except in certain circumstances which I'll touch upon later. Symptoms of hyponatremia are primarily neurologic. It could range from mild nausea and vomiting to lethargy, headache, confusion, muscle cramps, and it could be more dangerous, including cerebral edema, seizures, coma, brainstem herniation, and even neurogenic pulmonary edema. So patients with chronic mild to moderate hyponatremia can also have some cognitive impairment, falls, risk of fractures and osteoporosis, gait instability, mortality, and they can have increased mortality and calcium-forming kidney stones. So how do we approach a patient with hyponatremia? So we obtain these labs. One is we get a full set of electrolytes, including calcium, magnesium, phosphorus, glucose, and also uric acid. Serum osmolality, so many times this is skipped because it's very rare to get pseudo-hyponatremia. We look at cortisol levels, urine osmolality, and urine sodium. So by far the most important of all this is urine osmolality. And when it comes to interpretation of labs, a note of caution. So traditional diagnostic algorithms may fail because patients can have multifactorial hyponatremia. They may not fit into one box. Nonetheless, laboratory tests can often point us in the correct direction. So the most important lab test for patients with hyponatremia is the urine osmolality, and it's important to understand how to interpret it. So a crude estimate of how dilute the urine is can be obtained by looking at the urine specific gravity. If the specific gravity is less than 1.010, it suggests dilute urine. If it's above that, it suggests concentrated urine. Most of the times, urine osmolality is more than 300. Concentrated urine indicates that the kidney is still inappropriately retaining water in a patient with hyponatremia. And this kind of also indicates that the patient is not going to autocorrect. And if a patient has very high urine osmolality, if you give the patient isotonic fluid, this could potentially worsen the hyponatremia by a process termed desalination, because the patient will end up retaining water and excreting sodium. So patients with SIDH with very high urine osmolality, giving that isotonic saline challenge can be potentially dangerous. So dilute urine is when the urine osmolality is much less than 300, usually less than 100, and the specific gravity is low. This means the kidney is doing its job. It is appropriately secreting water. That is what it is supposed to do. So this can suggest one of the following. One is hyponatremia is due to a lot of water intake, more than solute intake, and the patient is in a recovery phase from some other cause of hyponatremia. For example, if you have a patient who is hypovolemic, then that becomes a non-osmotic stimulus to ADH production. And if you give the patient even a small dose of some isotonic fluid, they'll suddenly, stimulus for ADH is switched off, and the patient will secrete a lot of dilute urine. So initially the osmolality may be high, but once you've started correcting and then you check the urine osmolality, it would be low. And in a patient in whom you have started sodium correction, and if the patient produces a large volume of dilute urine, if it is more than 150 to 200 cc per hour, it is a sign that the patient is about to overcorrect, and we should be very cautious in these patients. So how do we approach a patient with hyponatremia? First, we check if the patient is genuinely hyponatremic. So you can do direct potentiometry if pseudo-hyponatremia is suspected. This is on blood gas. Once that is ruled out, we look at if the patient is genuinely hypotonic. So patients can have hypertonic hyponatremia. So with hyperglycemia or mannitol, there is translocational movement of sodium in the extracellular compartment, and they may actually not be genuinely hypotonic. The next thing is to look at the urine osmolality. If the urine osmolality is low, which is appropriate in these patients, it could be primary polydipsia, it could be beer potomania, and it could be low solute diet. So this is a very unusual condition where we might be actually having a solute problem. So this is the exception rather than the rule. And if it is AVP mediated, that is the urine osmolality is more than about 300, this is now truly pathological. So it could be because patient has hypovolemic hyponatremia, where again the urine osmolality will be high initially, but then these are the patients who tend to overcorrect because even a small amount of isotonic fluid and that will switch off the ADH, and the patients can start passing huge amount of dilute urine. Second, if you have euvolemic hyponatremia, most commonly it is SIDH, rarely glucocorticoid deficiency. And hypervolemic hyponatremia, this is because of a decrease in effective circulating blood volume. So this is a rare scenario where water intake is much more than solute intake. So just to give you an example, if the urine has a maximal diluting capacity of 50 milliosmoles per day, and you consume a diet which generates a solute of around 800 milliosmoles, so the kidney can maximally secrete 16 liters, that is 800 divided by 50, of solute-free water. So you need to drink more than 16 liters of water to develop hyponatremia. On the other hand, if you're having a very low solute diet, patients who are on a tea and toast diet, or patients who have excessive beer intake with reduced solute intake, so the amount of milliosmoles generated would be maybe around 200, for example, and the maximal diluting capacity is only 50 milliosmoles per liter. So the maximum free water excretion that the kidneys can do is around 4 liters. So anything above 4 liters, and that can lead to hyponatremia. So then this is the only condition where you actually have a solute problem. So management of hyponatremia, you need to manage two things. One is the risk of seizures of herniation due to hyponatremia, and the risk of ODS due to rapid correction. So on one hand, you have cerebral edema, and on the other side, you have a very dreaded complication of hyponatremia correction, that is osmotic demyelination. So we move on to the next case. A 45-year-old man with known heart failure is admitted with a change in mental status in the past day. Family states he has been complaining of excessive thirst. His medications include furosemide, metolazone. On physical examination, his vital signs are stable, but he is disoriented and agitated. Laboratory results show sodium of 118, potassium of 2.9. And most importantly, he is hyponatremia and he is obtunded. So what would you do? You would treat with 3% saline at 100 ml over the next 3 hours. restrict water intake only. C, use tolvaptan. And the last option, restrict water intake and use tolvaptan. So this is a patient with severe hyponatremia. Any hyponatremia less than 120 is considered to be severe hyponatremia, and he is also obtunded. So the answer is A. This is a hyponatremic emergency. You treat with 3% saline. So the initial package, you order hyponatremia lab panel as described before. It's very important to prevent further water intake. So patients who have very severe hyponatremia, it is even suggested that you keep them nil by mouth for some time. And in patients with high circulating ADH levels, that is very high urine osmolality, isotonic fluid can actually exacerbate the hyponatremia, and it could be potentially dangerous. If a patient is symptomatic, so this is irrespective of whether this is acute hyponatremia or chronic hyponatremia. If you have a symptomatic patient with severe neurological symptoms, you have to correct it right away. So you can give 150 ml of 3% NaCl or 100 ml of 3% saline in 15-minute intervals, and you target an increase in serum sodium of 3 to 6 millimoles. So isotonic fluid challenge is a very common practice. It's very common for patients to get 1 to 2 liters of isotonic crystalloids shortly after presentation. So this can also, even though this is potentially dangerous, it can also be diagnostically illuminating. If the sodium increases, this indicates that the patient is making dilute urine. If the sodium decreases, this confirms the diagnosis of SIDH. It means it implies the presence of concentrated urine. So what are the indications for bolus of IV hypertonic therapy? Strongest indication is symptomatic hyponatremia. If the patient is seizing, if he's confused, if he's headache, nausea, vomiting, dizziness. Hypotonic therapy may also be considered for patients with profound hyponatremia in whom any further worsening could be life-threatening. Someone comes with a sodium of 108 and strangely is not symptomatic. So you could still consider hypertonic therapy for them, but then the boluses would not be required. So when it comes to dosing of hypertonic solution, the formula for initial guidance is 1 ml per kg per hour of 3% saline administered over the next 6 hours. And each 1 ml per kg per hour of 3% saline can be expected to increase sodium by 1 milliequivalents per liter. So we can completely overshoot. This formula is considering that there is no free water clearance. So it's very important to keep monitoring electrolytes. The goal is to increase the sodium by only 3 to 5 millimoles, which should cause clinical improvement. So if the symptoms still persist, if the sodium has increased by less than 4 millimoles and then patient is still symptomatic, you can give an additional round of hypertonic therapy. However, if the sodium has increased by 6 millimoles and the symptoms have not resolved, then hyponatremia probably is not the cause of the patient's symptoms, and we'll need to look for alternative or additional problems. It's very important to stick to the target rate of sodium correction. Target is 6 to 8 milliequivalents per liter every 24 hours. Excessive rapid correction runs the risk of osmotic demyelination, which is extremely debilitating and very importantly won't be obvious immediately. And the key is the net rate of correction. If the sodium corrects too rapidly, that is completely okay as long as you bring the sodium back to its target value. So for patients with acute hyponatremia that is developing less than 48 hours, faster rates of sodium correction are completely safe. One is exercise-associated hyponatremia or MDMA intoxication. A third situation is where you have a patient who is hospitalized, you have his historical labs, he has undergone surgery, he is in pain, which itself is a potent stimulus for ADH release, and he is getting hypotonic fluids. A patient like this, if he develops hyponatremia, you can correct it rapidly. However, all patients presenting to hospital with hyponatremia, this should be assumed to be chronic and treated accordingly. So what about the physiology of overcorrection? It is almost never due to the practitioner giving too much of sodium chloride. Common causes are, one is the cause of underlying hyponatremia is reversed, and this causes the body to suddenly excrete a lot of free water. Second, very importantly, is potassium chloride administration without taking into account the effect this will have on sodium. And third, and the most dangerous one, is treatment of hyponatremia with Vaptins. So initially, Vaptins should never be used. It's very important to remember that overcorrection is okay and it is easily treated if it occurs. Patients who overcorrect will do fine if their sodium is immediately lowered, and patients who develop osmotic demyelination are patients who overcorrect and nothing is done about it. So have you ever overshot your goal for hyponatremia correction? See, of course you have. So the key correction concept is that you need to get back on track. So I'll come to the DDAVP clamp in some time. And the other key concept is delayed deterioration. So even if the overcorrecting patient looks okay, they're still in trouble, and this needs to be actively managed. So DDAVP clamp technique is used in patients who are at high risk for overcorrection or patients who have already started to overcorrect. General concept of DDAVP is that it prevents the kidneys from secreting free water, and it completely takes the patient's kidneys out of the equation. Patient essentially becomes like a passive container and will have very predictable behavior. So out of all the correction strategies, giving isotonic saline, giving Vaptins, and giving 3%, a lot of people are scared to give 3%, but it is the safest way to correct hyponatremia. So when it comes to the strategy for using DDAVP clamp, I'll just come to it in some time. This concept was introduced in 2013, and there are several strategies which can be used. It can be proactive, reactive, or rescue. So proactive strategy is using DDAVP clamp right at the onset of treatment. A patient comes with severe hyponatremia, you give the clamp, and then you start correcting with 3% saline, and as and when required, you give DDAVP again. Reactive strategy is when you have started correcting with 3% saline, but then you are overshooting your goal. In that case, you can institute DDAVP to re-lower the sodium. And a rescue strategy is when you have already overcorrected in a 24-hour period, and then you are trying to re-lower the sodium. So typically, this is done with instituting the clamp again and by giving D5. The dose is 3 ml per kg per hour over 3 hours. So this should bring the serum sodium down by 1 milliequivalents per liter. So this is a very devastating and debilitating condition which occurs if chronic hyponatremia is corrected too rapidly. It occurs in a biphasic pattern. You have initial improvement neurologically, and a few days later you have progressive and sometimes permanent neurological deficits. So ODS can come as late as up to 4 weeks. A patient may get better, may go home, and would come back as late as 4 weeks with osmotic demyelination. So they can present with paraparesis or quadriparesis, diplopia, locked-in syndrome, loss of consciousness. Most common area affected is the pons. And lesions may not develop until 2 weeks after development. So an initial normal imaging does not rule out the diagnosis. So this is the classical trident sign which you can get from overcorrection. So what are the risk factors? One is there is a reversible cause of hyponatremia. Second is the chronicity and severity. The other risk factors include hypokalemia, cirrhosis, alcoholism, malnutrition, and a high rate of sodium rise. The greatest risk is if a person transitions from hyponatremia to hypernatremia, and this should be very aggressively avoided. So it is not all bleak when it comes to CPM and EPM, and several studies have reported full recoveries. This was a disorder that was once thought to have a very dismal prognosis. So a series of 24 patients identified at Mayo Clinic. There was a favorable outcome in 60% with an overall mortality of 8%. And these findings indicate that recovery from severe ventilator-dependent CPM or EPM is likely, and that for an individual patient, the prognosis cannot be predicted on the basis of clinical presentation. And aggressive supportive care is warranted in most patients before you declare that the situation is hopeless. So this is a third patient. I'll just straight away go to the labs. She's brought to the emergency department with severe hyponatremia, hypokalemia, and she experiences a generalized seizure. So we are very clear what to do now. We give her boluses of 100 ml 3% saline over 10 minutes. You have a colleague who's planning to run a marathon race for the first time, and he's concerned about developing electrolyte complication, and he asks you how best to prevent such an event. What would you advise him to do? Drink a glass of water for every mile, take salt tablet and at least 4 times during the run. Drink only when you're thirsty, and take a salt tablet before and during the run, as well as a glass of water for every mile. So any guesses? So this is exercise-associated hyponatremia. So this is one condition where you have a patient presenting to the ER, and you can see this is acute hyponatremia, and the rate of correction is immaterial. So this was, the general thinking once upon a time, especially in the 1980s and 90s, that drink a lot of water, timing is very important, and get as much of sports drink as you can. And there used to be a lot of water stations during marathons. So exercise-associated hyponatremia is defined as plasma sodium concentration of less than 135 within 24 hours after prolonged exercise. It was first reported in 1980s. That is because in 1960s and 70s, runners were told not to drink water. So you used to have a lot of dehydration and collapse due to that. And this is most common in marathon and ultra-marathon runners. It is asymptomatic in most cases. The incidence of exercise-induced hyponatremia is highest amongst women participants with low body weight, lack of training. Other factors include excessive intake of water, warm temperature, and use of NSAIDs. And the pathogenesis is increased water intake, compounded by loss of sodium in sweat and urine, and also because of an increase in vasopressin. So this should be treated based on the severity of symptoms. If a patient has mild exercise-associated hyponatremia, you can ask them to take some hypotonic oral solution like vegetable broth, and it's a good idea for them to drink water only once they have started passing urine. However, patients who have severe symptomatic hyponatremia, you need to treat them rapidly with IV hypotonic solutions. So in many situations, sodium measurement is not readily available. So patients suppose there's someone who is, running in a marathon and who has suddenly collapsed, is seizing, it is imperative to treat them empirically with 3% saline even before you get your lab results. So rate of correction is not important. It's an acute event, does not generate cerebral adaptations that account for risk of overly rapid correction. So this is a repetition again. So someone who has seizures, coma, decorticate, posturing, don't even wait for the sodium values. Straight away give them 3% saline. And the recommendations are endurance athletes should drink according to thirst, and we should have fewer water stations at endurance events. And it is important to have facility for on-site analysis of serum or plasma sodium. And it is important to also serially measure body weight. So if you have a runner who is gaining weight during the run, this is someone who is actually at risk of exercise-associated hyponatremia. Frequently overlooked is the effect of potassium correction on sodium correction. So when you administer KCl, this will increase the sodium concentration just as much as NaCl would. They have the same impact on tonicity. So 50 milliequivalents of oral KCl would have approximately the same effect as 100 ml of 3% NaCl. So this should be accounted for in patients with significant hypokalemia. So in some patients who have moderate hyponatremia and moderate hypokalemia, only oral repletion of KCl will simultaneously address both the problems. So some take-home points: don't forget to implement free water restriction for all hyponatremic patients. Suppose you have a patient who has got a DDAVP clamp, any intake of free water would lead to worsening of the hyponatremia. Very importantly, do not use Vaptins. If you use Vaptins are just the opposite of DDAVP clamp. If you use a DDAVP clamp, again, be sure to restrict the patient's fluid intake. And patients with symptomatic hyponatremia, irrespective of whether it is acute or chronic, should be treated with hypertonic fluid. If the patient's sodium rises too quickly, don't give up. Patients may look okay for a while, but they may develop ODS. And if the patient's sodium overcorrects, give them DDAVP and water and reduce the sodium to the appropriate target. Thank you. So I'm happy to take any questions.
Any questions? Yes, sir, please.
Nice talking.
Thank you. Thank you, sir.
So, a couple of rapid questions. First, in your list of pseudo-hyponatremia, hyperglycemia should be mentioned?
Sir, hypoglycemia is not hyponatremia. This would actually be hypertonic
Hyperglycemia. So, one of the factors contributing to hyponatremia, pseudo-hyponatremia is hyperglycemia, gross hyperglycemia.
No, sir. Pseudo-hyponatremia is a measurement artifact. So this is because we use indirect potentiometry. It's purely a measurement artifact. There is no hyponatremia and there is no hypoosmolality in these patients. So when it comes to hyperglycemia-induced hypernatremia, that is actually a hypertonic hyponatremia. This is because glucose is an effective osmol and this will lead to increase in tonicity, and this leads to translocational draw of water from the intracellular to the extracellular compartment. So.
Alright. Now, amongst us Asian Indians, one of the most underappreciated factors is uric acid. Now,
Correct.
In the latest edition of Washington Manual, 37th edition, for the first time they have mentioned one of the contributing factors for hyponatremia is uric acid. So, what is your take on that? Do we give them credence to uric acid?
Sir, we look for uric acid in patients with hyponatremia as part of the laboratory evaluation. That is because a uric acid level of more than 4, it is very unlikely to be SIDH. So in patients with SIDH, typically they have a very low fractional excretion of urea and they have low uric acid levels. But uric acid per se, hyperuricemia per se contributing to hyponatremia, I am not aware of that.
It's a headache for all of us to will be faced with that possible problems of central contact diagnosis. So, with all your experience, do you have any algorithm? Can you predict which patients are likely to go into central contact diagnosis?
Sir, there was a slide where, I had mentioned the risk factors for CPM. So one is patients who are alcoholic, patients who are malnourished, patients who have low body weight. Women are at a higher risk for developing central pontine myelinosis. Presence of hypokalemia is also a risk factor for CPM. And very importantly, patients who are autocorrecting, they are also at a risk factor for CPM.
Maybe one can answer you also.
The similar case, we had a case who transferred to us from the Bhopal. So there, I don't know, there might be a rapid correction of hyponatremia was there. The patient had extensive CPM. He came to us almost after 3 weeks. We did the MRI. Patient had all the systems. He was in multi-organ, but he settled down. But ultimately, he didn't have any neurological recovery. The typical findings like central, some bilateral symmetrical enhancement, actually, which is like some kind of metabolic encephalopathy kind of picture. And after a week when we again repeated, it was again extensive and it has spread to the periphery. So this osmotic demyelination actually is a misnomer sometimes. So it is not a central and it is not a pontine actually. Rather the ideal term would be osmotic demyelination rather than a CPM. So now the paradigm is changing. So more and more coming up like osmotic demyelination.
Reports about Mario Inositol having some beneficial effects on this. Any idea?
Sir, one thing I have discussed with the neurologist. So there are some role of early plasmapheresis in CPM. If the patient comes within a very early phase, like if you come to identify that this patient may going to have CPM in 1 or 2 days, the early plasmapheresis sometimes happens. Actually, we have planned for plasmapheresis for that patient, the relative 15%, and we didn't get over.
So, but the only thing which is proven to have any benefit, that to questionable benefit, once CPM has developed, is relowering of the serum sodium. There is absolutely nothing else. Everything has been tried, steroids have been tried, plasmapheresis has been tried, but there is no strong evidence to actually implement it in practice.
This is a nightmare.
Correct.
Physicians totally held responsible for this.
But at the same time, sir, this is something that can develop even if you have appropriately corrected sodium. There are case reports where patients have developed osmotic demyelination irrespective of the rate of correction.
Yes, sir. Dr. Nephro, you want to say something?
You ask me.
It was an excellent presentation. So,
Yeah, thank you, sir.
you talked about going
correction of hyponatremia, correction of hypernatremia is also an issue. Have you seen any neurophysically to correct the hypernatremia quickly?
Sir, never. And there was actually an article also. There has not been a single medico-legal case in US following any neurological sequelae following correction of hypernatremia. So it is probably, this may not be reality. And previously we used to have formulas for correction of hypernatremia also, but then that is now out of practice. We don't, we can correct hypernatremia rapidly. Probably that does not occur. Correction of hypernatremia rapidly does not lead to any kind of neurological sequelae.
The next question is regarding hypertension, as sir is saying. What do you target? You will target the osmolality calculated one, or you target the sodium correction?
Sir, we target the sodium. We still look at the serum sodium.
And what's the target?
So the target will be the same, sir. Chronic hypernatremia, irrespective of the etiology, the target would be same. We only target an increase of 6 to 8 milliequivalents in a span of 24 hours. Be it hypertonic, isotonic or hypotonic hyponatremia.
So, Dr. Nikhanji, like yesterday we were talking regarding this desmopressin therapy. So, can you throw some light on it? Before correcting the hyponatremia.
So we used to use this desmopressin lock, whenever you start correcting. So this was during my continuing development. So I don't think we have access to IVD here. So that's the same protocol that we used to follow. What Ashwin mentioned. We used to use the dose.
2 micrograms.
And then start correcting sodium, whereby you create a closed loop and patients cannot auto-correct. And you can have a very precise correction of sodium. You can actually calculate that you give this much sodium and by tomorrow morning, then by the next 24 hours, the sodium will come by 2-3 points. And you would always aim for a very low, like maybe 4 to 6 level. So even if you overshoot, maybe you go to 6 to 8. So because the medical implications and the neurological implications are like very, very horrible. The patient develops CK, and there is really no reversible. You can try and lower the sodium, but it rarely helps. So I think only precaution is under-correct. Let it correct very slowly. I mean, only indication for correction is neurological imbalances. So give 3% saline only for that period of time. Increase it by 4 to 6 points. Let the patient be neurologically stable, and then again go very slow on the correction point. Always try to find out the reversible factor if there is any. Usually dehydration or that's something which we don't appreciate much, and patient just it gets set off and patient start dialysis, and that's a really bad thing to happen. Now after that I have 2 questions for Ashwin. That was a nice one, very nice. One thing is, is there any basis to the my understanding, and generally, all of us are taught, like it's a nephrocritical care conference, that uremia protects against ODS. So if patient is getting simultaneously uremia as well as severe hyponatremia, you can be a little relaxed about the goals of correction. And second is, any thoughts about how do you protect our CKD or patients with acute kidney injury who are getting dialyzed with a very low sodium? So if a patient presents, whether it's an acute kidney injury or say this patient presenting emergency with a very low sodium and you need to dialyze such patients, how will you protect the correction of sodium which may happen inadvertently after putting them on dialysis?
So uremia is considered to be protective for hyponatremia, and this is based on evidence that we don't see much osmotic demyelination in patients with severe uremia who do actually hypercorrect. The other thing is patients who are on dialysis. Suppose you have a patient with a sodium of 110 who's who needs to be initiated on dialysis. So it's important to set the dialysate sodium. You bring it down to 125. It should be 10 milliequivalents above what the patient's sodium is. But despite that, these patients do tend to overcorrect because you remove ultrafiltration. So there is no good evidence, but then intuitively it is said that uremia is protective for hyponatremia. But there is not much literature to support it. But it's very unusual to have a patient with severe hyponatremia and uremia who goes for dialysis and who develops osmotic demyelination. These patients are at a much higher risk of dialysis disequilibrium though.
So there was a strategy when I was training at this. So what they would do, they would calculate how much of D5 is required to bring down the sodium by 2 points. Like maybe say if you want, if you expect the increase in the sodium, say by around 10 milliequivalents after dialysis, like a short dialysis, then you give that much amount of dextrose or water, IV, to give the dialysis period. So I mean, you can do it if you are getting water about.
But that would be a lot of volume, for a patient who is on dialysis. That's around 3 ml per kg.
You define remove the water.
Okay.
So can be done if you are.
So you simultaneously ultrafiltrate and you give D5.
Dextrose so that sodium remains at least.
Correct.
Great talk.
Thank you.
Looking at the audience for hyponatremia correction, you can clearly see that everybody is very anxious whenever a patient like that shows up. But that being said, I think over the last 10-15 years since the publication of the European and American guidelines, things have become a little better in the sense that all the calculations that you had to do to correct the sodium, it has sort of kind of gone in the back now, and you could just give a 3% bolus and monitor the sodium levels. And that's one. The other thing, I completely agree with you that we don't have to be too anxious about hypernatremia, which is an ongoing phenomenon, especially in your cardiac ICU when we were investigating diabetes in patients. And then the other comment I had was regarding the use of dextrose to help with overcorrection of the sodium. We use that frequently, and in patients who are on CRT, we get started on CRT. Patients who have some liver failure, and if they go on CRT, they have chronic hyponatremia. In addition, then that's a common strategy that we use D5 post-filter to see risk.
Thank you. Just one comment that I had about Ddavp. We don't get IV Ddavp, so we use intranasal desmopressin. So the absorption rates are very unpredictable. And the other thing is, if you have a patient who's on ventilator, who's got an endotracheal tube, it is completely useless giving this patient intranasal desmopressin. You have to give it through the ET tube.
Is it not in this context, but it's something else? Intravenous Vaptans,
Conivaptan, no sir. I don't think it's available anywhere. It's not used anywhere. And in patients with severe hyponatremia, Vaptans are contraindicated. Yeah. So, thank you.
So now I will request Dr. Sanjay Khare sir to present a token of appreciation to Dr. Ashwati. Sir is our senior most physician and he also manages some of the patient in intensive care. So welcome Khare sir and Ashwati. Thank you. So continue with the talk. So the next topic is going to be very interesting, and if every one of you have attended the Zoom sessions on cardio-abdominal renal syndrome. So basically today is the day for cardio-renal syndrome along with the hepatorenal syndrome. So this is the organ crosstalk, and I welcome Dr. Ramanathan sir to present the talk. No other than him can, I think, justified for this topic with a vast majority of experience in ECMO and the transplant care. Please.
Good morning, everyone. Thanks, Gunadhar. In fact, the topic given to me is about cardiorenal syndrome and hepatorenal syndrome. Mind you, these are two big textbooks in itself, and I've been asked to summarize this by Gunadhar and Tapas in 30 minutes. It's a daunting task. I'll try my best. Clearly, one good thing about talking about this set of syndromes is essentially that, as Gunadhar rightly put it, it involves talk about organ crosstalk. More importantly, I find that this kind of clinical syndromes, you need multidisciplinary specialists to get involved to manage some of these patients, and that's where perspectives can be different. So when you have a cardiologist, a nephrologist, a hepatologist, and a critical care specialist looking at this patient from various angles, you may find that their perspectives are slightly different, but the principles of management they all adhere to are the same. So clearly, from at least for the sake of this particular talk, my perspective is essentially more of an ICU perspective. I'm sure, and I welcome all your thoughts and comments from each of your specialty perspective too. And with that in the back of my mind, in the back of your mind, let's jump into what these syndromes are and how we manage it clinically. Now, I want to focus more on the clinical aspect of things, but having said that, it's very difficult to talk about clinical aspect and clinical management of some of these syndromes without actually talking or giving you some facts about it. Now, clearly, we start off with cardiorenal syndrome. And that diagram out there clearly explains that this is very complex. So, my mind works, I like to simplify things, keep it very simple. So, to me, there's that. Yeah. So, my mind tries to keep this very simple. For me, cardiorenal syndrome, it represents the confluence of heart and kidney interactions. And irrespective of how they interact, the way I look at it is there are some hemodynamic factors which affect this. There are some neurohumoral factors that affect this. And eventually, there are some inflammatory molecular signatures that underline the cause of cardiorenal syndrome. So I keep it as simple as that. The other thing at least, for the sake of understanding before we talk about management, is the fact that cardiorenal syndrome in cardiac ICU, it's quite common and on the cardiac side. And you'd find that, when you look at the phenotypes, you essentially have 5 types of cardiorenal syndromes, where you have type 1 and type 3, the acute varieties of cardiorenal syndrome, where either the heart or the kidney contributes primarily to the syndrome. And then you have type 2 and type 4, which are the chronic variants of cardiorenal syndrome. All said and done, the pathogenesis of each of these subtypes is slightly different. Again, I'm not going to go into the details of it. I'm sure, these are all available in textbooks. But the point I'm trying to make here is the way you get a patient's kidney deteriorating in acute heart failure is slightly different when that happens in chronic heart failure. The same thing where the patient who has an acute kidney injury, when he has cardiovascular side effects, it's slightly different in the acute format as compared to how it happens in chronic kidney disease, irrespective of the stage of the disease. So if you understand this part of the aspect, I think, it's going to be, these are going to be the fundamental tenets on which we're going to base our patient management on. And of course, there is a type 5 CRS, which predominantly includes other diseases. And, if you look at literature, most common disease that has been implicated in that pathogenesis is sepsis. So again, that's a different ball game altogether. But certain facts about cardiorenal syndromes in particular. Cardiorenal syndromes per se, if you look at it, types 1 to 3 are the most common. And you got to understand that presence of an acute kidney injury in a patient with acute decompensated heart failure in itself is an independent risk factor for mortality. Mind you, this risk factor is enhanced if your patient has acute decompensated heart failure from an ST elevation MI, or if the patient has a concomitant reduced LVEF. So essentially, the mortality is higher. You have, as I said, a chronic kidney disease interacting with the heart as well. And in fact, as one of the speakers was highlighting yesterday, more than 50% of the causes in CKD is attributed to a cardiovascular cause. So again, it's another fact that you need to know when you manage these patients. In a critical care setting, you'd find that, patients who have septic shock, about 50% of them with septic shock and positive blood culture, they develop AI. They also have some element of cardiac dysfunction, whether it is diastolic, systolic, or combined diastolic, systolic. And if you take critically ill patients as a bigger cohort, not the ones with just septic shock, about 1/5 of them do get this kind of syndrome, end up having both cardiac and renal manifestations of their critical illness. There are certain risk factors that predispose to cardiorenal syndromes type 1 to 3. I'm not going to again go into these details, but again, this is more for awareness and brushing up your memory than anything. To me, knowing all this helps you in a better way to prognosticate your patient by the bedside. And to prognosticate your patient by the bedside, I think, we should discuss this particular syndrome in the context of a clinical case. So unless and until we discuss the clinical tenets of management, you're not going to understand the nuances of what are the difficulties you face by the bedside. Yes, you can talk about pathogenesis, you can talk about risk factors, you can talk about all these facts about cardiorenal syndrome, but at the end of the day, when the patient is in front of you, trying to survive, what are you going to do to make a difference to his survival? So to discuss this further, I'll bring in a case history. So you have a 63-year-old male who essentially has acute decompensated heart failure. Mind you, he's got a history of diabetes and hypertension. So you clearly saw from the risk factors that he's vulnerable to this. His BP is currently 100/75. It's not bad. but he's got a CVP that's quite high and he's got peripheral edema. Now, his admission serum creatinine is about 1.7, and his bedside echo shows that his ejection fraction is 35%. His pulmonary pressures are high as well. He's got ascites, pleural effusion, and this is the classic patient with acute decompensated failure that would present to any cardiac unit with some amount of kidney dysfunction too. I mean, by the bedside, you would clearly go by, as an intensivist, I would go by what I've been taught, go by airway, breathing, circulation, make sure that he's stabilized. And in that process, I also make sure that his underlying problem is treated. So clearly, the first line drugs I would probably use, given that his heart failure is predominant here, I would start him on nitrates and diuretics. I tried to aim for a negative fluid balance. So by virtue of starting him on furosemide, I was able to get his fluid balance down to 2 liters. The next day, this is what happens. Essentially, you would find that the urine output starts to tail off and the serum creatinine has now jumped. Clearly, a clinical conundrum as to what you're trying to do is whether it is doing harm or whether the patient is clearly benefiting out of it. And this is a common conundrum we all face when we treat patients with acute decompensated heart failure who start developing cardiorenal syndrome type 1. Now, clearly, I told you earlier on that, in the context of cardiorenal syndrome type 1, acute decompensated heart failure tops the list. It can also happen in the setting of contrast-induced nephropathy for acute coronary syndrome, and more commonly, in cardiac surgical patients who come back after cardiopulmonary bypass. So these are the other causes for cardiorenal syndrome in other patients. Now let's come back to this patient again. Why am I worried about this patient's deterioration on day 2, and what am I going to do here differently? So again, as I said, this is a nice conundrum to have by the bedside where you are trying to figure out what you need to do for your patient. Now, at least from evidence, I can conclude that, the in-hospital mortality is less as long as I'm going to be on diuretics and vasodilators. The moment I start an inotrope, the mortality is going to jump in this context. The second thing which worries me is the way serum creatinine has gone up. Clearly, it has jumped by more than 0.5 milligram per deciliter. Again, makes me think whether it's correlated with a higher odds of mortality here. Now, the problem you face essentially is you clearly know that from a baseline, if serum creatinine were to rise, say by 0.3, 0.4, 0.5, the odds of mortality will also go up. So clearly, you're now in a situation on day 2 as to how you're going to treat this particular patient from here on. You can clearly see some signs of bad prognosis, but then, you also know that you have not fully treated this patient yet. So with this in the background, we'll come back to the patient later. I'll talk about how we generally manage cardiorenal syndromes. And you got to understand that when you treat cardiorenal syndrome type 1, you clearly know that the primary driver of CRS1 is venous congestion. So as part of your management, decongestion still remains the first-line therapy in such patients. Now, a few things that are predictive of renal dysfunction. One thing would be your RA pressure or your CVP. Clearly, you went through some of the POCUS sessions and the VEXUS sessions yesterday, and clearly, intrarenal venous flow patterns, they are a very nice emerging tool to identify renal congestion, and in fact, they have been used as prognostic tools in patients with cardiorenal syndrome. So again, one way by the bedside as to what all you can assess, as to what are going wrong or what things you can do differently. Clearly, as I said, to decongest the patient, you need to assess what's the volume status of this patient. So that becomes really tight or very difficult in a critically ill patient for many reasons. Of course, there is always this unresolved issue of what is the optimal method to assess fluid status in patients with, say, cardiac and renal failure. People have used different yardsticks. Clearly, newer emerging modalities can be helpful in this scenario. But whatever said and done, most of us, we go by clinical methods, and irrespective of a lot of these guidelines which talk about some of the latest available devices to measure volume status in such patients. You also have a set of biomarkers available. You heard the talk yesterday as to how this can be useful in the setting of cardiorenal syndrome. There are a list of cardiac biomarkers, kidney biomarkers, especially those of glomerular and tubular biomarkers. And again, from an array of these biomarkers, which one are you going to use? More importantly, how many of these biomarkers can be measured in your hospital? So again, that becomes very important question when you manage these patients. Clearly, knowing about these things is one thing, but being practical by the bedside is the other thing. Of all the things that has been found to be useful, NGAL and the TIMP IGFBP, what is called as the Nephro check kit, have been at least been validated in a lot of studies. I can tell you that this kit is currently approved by FDA, and it has been validated in cardiac surgical patients as an early marker of kidney injury. So even before your serum creatinine goes up, about 48 to 72 hours prior to that, these values go up to give you an indication that there is an impending renal injury to this patient. So if it is available, you can use it, but very often, you are in a scenario where Nephro check kit may not be easily available in your locality. So again, what happens? You do a clinical assessment and go by what is available clinically. And as I was telling you early, my concern was this rising creatinine in this patient. Now you got to understand that when you're going to start your patient on diuretics as part of decongestion, the serum creatinine is going to go up. Now, even though I showed that the odds of mortality is high, the fact still remains that despite a rise in creatinine, these patients survive long-term better. So it's not a concerning fact that the serum creatinine went up by 0.5. You continue to diurese him. You would find that even though their baseline creatinine might shift to a higher level, they may still leave the hospital and survive further. Right? So don't stop your decongestion therapy based on the fact that the serum creatinine jumped on day 2. That's the point I'm trying to make here. The next question is, okay, fine, you use diuretics. How much and how fast? Mind you, your goal here should not, your goal should be more towards maintaining normovolemia, and in a clinical setting, you usually use loop diuretics. Clearly, the questions on whether you use intermittent or continuous infusions of diuretics always is there. And as I said, the best clinical measures, at least what we use, would be the patient weight and the patient urine output. In terms of other third-spaced fluid, you might reach a stage where you might have to do paracentesis for the ascites. And in this setting, you might have to combine it with concentrated albumin, and that's one instance where you might have to give the patient fluids to take out more. So essentially, that's something which you need to keep in the back of your mind. Now, as much as oral versus IV furosemide goes and bolus versus continuous dose of furosemide goes, clearly the dose AHF trial showed that there was no big difference in terms of composite endpoint, both with bolus or continuous infusion or with low dose or high dose strategy. So essentially, all these things are put to rest, at least from an evidence point of view. So at least from a clinical perspective, I find giving boluses much more safer than giving continuous infusions. Of course, in an ICU setting, you can always argue that you can monitor electrolytes and other things much more closely. But, again, it's personal preference here. I wouldn't say that in terms of outcomes, there is a big change between continuous and bolus IV doses. But one problem you usually face in this scenario is diuretic resistance. Sooner or later, you'd find that your patient is not responding to the same dose of furosemide. And, of course, there are many reasons that have been mentioned as causes of diuretic resistance in this setting. Now, to me, the more important fact here is, how do I recognize this diuretic resistance early? To identify diuretic resistance early, I introduce a concept called as diuretic efficiency. I mean, it's been well described. It's not that I introduce it, but for the sake of the audience, I'm telling you about diuretic efficiency. It focuses on quantifying the renal response, let's say to a fixed dose of diuretic. Now, this may be in terms of your or in terms of your urine sodium to urine fluid done, but you do have, what I'm trying to say here is, you still have methods of identifying diuretic resistance early. And in the patient who starts to develop diuretic resistance, the usual response from the physician side is either you increase the dose of diuretics or you start adding in a new diuretic, either a thiazide or some other diuretic, whereby you enhance the decongestion process. The principle of management, as I said, still remains the same. You try to decongest these patients. Now, is there any role for using agents that would increase renal blood flow? Clearly, a lot of interest was generated in the early 60s. Now, this is a paper I managed to pull out of internet, which was published in 1965. And one of the first line papers that showed that dopamine was an effective drug that would improve renal blood flow, and hence, dopamine can be used in such a setting. Clearly, these people who published this paper, they showed that in normals, the GFR and the effective renal plasma flow would improve after a dose of dopamine. But what was more important was, in patients with heart failure, the degree of rise wasn't that great. And clearly, there were other adverse effects. And subsequent papers which got published, including meta-analysis as well as a few randomized trials, they clearly showed that improving renal blood flow with just renal dose dopamine, as they used to call it, was not effective in terms of improving renal function or clinical outcomes. So goes on to say that there is no big role for improving renal blood flow in these settings, and the use of dopamine in such settings clearly doesn't have big time data or evidence to support such a claim. Now, there are other ways of modulating the kidneys. Mind you, I'm just talking about the acute side of things. A lot of this would come under the chronic side of management. Neurohumoral modulation, clearly in the setting of acute decompensated heart failure, has not shown any big change in hardcore renal endpoints in large randomized studies. You have the tolvaptan, the necitide, and the inotropes that can modulate, because one of the factors in the pathogenesis that we discussed was neurohumoral factors, so he can clearly modulate this aspect to improve the patient's condition. But clearly, if you go by evidence, not much evidence in this setting. Now, what happens when diuretic fails? Clearly, you resort to ultrafiltration. And clearly, there are a few trials that have looked at ultrafiltration as a modality in patients with acute decompensated heart failure. Except for one study, the UNLOAD study, which showed survival benefits. The other studies have essentially showed that using ultrafiltration essentially didn't affect outcomes in a big way. I mean, in fact, some of these studies, such as Avoid HF, did show that the serious adverse effects was more in the ultrafiltration arm. But clearly, in a patient who is getting anuric and at the same time not getting decongested, ultrafiltration still would remain an option to the intensivist, and they would want to use it if things are not working as expected. So let me come back to the management of this patient. So I've given you what are the management options available from an intensivist perspective in managing this patient. So how do you manage this patient? The problem with whatever I discussed so far is the fact that we think one size fits all. So for every patient, the general principles remain the same, but you'll have to tweak a few factors here and there using those principles to suit that particular patient's management. So that is where, you talk about individualized medicine in such context. And again, the fact that this arena has a lot of dogmas, less facts, makes it more difficult to judge certain things. So, for example, the classic example would be the use of creatinine as a marker here. We all know that it's a late marker and you have better biomarkers, but then when you don't have it at your disposal, you clearly are at a loss at better judgment. So essentially, you are driven by certain things that are being taught to you rather than what you see by the bedside. And the third point, again, with respect to the management of this patient is, so far I discussed only the renal biomarkers. I never discussed the cardiac biomarkers in this setting. And in fact, if you're talking about precision medicine in this context, we need to be talking about cardiorenal biomarkers in the management of cardiorenal syndrome. So a classic example would be the use of natriuretic peptides in worsening renal failure patients. I'm not going to the details of it, but I'm still telling you, when you combine natriuretic peptides, say, with a renal biomarker, we don't have research on it yet, but these are areas of future research that we should focus on so that you can individualize therapy better. So this gentleman, against all conventional thinking, if you thought inotropes were bad, I thought of starting him on an inodilator. So I started him on dopamine, started him on about 4 mics per kg, and essentially, I saw that diuresis improved. I could achieve my fluid balance of whatever I wanted to over the course of next 3 to 4 days. And I could also find out that the serum creatinine, which went up, started now settling down. Clearly, we went for salt and fluid restriction. I used intermittent boluses of furosemide. And as a yardstick of measurement of decongestion, I didn't have big-time markers, so I just looked at his daily hematocrit. And that was the only thing which was available to me by the bedside. So again, it was an indirect, probably a crude marker that my patient is, the decongestion is still working. Gladly, he never had to go to the cath lab, so he didn't need a contrast. But my backup plan was always there. If this patient were not to respond to diuretics, I would have my CRRT machine primed up and subject him to ultrafiltration. Now, the other factor which you need to think here is patients who have acute CRS are at risk of going into the chronic stage at some point. So you need to make sure that while you are treating these patients during the acute stage, you also need to think about how you prevent them from going into CRS or chronic CRS. And that's where, you need to look at what all can be given in a setting when they start improving. So use of, essentially mineralocorticoid receptor antagonists in this setting, along with ACE or ARB, might help delay CRS in this setting. But clearly, these are, again, not without its own set of side effects. You got to understand that when you add mineraloreceptor antagonists in the setting of renal failure, you're going to invite the wrath of potassium. So clearly, that's one aspect you need to think about. As I told you earlier, this patient is also a diabetic. And there is emerging evidence that in the context of diabetes, SGLT2 inhibitors clearly have shown evidence of improved outcomes, so renal outcomes as well as mortality. Clearly, there have been enough trials published from a cardiology perspective, which has looked at looked at various SGLT2 inhibitors, say empagliflozin, canagliflozin. All these drugs have been looked at And at least, CANA and DAPA, they've shown that these patients clearly have better renal outcomes. So in patients who have diabetes, this might be, this at least has been described as a future game changer when it comes to patients developing cardiorenal syndrome. Now, as I said, this is a vast topic, so I cannot discuss everything in detail. As the cardiorenal syndrome progresses, you have various other modalities that are available to stabilize the heart, while at the same time delaying the onset of cardiorenal syndrome. So clearly, it goes clearly up to kidney transplant, and each point I've highlighted here is a topic on its own for discussion. So you can have a separate talk on it. But the point I'm going to highlight next is another aspect which is least used, at least in an acute care setting. The point here is we think we are all gods, we can save everyone's lives, but we don't know when enough is enough. You got to understand that patients with chronic renal or cardiorenal syndrome, when they end up in the chronic stage of things, they become refractory to treatment. I think it's at least from an ICU perspective, we need to start thinking about how it becomes a burden for the family, how it becomes a healthcare burden, and essentially how it becomes a burden for the patient himself. And that's where one aspect which we need to think about in this setting is palliative care. A lot of these patients end up having depression, so you'd find that whatever you're trying to treat may not eventually get treated for other reasons, and it consumes a lot of resources. And that's where multidisciplinary approach becomes very important. So the nephrologist, the cardiologist, and the critical care physician needs to be on the same page when it comes to management of such patients. Very often, the hopes are different for different treating physicians. So that aspect of it needs to be balanced when it comes to management of cardiorenal syndrome. Of course, I did speak about the newer perspectives, the use of individualized approach, the newer biomarkers, which should include both cardiac and renal origin. And of course, newer trials and research should be focused on major adverse renal and cardiac events as a composite outcome. And unless and until we get more data on such events, it's going to be difficult to prognosticate these patients straight away when they land in your ICU. So as much as the take-home message for cardiorenal syndrome goes, clearly, the facts remain that major challenges in management of CRS would be identifying your diuretic resistance, which can hamper decongestion. Clearly, you need to use biomarkers of cardiorenal origin if you are looking at individualizing approach. Goal-directed medical therapy in chronic cardiorenal syndrome, it's still lacking. And of course, palliative care still remains an underused strategy in these patients who have both advanced heart failure and advanced kidney disease. And that's where, the importance of multidisciplinary approach in such patients becomes very important. Now, having said so much about cardiorenal syndrome, I think, Tapas and Gunadhar will not pardon me if I don't touch upon hepatorenal syndrome in this context. But what I'm going to do is I'm going to simplify hepatorenal syndrome into a few slides. I'll try to make comparisons with cardiorenal syndromes so that you understand it in the context of organ crosstalk and how much, or you can compare and contrast how liver failure in a setting can complicate things compared to cardiac failure. Now, you need to understand that hepatorenal syndrome is clearly, this aspect of the organ talk that we are talking about. It refers to those patients, or it refers to the clinical set of symptoms which patients with well-established liver cirrhosis and ascites develop. So they have progressive rise in serum creatinine, they have oliguria. Of course, some of these parameters, the lab parameters, may still not change drastically in the early settings. Again, if you look at some of the facts about hepatorenal syndrome, and again, I suggest you compare and contrast this with cardiorenal syndrome in this particular context. Clearly, patients with cirrhosis and ascites, the global incidence of HRS is about 20%, so 1/5 of these patients develop it. While those with end-stage renal disease, this rises drastically. It becomes twofold higher, and it's up to about 40%. Now, clearly, these patients stay longer in hospital, longer in ICU. Their mortality rate is quite high. The moment you say you have a patient with hepatorenal syndrome in your ICU, it itself portends a grim prognosis. And clearly, if you look at median survival in untreated HRS, it's hardly less than 2 weeks. And if you start treating these patients, they may still succumb at some point, sometimes even, up to, say, 3 to 6 months down the lane. So, again, and the other thing is, it usually presents very late. So, if you look at the age incidence, HRS appears in the 6th or the 7th decade. Now, there are established criteria for HRS. I'm not going into the details of it. What has happened in the last few years, of course, this is something that has been undergoing a lot of changes, the definition, the diagnostic criteria. We have moved away from type 1 and type 2 HRS, and we now have started calling it HRS AKI and HRS CKD. The same old wine in new bottle. Okay, so nothing different. It's the same thing, but we've named it differently now. Again, pathophysiology is complex. I like to keep this simple. Just as with cardiorenal syndrome, you have a hemodynamic crosstalk, you have inflammatory markers, and you have neurohumoral markers. As simple as that. Clearly, at the end of the day, when you have a sick patient, clearly, if you look into the pathophysiology, these 3 factors will always play a major role. Now, when it comes to management, of course, unlike cardiorenal syndrome where we had various subtypes and the various modalities of treatment, the management of HRS is more or less straightforward. When I say straightforward, it's still tough by the bedside when you know that the prognosis is grim. Of all the things that you tend to do, and I am still comparing this with cardiorenal syndrome, you would find that HRS is treated with vasoconstrictors when we want to, compare and contrast this with inotropes, which we want to avoid in cardiorenal syndrome as much as possible because of higher mortality. So treatment, the mainstay of treatment in HRS is going to be a vasoconstrictor. The second thing that also need to know about in this setting is a major part in chronic HRS when you manage these patients. An ideal way of looking at whether you have ruled out other causes of AKI in your patient who is otherwise suspected to have HRS, and if your diagnosis is certain that this is HRS, then you look at whether you can improve it with a vasoconstrictor. So if you're going to improve it with a vasoconstrictor. So if you're going to use a vasoconstrictor, and the second common drug that's used in this setting is norepinephrine, again plus minus epinephrine, again plus minus albumin. Clearly the use of albumin in this setting has been shown to enhance outcomes. So again, it forms the mainstay of therapy. Second line drug usually is something like midodrine or octreotide as to whether he or she would be a candidate for transplant. Now, if your patient has contraindications to vasoconstrict, at whether you manage the renal failure first, with renal replacement therapy, see if you can subject the patient to MAS if it is available. Our results with MAS have actually, none of the patients whom we have offered MAS have survived. Probably it's a question of experience with MAS, or it's a question of timing of MAS. But clearly, we find that at least MAS in this setting might be useful, but at least our learning curve is probably not up to the mark. Having said that, even if you go through that pathway, you'll still have to evaluate these patients eventually for transplant. So in an acute setting, clearly, your mainstay of therapy would be vasoconstrictors. Big onus should be placed on prevention of hepatorenal syndrome because that is what is going to be easier in these patients. So in a patient with otherwise risk factors for HRS, avoidance of renal toxic drugs or renal toxic drugs, and the use of antibiotic prophylaxis for spontaneous bacterial peritonitis becomes important during an ICU admission. Clearly, a lot of these patients develop refractory ascites. They are refractory to diuretics, to resort to paracentesis in such a setting. Again, in this setting, you would replace albumin. So again, another a big difference between decongestion in cardiorenal syndrome and fluid therapy in hepatorenal syndrome. And of course, TIPS has been tried in such settings to prevent progression. But all said and done, clearly this group of patients have a grim prognosis, and definitive treatment would eventually amount to, say, transplant of either the liver or simultaneously liver and kidney. The reality is, even though whatever I spoke just now is familiar to all of you, this treatment strategy has not undergone any big changes in the last 15 years. So we've been mostly following some of these protocols.
Great talk, of course. Only you could lose us to these two big topics in such a short time. But first of all, I want to comment that with acute cardiorenal syndrome, at least some of them, so we're likely to see a lot more of those with the increasing number of heart failure and cardiac shocks that will happen at the ICUs here. And one of the strategies that needs to be considered early on is basic hemodynamic monitoring. Because I think a lot of them, if you just check blood pressure, that may not give you the full picture. You, of course, besides the echo and looking at the right heart function, consider going for DRG catheter replacement early on, especially if indicated, monitor the cardiac outputs in vascular resistance. And with the use of inotropes, I think, yes, inotrope usage is associated with higher mortality, but that is probably just a reflection of the advanced disease process. And if these patients are put on inotrope and some of them recover, then that's a success. It's the data regarding the use of inotrope is most of it is retrospective, and just yes, it just confirms that the underlying heart disease is severe, and even though you use inotrope, the patient still lives.
Thanks. And I'm aware of a lot of institutions and centers that use PA catheter to assess volume status in such a scenario. But if you look at results of some of the major trials, I think it was the Rose AHF, clearly, they used a PA catheter-based therapy to guide their diuretic therapy. They never showed any improvement in renal outcomes eventually, and they were quite skeptical about it. But I agree that having some yardstick than nothing would be far better in an ICU setting, and clearly PA catheter might work in such a setting. Right, no more questions. Thank you.
Thank you, Dr. Ramanathan. Moving on to our next speaker for the day, I would like to invite Dr. K. Subba Reddy, MD, PDCC, IDCCM, EDIC, Senior Consultant, Head Critical Care Medicine, Apollo Health City, Hyderabad. He is also the ex-chairman, Apollo Hyderabad. He is also the medical director, Opocos Rehabilitation, chairman for Indian Association of Parental and Enteral Nutrition. He is the faculty for DNB Super Speciality and Fellowship in Critical Care Medicine for the past 10 years. He is also the awardee for Young Clinician Awards in Apollo Group, Leadership Award and Best Branch Award for Indian Society of Critical Care Medicine 4 times during his tenure as chairperson. His area of interest is neurocritical care, ECMO, and critical care nutrition. He is here to give you all an insight about when to start and when to stop renal replacement therapy, fixed versus customized approach. We welcome you, sir.
My slide. Good morning, all. Small correction. I'm not the ex-chairman of Apollo Hospitals. I'm the ex-chairman of ICSM Hyderabad. Sorry. So thanks for that introduction. I'll be talking about basically when to initiate RRT and
This is the slide.
yeah.
Next slide.
Yeah. When to initiate RRT, when to stop RRT. And first let me thank Dr. Gunadhar Padi, Dr. Tapas Sahu, and the Apollo Hospitals and entire team of Nephro Critical Care team for giving me this opportunity. When Dr. Gunadhar Padi called me and said you have to talk about when to initiate RRT and when to stop RRT, first part is easy, but the second part is difficult. When to stop RRT, we don't know. And then if you look at the evidence is also not great. So that is a little difficult, but the first part is easy, and then you might have heard many times in the critical care conferences. So when to initiate RRT, and then we have a tetrad of trials which are which all of us know, and then I'm going to review these trials, the 4-5 trials about initiation of renal replacement therapy. Then we will go to the stopping RRT, when to stop. So acute kidney injury is very common in our ICUs, and then we see more than the incidence is 50 to 70% depending on the kind of ICU you are working. And the renal replacement therapy is also quite common when they develop acute kidney injury, when they don't recover. And as a organ support, advanced organ support, we use renal replacement therapy. And then all of us know the clear indications, but you wait till you get the clear indication, or if you start renal replacement therapy little early, do you see any benefit in terms of mortality, in terms of renal recovery, in terms of ICU length of stay? So we will go through this. And if you see the common indications, so whenever there is refractory metabolic acidosis, severe hyperkalemia, which is refractory to your medical treatment, and then there is pulmonary edema, and then the oxygenation is an issue. When the patient is having fluid overload, we know that we need to dialyze, we need to go for renal replacement therapy. But the optimal timing when to go for renal replacement therapy, but the optimal timing when to RRT, when to initiate RRT, is still under debate, and then there is no consensus guidelines about when to stop RRT. So if you look at the landmark trials from 2006, the first trial, the Bowman et al. Trial, so they divided into two groups. One is whenever there is a clear-cut indication, that is late, till that indication you are waiting, that is late RRT. And early RRT they have taken when the creatinine clearance less than 1 per minute and less than 12 hours after onset of oliguria. Two groups they have taken, and then they have not seen any difference in the mortality. Then another study came in 2013. Again, in this study also, they have not seen any benefit of early RRT. There was no difference in the mortality when you start early versus late renal replacement therapy. And the Elaine trial came in 2016, and this is a positive trial. It showed all like a very good trial, and then it showed a lot of benefits if you go for early renal replacement therapy, mortality benefit, and then renal recovery is good, all positives, and then it is a positive trial. And after Elaine trial, they decided to do some more trials, why this is contrary to the previous trials. And then we got this Akiki trial in 2018, and then the Ideal ICU trial, and then the most recent one is the START AKI trial, and Akiki 2 trial came. And in rest of the trials, again, they did not find any difference in the mortality in the subsequent trials. So first I'm going to discuss about START AKI trial, because this was published in NEGM, and then this is a very good study, the most recent study, and they have taken nearly 3,000 patients, and they have done in 15 countries. This is a multinational randomized controlled trial. The UK critical care group, Canadian critical care group, Australia, New Zealand critical care group, and then Irish critical care group, all of them participated. If you look at previous trials, they have done mostly in Europe, and some trials like Alien trial, they have done only in one center in Germany. Other 2 trials are French trials. So this trial, they have included 15 countries, and then around 168 hospitals, and then like you got the data from different countries. So this is a better trial when compared to the previous trial. They have taken patients with kidney dysfunction with a serum creatinine 1.13 milligrams per deciliter in women, and in men more than 1.47 in men. And then basically they have included KDIGO stage 2 and stage 3 patients requiring renal replacement therapy. Is there any benefit? So they have excluded patients who are already on dialysis, and then previously these patients are on renal replacement therapy, and other causes of AKI like rhabdomyolysis, and then any toxins. If you are dialyzing, they excluded that patient. And they divided basically into 2 groups. They have taken patients and divided into accelerated group and then the standard care. In the accelerated group, they started within 12 hours of going into when the patient goes into KDIGO stage 2 or 3, within 12 hours they initiated renal replacement therapy. In the standard group, this is your common indications in ICU. When the potassium is more than 6, when the pH is less than 7.2, when the patient is having metabolic acidosis, when the bicarbs are 12 millimoles, whenever there is metabolic acidosis, whenever there is severe respiratory failure, P/F ratio less than 200, and then whenever you feel there is a clinical perception of the volume overload, and the patient is in AKI up to 72 hours of KDIGO stage 3, then you go for renal replacement therapy. These are all our standard indications. So this is the standard strategy. And then the primary outcome, they have seen death, mortality at 90 days. And secondary, they have seen how many patients were dependent on renal replacement therapy. Most of the time you might have seen in ICU. If you don't put my patient on dialysis, because if you start, then they are RRT dependent, so the attendants will not give consent. So actually, what is the dependence of RRT in both the groups at 90 days, and what are the major adverse events they have seen? Death or major events they found, like hypotension and other line-related infections and all, and death, basically the death. So, and they have seen again death in the ICU or during hospitalization, and number of days they were RRT free, how many days they were not requiring RRT, and number of ventilator and vasopressor free days. So these patients, they've taken patients with septic shock in the medical ICUs who are on vasopressors, and length of hospitalization and at 90 days, and then the quality of life. They have taken all these parameters in this study. As I told, each group, they recruited around 400 patients in each group. And then if you look at the baseline characteristics, and they're similar, there's no difference between these 2 groups. And they have taken variety of patients on cardiopulmonary bypass, like cardiac surgery patient, aortic aneurysm surgery patients, and then patients with major trauma, obstetric complications who develop acute kidney injury, and patients who are on like a polytrauma patient, even traumatic brain injury patients they've included. They've included patients with sepsis, septic shock, and then the patients who developed AKI because of amphotericin B or because of aminoglycosides. They've taken variety of patients, and then SOFA scores and Apache scores were almost similar in both the groups. If you look at accelerated group, around they started RRT within 6 hours, around 6 hours. 6 hours. In the standard group, they started around at around 31 hours. And And if you look at the outcomes, there was no difference in the mortality at 90-day mortality, and there was no difference in the ICU length of stay or the hospital stay in both the groups, whether you are in accelerated strategy or whether you go for standard strategy for starting renal replacement therapy. And then if you look at the RRT dependence, there is no difference in the RRT dependence again. But if you look at complications, they have seen more hypotension and line-related infections were little high, but hypotension episodes were more in the accelerated group. We know when you start RRT, the patients will develop hypotension. Most, like a lot of people got dialyzed, got renal replacement therapy in the accelerated group, so they developed hypotension in the accelerated group. But there is no difference in the RRT free days or no difference in the mortality. And if you see, there's a lot of heterogeneity. All these patients did not receive only one type of renal replacement like CRRT. Some people received CRRT, and that number is same in both the groups. And some people received intermittent hemodialysis, some stable patients. Some people received SLED when there is no CRRT. So there is a lot of heterogeneity in all these trials with AKI. And as I told again, there is no difference in the post ICU quality of in the survivors, and then there is no difference in the mobility, self-care. All are similar in both the groups. And then if you look at this Kaplan-Meier curve, definitely there is no difference in the mortality whether you go for early RRT or late RRT. When they did subgroup analysis in some patients like surgical patients and all, they found little benefit when they go for early RRT than late RRT, which we have seen in Align trial also. And then sometimes we are worried about arrhythmias. When the patient develops metabolic acidosis, when the potassium is high, if you are not dialyzing, if you are waiting till the patient develops metabolic acidosis, we all are worried about arrhythmias. But in this trial, they did not find any difference between whether you go for accelerated approach, early RRT or late RRT. We think if you dialyze, that is what we tell the nephrology team. So you you do go for renal replacement therapy so that we can avoid electrolyte imbalance, acidosis, so that they will not develop arrhythmia, but there's no difference in both the groups. And other complications are similar except hypotension, which we have seen more. So to conclude, accelerated strategy for initiation of RRT did not decrease the risk of death at 90 days. And they have taken, this is a very good study, this is a large study, they have taken nearly 3,000 patients and then they randomized. The sample size is very good, and then they recruited patients from several countries, several ICUs. And if you look at the limitations, there is a lot of heterogeneity in the trial. Type of RRT, type of patients, and then lot of heterogeneity. And then again, the initiation of renal replacement therapy in standard group is basically it was dependent on the clinician. So if somebody is managing potassium 6 medically, they were not recruiting into RRT. There were no strict guidelines. So when to recruit in the standard group. So that is one limitation. But 60% of the people got dialysis in the standard group. Coming to the next positive trial, that is Align trial. This is a single center trial, the German trial. And they have taken mainly post-surgical patients, and then they have seen, they recruited into two groups. One is early group. They started RRT within 8 hours of KDIGO stage 3. So stage 2 or 3, that is the early group. And then in another group, the late group, they have taken 12 hours. There is no much difference, 8 hours and 12 hours. And then they found a mortality difference when they go for early RRT. Basically, most of the patients were surgical ICU patients. And they have taken patients with KDIGO stage 2 and stage 3. And then they were using biomarker NGAL. If the NGAL was hugely positive, if it is high, if it is more than 150 nanograms per ml, then they have recruited these patients into the renal replacement therapy. And 80% of the patients were surgical patients. Out of 80%, 47% of the people, they underwent cardiac surgery. We know after cardiac surgery, AKI is very common. And then they found mortality difference, and then they found secondary outcomes like RRT, like in the early group. So if you look at the early group, there were only less number of patients were on RRT. In the delayed group, more number of patients were on RRT. And then renal functions. In early group, the renal recovery was better. So this is a positive trial. They found everything positive. Renal recovery is better, mortality is better, and then hospital length of stay is also less when they go for early RRT. But this is not translated when in the subsequent trials. So this is Akiki trial, and again this is that was German trial. This is a French trial. They have done in 31 intensive care units. It's a multi-center prospective trial, and then they randomized it into two groups. The first group is early strategy, that is within 6 hours, and the second one is late strategy. So patients who are really having dialysis indications. So they have done into two groups, and they did not find any mortality benefit. Then the ideal ICU trial. In the ideal ICU trial, they've recruited patients from the medical ICUs with a septic shock, and then people were on mechanical ventilation, people were on vasopressors, and they have taken in this trial. And then the early is within 12 hours. Late is when the patient is requiring, they went for RRT after 48 hours. And again, there is no difference in the mortality, whether you do within 12 hours or you wait more than 48 hours. There is no difference in RRT free days. There is no difference in mechanical ventilation free days. Or there is no difference in the ventilator vasopressor free days. So absolutely there is no difference in both the groups. Then they have done this Akiki 2 trial. This is the latest trial. So they divided into delayed group and then the very delayed group, more delayed group. So you wait till you get the classical indication, refractory hyperkalemia, refractory metabolic acidosis, and the other one is the delayed group. Because in all other trials, the late initiation of RRT indications they have taken in the delayed group. That is blood urea more than 112 and Kidigo stage 3 more than 72 hours. They waited till that time, and then they started RRT. That they considered it as delayed group, and very late, more delayed is when till they develop complications like refractory metabolic acidosis. And again, they found mortality difference. If you go for more delayed approach, then the mortality will increase, and then the secondary outcomes, like the patient's RRT dependence is also more if you delay till the patient develops complication. So you should go for late initiation, but not very late till the patient develops complications. So they have seen the meta-analysis of all these randomized controlled trials. In the meta-analysis, they found early initiation of renal replacement therapy was not associated with the survival benefit. And early initiation of renal replacement therapy could lead to unnecessary RRT exposure. You are exposing the patients for RRT, and because of RRT, they are developing hypotension, they are developing line-related complication. If you look at the ELAINE trial, the CLABSI rates, central line infection rates, were very high in the early group. So you are seeing all the complications, and then the cost effectiveness, and then these people will stay in their ICU for a long time. So early initiation of RRT is not beneficial in these patients. This was published in the Critical Care Journal 2021. So we know now when to start RRT. So now we are going towards when to stop renal replacement therapy. So we are good in weaning the patients from mechanical ventilation, but we are not wise enough to wean the patients from RRT. Because we don't have much evidence, we don't have consensus guidelines when to stop renal replacement therapy. Most of it is a clinician dependent, but there are few studies, one or two randomized controlled trials. We will go through that. So there is no large data. Kidigo has given clinical practice guidelines in 2012 when to stop RRT, when it is no longer required. We all know when it is not required. When the patient recovered from the intrinsic kidney disease, and when the patient is not in the volume overload or solute overload, we stop RRT. This is again expert evidence, expert opinion, but that time there was no evidence. This I got it from dialysis seminars, which was published in Willy. And then currently the decision to stop the RRT is based on the hemodynamic stability and fluid balance. Patient is not volume overloaded, and whenever there is electrolyte disturbance is not there, and whenever sometimes logistic problems, staff is not there, and then the catheter is blocked, or your filter is blocked, then you stop RRT and see whether the patient is improving or not. So because of the logistical issues, sometimes we stop and see when the patient is recovering. So there are two approaches: wait and see. Sometimes we wait and see whenever there's a logistical approach, or we go for fast track. We will not stop the RRT. So this is one meta-analysis. This is called done RRT. So we are done with RRT, done RRT, determining the optimal time for the liberation from the renal replacement therapy in a critically ill patient. They have taken 23 trials. In these 23 trials, there are only 3 randomized controlled trials. Other trials are observational studies. They have taken different variables, not clinician dependent. They have taken a lot of variables. So 16 variables for predicting RRT weaning. So they have taken conventional biochemical criteria. They have taken kidney biomarkers. They have taken physiologic criteria. They have taken multivariate models, and urine output was most commonly used. So we all use urine output, right? When the urine output is more than 1000 ml per day, then we'll take a chance. We'll stop RRT and see whether the patient will recover, right? So in the biochemical criteria, they have taken serum creatinine, they have taken 2-hour creatinine clearance, they have taken residual creatinine clearance, they have taken kinetic EGFR, not EGFR, kinetic EGFR. How many of you know kinetic EGFR? You take 2, because if you take the creatinine, it is 0.6, but next 6 hours there is no urine output. That means GFR is 0, but still if you calculate GFR, it is normal. So if you take kinetic GFR, if you take like first hour creatinine, and after 2 hours you take the creatinine and calculate the GFR, that is the kinetic GFR. And based on the kinetic GFR, there are some models to wean the patients from renal replacement therapy. And 24 hours urine creatinine, urinary urea, and daily urinary urea excretion, they have taken these parameters. And they have taken biomarkers like cystatin C, we do in most of the hospitals. Yeah, I finished. And the 3 slides. NT-proBNP, NGAL, IL-18, IL-6 we do. And then serum osteopontin they have taken. And then they have taken urine output criteria before RRT discontinuation. After stopping RRT, what is the urine output? But when you take the urine output, there is a lot of heterogeneity. They have different studies. They have taken a wide range of urine output, 191 ml in 24 hours to 1720 ml, and in different studies. And then the sensitivity of this urine output, if you take urine output to stop RRT, it is only 66%. And then in the multivariate models, they have taken NT-proBNP, Apache 2, urine output, creatinine, multiple models they have taken to stop RRT. Not one single parameter will determine when to stop renal replacement therapy. In the last one, if you see, they have taken urine output on day 0, and then kinetic EGFR next day, and you see whether you can stop. I will go through that study. So there are 2-3 studies about the urine output. In some studies, they have found urine output is a good predictor to stop RRT. In some studies, they have not found that it is a very, very good indicator to stop RRT, to discontinue RRT. So currently there is insufficient data about the urine output. How much urine output you can stop RRTs? Still there is insufficient data, but there are a lot of studies ranging from 191 ml to 1700 ml. So biomarkers we can use to discontinue RRT, and in this is a very good study, kinetic EGFR as a predictor for the successful continuous renal replacement therapy for the discontinuation. If somebody is on CRRT, you can use kinetic EGFR and then the urine output, and then you can, based on the kinetic EGFR and the urine output, if the GFR is improving, if it is more than 20 ml per minute, then you can stop RRT in these patients. So this is a very good algorithm. This is my last slide. This is a very good algorithm when to stop RRT when you initiate. When the patient is stable with acute kidney injury, stable hemodynamics, respiratory function is stable, the patient is not volume overloaded, and no impending renal insult. So there is no aminoglycosides going on, or you are not giving more contrast to the patient. When the urine output without diuretics, if the patient is getting 400 to 1000 ml in 24 hours, Or if you are giving diuretic challenge, if they're producing more than 2000 ml in 24 hours, and these patients, you can give a trial of RRT weaning. And if you are calculating creatinine clearance, if it is 20 ml per minute, then you can stop RRT. If it is between 12 to 20 ml, then it depends on the clinician, nephrologist, and intensivist decision to stop RRT. So this we can use for the weaning attempt of RRT. This table we can use. So to conclude, early initiation of RRT was not associated with survival benefit. So you can wait up to blood urea nitrogen around 112, KDIGO stage 2 or 3 more than 72 hours to initiate your RRT. That is the late strategy to initiate RRT. In addition, early initiation of renal replacement therapy could lead to unnecessary renal replacement therapy exposure in some patients, resulting in, so if you give unnecessary RRT, then the ICU length of stay will increase, cost will increase, infections will increase, and the renal recovery also will be delayed. These patients will not recover fast from the, like if you continue RRT, renal recovery will be delayed. So in a critically ill patient, with a clear and hard indication such as severe acidosis, pulmonary edema, hyperkalemia could benefit from early RRT, otherwise we can wait. So when you are doing acute RRT mode, you should have the RRT daily goal and start RRT when there is maximum benefit to the patient. And exact timing of RRT still we don't know, but as of now, based on all these trials, we can go for late initiation of RRT, but not more delayed approach. So you need a teamwork, you need to discuss with the nephrologist, with your nephrologist and with your other colleagues, and then you should go for RRT. So when to discontinue, we have seen the algorithm when to discontinue. You can take, but if you take multivariate models, if you take all the parameters into consideration, then you are successful when you are in weaning the patients from RRT. Thank you. Any questions? Okay, thank you.
Thank you, Dr. Suba. That was an insightful lecture. Coming up next is Dr. Divya Kukian, MD Internal Medicine, IDCCM. She's also done her diploma in intensive care from Netherlands. She's a consultant critical care at Apollo Hospitals, Navi, Mumbai. Her area of interest is ECMO and IBP. Today she'll talk about the acid-base abnormalities due to renal failure. Over to you.
Good morning, everyone. I would like to thank Dr. Tapas and Dr. Ganadha for giving me this opportunity. I will be speaking about acid-base disturbances in renal failure. So acid-base disorders in renal failure. So acid-base balance in our body, we know it has been maintained by the renal excretion of daily acid load. So this daily acid load that is there, that is almost 1 milliequivalent per kg body weight per day. This comes mostly from the generation of sulfuric acid when there is a metabolism of sulfur-containing amino acids. So this acid load, normal kidneys are able to increase the net acid excretion in response to the acid load. So that means the excretion of hydrogen ions along with the generation of bicarb will help correct this serum bicarb to a normal range. But whenever there is an increase in the serum bicarb, if the kidneys are normal, the increase in renal excretion of bicarb will also be increased and it will be maintained. So this renal regulation of pH, so coming to a normal regulation of pH, how do the kidneys help in maintaining pH? So there are 4 main mechanisms in this. One is the excretion of hydrogen ions. So what happens is the kidney is the main route by which the hydrogen ions are excreted from the body. So this excretion happens in the proximal convoluted tubules, and hydrogen ion excretion is always coupled with the bicarb regeneration. So the main enzyme, the carbonic anhydrase enzyme, this generates carbonic acid from water and carbon dioxide in the renal tubular cells. So this carbonic acid which is generated in the renal tubular cells, that dissociates to form hydrogen and bicarb. So this hydrogen ion then gets secreted into the tubular lumen in exchange of sodium. Sodium enters the tubular cell and hydrogen exits it. So the bicarb that is there, that is reabsorbed into the circulation. So this is an effective mechanism to eliminate acids from the body. Simultaneously, there is a generation of bicarb. Sorry about that.
हेच आहे ना
हे सर
हो झालं हे बघा हे बटनने करा
ठीक आहे. I'm sorry about that. So the second mechanism is a reabsorption of bicarb. So this reabsorption of bicarb, this obviously is coupled with the same hydrogen ion excretion. So what happens is the bicarb usually freely diffuses from the plasma into the tubular lumen. There it combines with your hydrogen ion and it forms the same carbonic acid. This carbonic acid gets cleaved into a carbon dioxide and water. The carbon dioxide diffuses out of the cell into the tubular lumen, and as the carbon dioxide concentration starts increasing within the tubular lumen, it is transferred back into the cell, combines with water to form carbonic acid again, which dissociates again to form hydrogen and bicarb. So again the hydrogen ions are secreted into the lumen in exchange of sodium, and the bicarb is reabsorbed into the blood. So this continuous regeneration of bicarb, this maintains a steady state continuously in exchange of sodium. This is a cyclic process and it helps to maintain a steady state. It will not be effective for elimination of any new hydrogen ion generation or excretion of any new bicarb. So the third method, this is the excretion of titratable acid. So what do you mean by titratable acid? Is the measure of acid which is actually excreted into the urine by the kidney. So this is in total, it is the total quantity of sodium hydroxide which you need to titrate 1 liter of urine to a pH of 7.4. So this reflects the total hydrogen ion that is excreted into the urine. So we'll see how that happens. So when I told you that hydrogen gets exchanged for sodium, so where does this sodium come from? The sodium is there in the tubular lumen in the form of sodium disodium hydrogen phosphate. So that sodium you take into the cell and the hydrogen comes out of the cell, right? So then the hydrogen combines with this is the main base in the tubular lumen, the hydrogen, sodium dihydrogen phosphate. So hydrogen combines with this to form sodium dihydrogen phosphate, and that is the main base which gets excreted. So as the tubular fluid moves down the tubules, as the urine moves down the tubules, more and more hydrogen ions get added to this, and that is how the urine is acidified. So this causes a fall in the pH of urine as low as 4.5. The fourth mechanism is by the excretion of ammonium ions. So what happens is the tubular cell, glutamine gets deaminated to glutamate and ammonia. The NH3 ammonia freely diffuses out of the cell into the tubular lumen. There it binds with hydrogen and it forms ammonium. This ammonium is not able to diffuse back into the tubular cell. So ammonium excretion helps to remove the hydrogen ions. So these are the four mechanisms by which the kidney is able to maintain the hydrogen ion excretion and to maintain a pH. So this is what happens in a normal kidney. So now what happens when there is an acute kidney injury? Acute kidney injury, you know, the GFR starts dropping, and that is a major reason for the metabolic acidosis. So as the GFR drops, there's a decreasing capacity to excrete these fixed acids. There's a tubular metabolic acidosis. There is a respiratory compensation with a drop in PCO2. Initially, this acidosis is hyperchloremic. The anion gap is normal. Eventually, the anion gap starts getting widened when there is an accumulation of phosphate, small organic anions start happening in the blood. So why this metabolic acidosis is bad? Why do we want to correct it? So at a pH of less than 7.1, acidosis is known to cause hemodynamic instability because of a left ventricular contractility problems, arrhythmias, arterial vasodilatation, also an impaired responsiveness to vasopressors. But is this always true? Sometimes when there is a diabetic ketoacidosis and your pH drops very acutely, you don't get myocardial depression. But if you give a lot of bicarb to try to correct the acidosis, sometimes giving bicarb can also have a secondary effect on the pH. It can cause secondary myocardial depression also. So how do you treat this? Obviously, first thing you have to do is you have to treat the cause of the acute kidney injury. You have to treat the cause of the acidosis. Dialysis has to be initiated if there is severe acidosis, pH less than 7.1, and there is volume overload. You can consider giving bicarb for a severe acidosis if there are no other indications for your dialysis. If there is no fluid overload, if the patient is non-oliguric, you can consider giving bicarb. Diuretics can be given in non-oliguric patients to enhance the acid excretion also. So if you consider giving bicarb to a patient, what is your target? How much bicarb you should use? When should you not use? So the goal is obviously to have a pH of more than 7.2 and a bicarb of more than 16. What are the issues with giving sodium bicarbonate is, first of all, you're giving a lot of sodium load. You're causing a volume overload. Soda bicarb can also increase the carbon dioxide levels in case there is a ventilatory failure. So a lot of things to consider when you're giving a soda bicarb. Still, if you have to correct the acidosis with soda bicarb, how much should you give? So there is a formula to correct the bicarb deficit. So that involves the bicarb space and the bicarb deficit per liter. So calculating this bicarb space, because bicarbonate diffuses into the extracellular space, it is freely diffusible. So if you think, if your metabolic acidosis is moderate, if the bicarb is moderately less, empirically you can think that the bicarb space will be 55% of the lean body weight. But this is very difficult to calculate, obviously. So what we do is we give empiric bicarb. So empirically, if you give 100 ml over 1 to 2 minutes, you recheck your pH and your serum bicarb. If your bicarb does not increase by around 2 to 3 MEq per liter, you can give another 2 ampules. The idea is to correct 50% of the deficit in 24 hours. But we know that this always doesn't happen like that. If you give a certain amount, you cannot exactly estimate how much your bicarb is going to rise, because ultimately it depends on what is your production. So slowing down the rate of acid production, correcting the cause of metabolic acidosis is very important. Oral soda bicarb also you can use if the acidosis is very mild. The bicarb levels are more than 18 MEQs per liter. So this trial, the BICAR ICU trial, in which they studied severe metabolic acidosis in critically ill patients in the ICU. So what they did was they gave soda bicarb 4.2%. They gave it in infusions of 150 or 250 ml. Maximum they used was 1000 ml in a day. With that, they looked for their primary composite outcome was mortality at 28 days and organ dysfunction at 7 days. So what they saw in this trial was there was no reduced mortality in 28 days in the patients after giving soda bicarb, except in a subset of patients who had acute kidney injury. Otherwise, there was no benefit of giving bicarb. So the other acid-base disturbance that can occur is metabolic alkalosis. When can you get metabolic alkalosis? When there's severe vomiting or a lot of nasogastric tube aspiration. So these patients are hypovolemic and they need to be treated with crystalloids. So coming to chronic kidney disease as the number of nephrons start declining as the CKD progresses. What happens is initially there's a compensation. The amount of ammonium that is excreted per nephron starts increasing, but eventually that compensation begins to fail when the GFR goes below 40 to 50 ml per minute. So that is when the acidosis happens. The other issue is the diminished excretion of titratable acid. Like phosphoric acid excretion also diminishes as the CKD worsens. Also these patients are on phosphate restricted diets, they are on oral phosphate binders. The retained acid which is there, that starts getting buffered by the bicarb in the extracellular fluid, tissue buffers, bone buffers, which are responsible for most of the consequences. A superimposed metabolic alkalosis also you might see if there is vomiting, if there are diuretic therapy that can normalize the bicarb, but the anion gap in this case will still be elevated. Also post-transplant recipient patients also we see a metabolic acidosis that could be due to renal tubular acidosis because of drugs like cyclosporin, tacrolimus, hyperkalemia, hypercalcemia, disordered citrate metabolism or other tubular dysfunctions. So even before, when we say metabolic acidosis, we say that the bicarb level should be less than 22. But in CKD, the acidosis progresses in such a way that the proton accumulation starts even before the bicarb starts dropping. So that is known as bicarbotenic acidosis. So you have a normal pH, you have a normal bicarb, and still there is proton accumulation. With progression, the pH and bicarb both drop. So the risk of organ dysfunction, the outcomes are directly related to the severity of acidosis in CKD. So what are the consequences of having metabolic acidosis? Bone resorption, there's osteopenia, muscle catabolism is more, secondary hyperparathyroidism and its consequences. The respiratory reserve is less, there is more intercurrent illnesses. The sodium-potassium ATPase in the myocardial cells is affected. The myocardial contractility is less. There's heart failure. There's resistance to growth hormone, insulin, hypertriglyceridemia, systemic inflammation, cognitive defects. So metabolic acidosis in CKD, it has been associated with poor mortality, higher mortality rates. Also, there are various trials that have shown an effect on cardiac outcomes, like the SPRINT trial, systolic blood pressure reduction interventional trial. A serum bicarbonate level of less than 22 was associated with a 54% higher relative risk of having a composite cardiac outcome, that is acute coronary syndrome, stroke, heart failures, cardiovascular death. There's also a higher rate of progressive kidney injury, progressive worsening of CKD that is there with metabolic acidosis. That is because of an increase in ammonium excretion, because of activation of the complement system, renin-angiotensin system, production of endothelin-1, which progressively causes tubulointerstitial inflammation and chronic damage. So obviously we need to treat this metabolic acidosis. So oral bicarb supplementation at 600 milligram TDS in CKD stage 4 has got a lower risk of ESRD, a lower mortality, lower rate of decline in creatinine clearance. Correction of acidosis also improves the metabolic bone disease. Uremic acidosis, as you know, it causes a skeletal muscle breakdown, muscle wasting. So bicarb therapy also improves the dietary protein intake. It decreases the catabolism with increase in serum albumin and lean body mass. Also in children with CKD, alkali therapy is beneficial to prevent the impairment in growth. So this is a summary of some recent interventional trials of using soda bicarb in CKD. The first trial that you can see, the use of bicarb in CKD, this trial actually showed a benefit. It showed a lower risk of creatinine doubling, reduced risk of needing renal replacement therapy, reduced mortality. The bicarb trial assessed basically the physical impairments with treating metabolic acidosis. It did not show any benefit in the physical symptoms. Alkali therapy in CKD did not show any effect on bone mineral density with correction of acidosis. The VA bicarb trial did not have, it studied diabetic patients with CKD who had a normal bicarb levels. The trial was done for 6 months, but it did not show any improvement in the urinary markers of kidney injury. The base pilot trial also, they evaluated whether there is a slowing in the progression of CKD and what is the dose of bicarb that needs to be given. They studied 2 groups with higher bicarb and lower bicarb, but there was no effect seen on blood pressure, weight, or even the GFR in both the groups. So this is another molecule, Beverimer, a novel non-absorbed polymer that selectively binds and eliminates hydrochloric acid from the GIT. So in a group of 135 patients with an eGFR of 35 ml per minute per meter square, serum bicarb of 17, they had given a range of doses of Beverimer and then studied the bicarb increase. Long-term follow-up, 63% patients had an increase in bicarb of more than 4. Secondary analysis, fewer patients progressed to ESRD or died. So we saw the renal origin high anion gap acidosis, that is uremic acidosis, where the GFR starts dropping. The other group of acidosis you see in renal patients is a normal anion gap acidosis, when the GFR is maintained. So what is this? This is renal tubular acidosis, a normal anion gap acidosis which happens because of the defects in the ability of the tubules to maintain an acid-base balance. There are 4 types: distal, proximal, hyperkalemic, and mixed. So distal, which is also known as the classical form, this happens because of the defect in the distal tubule to acidify the urine. There is a damage to the alpha intercalated cells, and so no new generation of bicarb happens. There is no hydrogen ion exchange happening. So the pH of the urine gets raised. Urine pH is more than 5.5. Hypokalemia occurs because of a failure of the hydrogen potassium ATPase. So there is normal anion gap with raised urine pH and hypokalemia. The leak of protons from tubule happens back into the lumen. Sodium reabsorption is also low. So this happens mostly with autoimmune disorders, hypercalciuria, drugs, hypergamma-globulinemic states. So you have patients present with growth failure, nephrocalcinosis, hypercalciuria. The proximal type is because of an impaired bicarb resorption in the proximal tubule, because of which excess bicarb leaks into the urine. Hypokalemia happens because of an osmotic diuresis. Because bicarb resorption is not there, there is an increased flow of urine to the distal tubule, so there is more potassium excretion along with the bicarb excretion. Also, there are some drugs which can cause proximal RTA, that is carbonic anhydrase inhibitors, because they impair the proximal bicarb resorption. So many different etiologies cause it, like monoclonal gammopathies, acetazolamide, topiramate, ifosfamide therapy. Mostly it is associated with Fanconi syndrome, seen in pediatrics. Patients present with phosphaturia, glycosuria, aminosiduria, uricosuria, bone demineralization due to phosphate wasting. The type 4 happens because of decreased aldosterone secretion or an aldosterone resistance. So you get hyperkalemia. Along with hyperkalemia, there's a mild metabolic acidosis. So this hyperkalemia impairs the ammonia generation. So there is no ammonia to buffer the hydrogen ions, and because of that, there is an acidosis. So the urine pH is less in this case. It is less than 5.5. So causes of hyporeninemic hypoaldosteronism, chronic tubulointerstitial disease, potassium-sparing diuretics, diabetic nephropathy can cause this form of RTA. Type 3 is a very rare autosomal recessive syndrome which happens because of carbonic anhydrase deficiency. It has features of both proximal and distal. So patients present with osteopetrosis, cerebral calcification, and an intellectual disability. So this is an algorithm to show you how to diagnose a hyperchloremic metabolic acidosis, how to approach it. So whenever you get a normal anion gap acidosis, you have to look at your urinary anion gap. Urinary anion gap we calculate by sodium plus potassium minus chloride in the urine. So that if the urinary anion gap is negative, then you have to look at other causes like gastrointestinal loss or some excess acid intake. If the urine anion gap is positive, then then you consider RTA. So whenever you are evaluating an RTA, you have to look at 3 parameters. One is the urine pH, second is serum potassium, and the third is your bicarbonate loading. So for proximal RTA, your urine pH will be less, your potassium levels will be less, and in risk, because proximal RTA you're not able to reabsorb the bicarb, so there is a bicarb loss. So normally the urinary bicarb fraction is less than 5%. So if the urinary bicarb excretion is more than 10-15%, it means the bicarb is not getting reabsorbed. So that is how you diagnose for a proximal RTA. And distal RTA, you will get a urinary pH of more than 5.3. Your serum potassium, mostly it can be normal, it can be low, it can be high also. Your fractional excretion of bicarb will be less than 5%. So you screen for hypercalciuria, nephrocalcinosis whenever you diagnose a type 1 RTA. Type 4 will have urine pH less than 5.4 and the hyperkalemia will be present. Bicarb excretion will be less than 5%. So you have to look for causes of hyporenemic hypoaldosteronism in this case. So treatment, type 1 RTA, you correct the acidosis with oral bicarb replacement. The dose required is low, 1 to 2 MEq per kg per day. Potassium citrate correction may be needed if there is hypokalemia associated, nephrolithiasis or nephrocalcinosis is present. Higher dose of bicarb you need for type 2 RTA, 10 millimole per kg per day. Thiazide diuretics also, they cause volume depletion, they can enhance a bicarb resorption, so they are used in type 2. Phosphate and vitamin D supplementation may be needed to normalize the serum phosphate and also to reverse the metabolic bone disease. Fludrocortisone 0.1 milligram per day is effective for hyperkalemia in type 4 RTA when there is aldosterone deficiency. A potassium restricted diet, loop diuretics, thiazide diuretics have to be given, and always the treatment underlying cause needs to be treated. Thank you. Any questions?
Irrespective of urine output, in some CKD patient, you give soda bicarbonate, or only in patients who are on dialysis, you give soda bicarbonate?
So soda bicarb replacement is given whenever the soda bicarbonate levels are low, less than 22, stage 4 CKD, they start oral soda bicarb supplementation.
Only after the ABG you will be giving it?
Only after looking at the bicarb levels.
Thank you, Dr. Divya. The next session is on thrombotic thrombocytopenic purpura and hemolytic uremic syndrome by Dr. Suvadeep Sen, MD, FNB Critical Care Medicine. He's done his diploma in intensive care from Vienna and ECMO from Paris. His area of interest is transplant, critical care and ECMO. Over to you, sir.
Thank you, sir, buddy. Good morning, everybody. First of all, I would like to thank you all for being a part of the first Nephro Critical Care Conference being held in Apollo, Mumbai. For the next 15-20 minutes, we'll discuss about a very unique and rare disease, which is a thrombotic thrombocytopenic purpura. We'll start with a case scenario. A 33-year-old woman presents with a weakness in the left arm and a severe headache. She was unwell with a fever for the last 3 days. Now she has delivered a baby 3 weeks ago. She is pyrexial. Her blood pressure is around 135/85. Pulse is okay. Her delivery and the antenatal histories are uneventful. She has a purpuric rash on the skin. Power in the left arm is around 3/5. Her lab markers, the hemoglobin is around, she is a little anemic with a normal red cell indices. With a little macrocytic picture, her retics is around 6%, so it's a hemolytic anemia. WBC is a little leukocytosis and platelet count is around 52,000. Her creates is a little elevated, bilirubin is a little elevated, her alkaline phosphate is a little elevated, and LDH is elevated. Now, it's one of the very common situations that we come across in our clinical day-to-day setting, and whenever this kind of thing comes, the first thing that comes as a kind of differential diagnosis is whether it is sepsis, which is a very common thing that we see in postpartum lady coming after 1 to 2 weeks after postpartum, or it's a part of she is dealing with a kind of DIC kind of situation, or it's a kind of thrombotic thrombocytopenic purpura, or any other form of thrombotic microangiopathy. Keeping that thing in mind, we'll start our discussion about the thrombotic thrombocytopenic purpura. So it's a form of thrombotic microangiopathy. It's a rare disorder with an annual incidence of just one in probably one case in per million. So if it is so rare, then why do we need to discuss these things? There are 2 reasons for it. Number 1, there is no pathognomic feature to diagnose TTP. It's difficult to diagnose, so we need to have a kind of very high degree of suspicion to diagnose it. And if we cannot diagnose this thing, if we fail to diagnose this thing, and if we leave it untreated, then the mortality is significantly very high. If mortality is more than 90%. So its prognosis is variable depending on the underlying cause. On the contrary, the HVS has much less mortality, and they rarely progress to end-stage renal disease. There are 2 common variants of TTP. The one form is congenital TTP, which mainly happens in children, but it can present in pregnant women. And the pregnant women, they can be kind of congenital TTP. Congenital TTP is basically because of deficiency of ADAMTS13 protein in the body because of the deficient gene. The other variant is acquired TTP. In the acquired TTP also, are almost more than 50% of the patients, we do not have any precipitating factor or precipitating cause. So most of them are idiopathic TTP. Rest 40 to 50% of patients, we do have some precipitating factors. Like it can be a part of the precipitating factor can be some autoimmune etiologies like SLE or any other form of vasculitis. The HIV is a kind of very prominent etiology or prominent precipitating factor for thrombotic thrombocytopenic purpura. There are a lot of malignancy that can precipitate thrombotic microangiopathies. The pregnancy is a very prominent cause, especially in the partum and the postpartum period. They can present with the thrombotic microangiopathy and the TTP. We can see the thrombotic thrombocytopenic purpura in the setting of the bone marrow transplantation patients, and they might be associated with some chemotherapeutic drugs or quinine and some other. Clopidogrel is one of the important cause as a thrombotic thrombocytopenic purpura. So coming down to the pathophysiology, the basic defect over here is the deficiency of ADAMTS13 protein, which is a von Willebrand factor cleaving protein. Whenever the von Willebrand factor cleaving protein, this ADAMTS13 activity is less than 10%, we come across this entity. That can be because of this congenital deficiency of ADAMTS13 protein, or it can be because of some antibody which inactivates ADAMTS13 protein. So what happens whenever the ADAMTS 13 protein is deficient, von Willebrand factor is not doesn't get cleaved inside the body. So we get an excess accumulation of ultra large hyperadhesive multimers of von Willebrand factors. Whenever that happens, there is a formation of the platelet plug and in the microcirculation that lead to three important things. That what happens whenever there is a microcirculation is impaired, the erythrocytes get shredded by the microthrombi in the microcirculation. That will lead to intravascular hemolysis and microangiopathic hemolysis. Secondly, there is a consumptive thrombocytopenia, which leads to decrease in the platelet count. And because of this microthrombi in the different circulation of the different organ, we tend to see a lot of organ dysfunction, like we see the dysfunction in the CNS, dysfunction in the cardiac system, and dysfunction in the kidney. When do we suspect TTP? Whenever there is an evidence of severe thrombocytopenia with an evidence of microangiopathic hemolytic anemia with some organ dysfunction without any underlying precipitating cause or any identified cause, we should suspect TTP as an important etiology. As I have already told, if you do not suspect TTP, you will not be able to diagnose TTP, and if you cannot diagnose TTP, the mortality remains very high. So it's very important we suspect to have TTP and then we progress. Coming to the clinical feature, the hallmark of the clinical feature. So the classical feature is the pentad that is always taught in the textbook and that we always read in the textbook. Is the evidence of microangiopathic hemolytic anemia with thrombocytopenic purpura, with a neurological dysfunction, renal dysfunction, and fever. This is the pentad. But practically, this classical pentad is present in a very limited number of patients, probably less than 7% of the patients they present with the classical pentad. But hallmark of this disease is the presence of microangiopathic hemolytic anemia along with thrombocytopenia. If somebody doesn't have the evidence of hemolytic anemia along with thrombocytopenia, TTP is not, you cannot diagnose TTP for those patients. So we have to have evidence of intravascular hemolytic anemia and thrombocytopenia. The bleeding symptoms is present in less than 20% of patients. Neurological abnormalities they are present is it's hallmark of TTP. Probably they present almost 40 to 80% of the patients. Among them, that around 45% they present with the major neurological symptoms like convulsions, some major stroke or something like that. Fever is around 40-20% of patients. Around 40% of patients they present with some GI symptoms. Renal involvement is around 10% of patients. It's not very common. It's more common in the hemolytic uremic syndrome. And in the laboratory findings, we get an evidence of thrombocytopenia, elevated creatinine, increased LDH, and anemia. In the peripheral smear examination, we get to see the evidence of cystocytes, but we need to remember that the cystocytes might be absent for initial 1 to 2 days, so that the absence of the cystocyte doesn't rule out the presence of thrombocytopenic purpura. How do we diagnose TTP? So there has to be some features of hemolysis, intravascular hemolysis to be very precise. Intravascular hemolysis, like they will have anemia with some amount of macrocytosis probably. There will be evidence of high reticulocyte count, unconjugated hyperbilirubinemia, low hepatoglobulin, and high LDH. There will be evidence of thrombocytopenia. Thrombocytopenia sometimes often very severe. Sometimes it might be less than 30,000 or less than 20,000 as well. Important is that the coagulation parameters over here has to be normal. That is how we distinguish it from disseminated intravascular coagulation. We always do a Coombs test to rule out autoimmune hemolytic anemia. So the Coombs test should be negative over here. Sometimes we can do a stool culture where we can see that the evidence of enteroinvasive E. coli infection, or most importantly, we should rule out the infection, or we should rule out sepsis before diagnosing TTP. There might be evidence of raised urea and creatinine. We always do serological markers like HIV, HBCG, and HCV serology whenever we suspect a TTP. And we do a cardiac marker test, troponin, to rule out the cardiac involvement. It's very important to understand that the cardiac involvement in presence of TTP is a very sinister finding, which tells us that which entails the very high mortality. And hallmark of the diagnosis is ADAMTS13 activity, which has to be less than 10%. There are a lot of other conditions where we get a low ADAMTS activity, but it remains in the range of 10 to 40%, like in presence of sepsis, some amount of pregnancy. But in those patients, we cannot diagnose TTP. ADAMTS13 activity has to be, or presence of ADAMTS13 specific antibody. If that is there, then we can diagnose TTP. As I have told, the thing is the TTP is a kind of diagnosis which has a lot of differences. You cannot, if there are a lot of differences, you need to rule out before diagnosing TTP. The classical clinical entity that we should rule out before diagnosing TTP is hemolytic uremic syndrome. Can be typical or atypical. There are a lot of, especially atypical hemolytic uremic syndrome. They are a very prominent differential for the thrombotic thrombocytopenic purpura, especially in the pregnant woman where HUS is a very common entity. Before diagnosing a TTP, we should rule out the HUS. Why? And especially in the children, because HUS, which is classical HUS, they do not require plasmapheresis as a treatment of choice. But TTP, if you do not do a plasma exchange, you might lose this patient. That is why it's very important we distinguish it from hemolytic uremic syndrome. We should always rule out the other causes of thrombotic microangiopathy like malignancy, some lupus nephritis, HELLP syndrome and eclampsia in the pregnant woman, malignant hypertension, catastrophic Epla syndrome. There are a lot of drugs that can cause thrombotic microangiopathy and some amount of hemorrhagic fever infections which mimic as TTP. We should always rule out the causes of autoimmune hemolytic anemia as a differential. DIC should always be ruled out before diagnosing TTP with a normal coagulation markers. And most importantly, the most practical, every point of time we diagnose TTP, we should rule out the sepsis as a cause of the entire clinical picture. And ITP comes as a kind of classical textbook differential. So how do we differentiate? Sorry for a very busy slide, but the thing is that we should understand why it is important, because like suppose we take ITP as an example where again the coagulation parameters will be normal. They present with a normal platelet count, but we don't have any evidence of intravascular hemolysis in ITP, so that is how we distinguish it from TTP. In DIC, the coagulation parameters will be abnormal, which will be normal in presence with the TTP. In hemolytic uremic syndrome, usually it presents in children, but there are a lot of atypical HUS that might present in the adult as well. But in HUS, most importantly, the ADAMTS13 activity is normal, and in HUS the renal involvement is much more predominant than TTP, where in TTP neurologic involvement is much more predominant. We should always rule out the other thrombotic microangiopathy. I will come to the next slide for that. And sometimes, very interestingly, we come across very important thing is that anybody who comes with a fever with some amount of pancytopenia with an evidence of some amount of organ dysfunction, we should always rule out HLH by doing a serum ferritin, triglycerides, and bone marrow examination, by which we can rule out the HLH as a kind of important differential. Now, why thrombotic microangiopathies are important to rule out? So how do we rule out the thrombotic microangiopathy? If we classify the thrombotic microangiopathy, there are four classical categories of thrombotic microangiopathy. One is hemolytic uremic syndrome. It can be typical or atypical, D+ and D-. It can be TTP that I have already told, but most important to know, we should understand that the various causes of secondary TMAs like drug-induced, infection-induced, malignancy-induced, after bone marrow transplantations, after anybody with a post-transplantation remains on tacrolimus, they develop thrombotic microangiopathy. And we should always rule out in the pregnant woman preeclampsia and HELLP syndrome as a cause of thrombotic microangiopathy before diagnosing TTP. One important cause is catastrophic Epla syndrome and malignant hypertension. Sometimes they also have an evidence of intravascular hemolysis as a part of microangiopathy. So we should rule out all those things before diagnosing TTP. There is a ISTH guideline that has been published in 2020 as a diagnosis and treatment of thrombotic thrombocytopenic purpura. So far, there was no clear-cut treatment pathway or diagnostic pathway, but they have come with it recently because to highlight the importance of this entity. So why it is important? Because as we know that if we do not diagnose, if we do not suspect TTP and diagnose TTP early, it has a very high, it carries a very high mortality. So that is why the ISTH guideline says, if anybody who has a very high pre-test probability of TTP, then we should start therapeutic plasma exchange and steroid immediately. And before starting therapeutic plasma exchange, we should send serum sample for checking the ADAMTS13 level activity. If ADAMTS13 level comes negative, then ADAMTS13 level comes less than 10%, then we should add Caplacizumab. So again, sorry, the Caplacizumab is not available in India, so it is the international guideline. And we should consider adding Rituximab. If ADAMTS13 level activity is more than 10% or more than 20%, then we don't need to continue Caplacizumab. For therapeutic plasma exchange steroid, we should be guided by other clinical diagnosis. But it is very important from the slide, it is important whenever we suspect TTP is a high, if it is, the suspicion is very high, then we should start therapeutic plasma exchange and steroid early in the course. How do we suspect it? There are a lot of predictive scores that has been defined nowadays. The most the commonest thing that we use is the plasmic score and the French score. Among them, the plasmic score is very popular. That takes platelet count, serum creatinine level, the evidence of intravascular hemolysis, the evidence of cancer or evidence of hematopoietic stem cell transplantations, INR and evidence of MCB. If more than 90, then it takes all these parameters and then determine the patients according to the likelihood of having severe ADAMTS13 activity. Now, what are the major treatment arms for treatment of the thrombotic thrombocytopenic purpura? There are 4 major treatment arms. First is the plasma exchange, which is the mainstay of the treatment in India. Why it is important? Because plasma is the source of missing or dysfunctional enzymes ADAMTS13. So the principle is to replace the dysfunctional plasma with a new plasma. In the process, we do a plasma exchange. Immunosuppressants is the second arm, which starts along with the plasma exchange. Why? Because the majority of the TTP, more than 50% of the TTP are acquired antibody mediated. So that is why it is important to use immunosuppressants to treat the TTP. Caplacizumab, it is a anti-von Willebrand factor monoclonal antibody, which sometimes it can be used for the treatment of the TTP. Then you can keep and halt the primary things that precipitate the TTP, because it is an anti-von Willebrand factor. If you give anti-von Willebrand factor, then the platelet cannot get clumped. So you break down the entire cycle of the pathology. And there are various adjunctive therapies like giving antiplatelets whenever the platelet count is high. We give folic acid supplementation and transfusions. Regarding the guideline of plasma exchange should be initiated as soon as possible within 24 hours of period, as soon as the diagnosis is suspected. Whenever there is an evidence of microangiopathic hemolytic anemia with thrombocytopenia without any other identifiable clinical cause. Pre-treatment samples should be obtained to measure the ADAMTS13 level activity or to detect anti-ADAMTS13 antibody. This is the only one treatment that has been shown to be clinically beneficial, which reduced the mortality from 90% to 15 to 20%. Regarding the dose of the plasma exchange, we usually exchange 1.5 times of the plasma volume for initial 3 days and then 1 times of the plasma exchange daily, till the stabilization of the condition or till the improvement of the platelet count. Sometimes the exchange volume may be more than 1.5 times depending on the response of the patient. Plex is very poorly, is not indicated for malignancy-induced thrombotic microangiopathy or bone marrow transplant-induced thrombotic microangiopathy, because we do not get much response in those clinical entity. Among the immunosuppressants, steroid play the predominant role or mainstay role, because most of the TTP, almost more than 50% of the cause of TTP is antibody mediated. We use a pulse dose of methylprednisolone 1 gram per day along with the plasma exchange. Along with that, rituximab is also coming up a kind of promising treatment. It was classically indicated for relapsing TTP or somebody who has a refractory TTP, but nowadays we use the rituximab even along with the steroid and plasma exchange, which causes lesser chance of remission, which has a kind of higher chance of remission and lesser chance of having a relapse. Among the other immunosuppressive therapies, vincristine was used in the older days, vincristine and cyclophosphamide. Probably we do not use vincristine and cyclophosphamide of late after the coming of the rituximab. Cyclosporin can be used, and in the other countries they use capecitabine as an anti-von Willebrand factor treatment. And the supportive therapy, red cell transfusions as a kind of standard transfusion trigger whenever hemoglobin is less than 7 gram per cent. Platelet transfusion we try to avoid as much as possible because the pathology is the platelet clump formation. So unless somebody is having some life-threatening hemorrhage, we prefer to avoid the platelet transfusion as much as possible. We supplement folate as a part of treatment of the hemolytic anemia. We should always rule out the occult infection, and we should treat the underlying infection, especially somebody on a plasma exchange. We should always suspect. We should always be very proactive in suspect and treating the infection. Low dose aspirin therapy may be given in the patients whenever the platelet count is more than 50,000, and these patients are highly prothrombotic, so they should remain some form of mechanical or pharmacological thromboprophylaxis. Pharmacological thromboprophylaxis probably whenever the platelet count more than 50,000. So one entity is refractory TTP when we get a slow or incomplete response to plasma exchange on corticosteroid. It was previously defined as a persistent thrombocytopenia or persistent LDH elevation after a total 7 daily dose of plasma exchange. It is currently redefined as a progression of the clinical symptoms or persistent thrombocytopenia despite doing a continuous plasma exchange. The treatment of refractory TTP is the intensification of the plasma exchange. Probably we can do a higher dose of plasma exchange with higher volume of plasma exchange, or even the plasma exchange can be done 12 hourly or double the plasma exchange volume. Rituximab is one of the standard treatment nowadays to treat and prevent the refractory TTP. TTP often is a very relapse is defined whenever there is an episode of acute TTP more than within 30 days after remission, and it occurs in 20 to 50% of cases. Again, rituximab is one of the mainstay of treatment in preventing the relapse of TTP, or even in the relapsing TTP, the rituximab can be given as a kind of important therapy. Prognosis, again, as I have told, it carries a high mortality in absence of the early plasma exchange. Like if we do a plasma exchange after 3 to 4 days, probably it doesn't make any sense because it might not help. So early plasma exchange is the most important therapy over here. But even after early diagnosis and treatment, mortality still is around 10 to 20% even at this moment. So as a conclusion, it's a difficult diagnosis, requires a high degree of suspicion and subsequent elimination of the multiple other possibilities. There is clear-cut trigger is absent in majority of the cases. PLEX may be started on the basis of presumptive diagnosis pending reports of the confirmatory test of the von Irem-certain level activity. If there is a high degree of suspicion, the overall treatment is difficult and often have a very poor prognosis. Thank you. If you have any question, probably can ask, or we'll wind up over here. Thank you.
Thank you, Dr. Shubhadev, for the wonderful session. Before moving on to the next session, I would like to invite Dr. Sanjay Chaudhary to kindly felicitate Dr. Shubha Reddy. now I'd like to request Dr. Sanat Das to felicitate Dr. Divya. Also, I'd like to request Dr. Tapas Sahu to felicitate Dr. Shubhadeep Sen. So moving on to our next speaker, Dr. Vishwavikas Mahanti, MD, FNB, EDIC, ECMO, Singapore. He is Head of Critical Care Medicine at Utkal Institute of Medical Sciences, Bhubaneswar. He is the General Secretary for Indian Society of Critical Care Medicine, Bhubaneswar. He is a speaker for national and state level critical care conferences. His area of interest is extracorporeal oxygen support therapy. Today, Sir is here to talk about abdominal compartment syndrome and acute renal failure. Over to you, sir.
ये वाला वो वाला ये है सर और ये पॉइंटर है और ये नेक्स्ट स्लाइड है ये नेक्स्ट स्लाइड ये पॉइंटर है
So, good afternoon. Thank you, Dr. Gunadhar and Dr. Tapas for inviting me. So, after a lot of organ crosstalk, so like liver, how liver affects kidney, how heart affects kidney. So, the important topic, one of the important topic which usually we intensivists underdiagnose or underestimate, it is abdominal compartment syndrome. So, how abdominal compartment syndrome affects kidney? So, now, since yesterday we are discussing that AKI is very common in critical care unit. 1 in every 5 patients develop AKI, especially surgical patients when they are admitted in intensive care unit. Now, intra-abdominal hypertension or ACS as a potential etiologic factor which is usually overlooked in ICU, but it is very common. Now we can see intra-abdominal hypertension is prevalent in about half of the critically ill patients admitted in intensive care unit. That means it is very common, that is intra-abdominal hypertension is very common, but when it causes AKI, we usually underestimate this. So now we should discuss why it's so, how common it is. See, here it's a meta-analysis. Here you can see in the meta-analysis here, so this is the intra-abdominal group, this is non-intra-abdominal hypertension group. The incidence of AKI in the intra-abdominal hypertension group is much more as compared to the non-intra-abdominal group. Here is the p-value is very significant. That means intra-abdominal hypertension causing AKI is very common. So coming to a case history. Now it is a 56-year-old male who referred to our hospital because of inability to take out of the ventilator. Okay, so his history was his case of pneumonia complicated with sepsis and septic shock. So initially in the outside hospital he received almost 10 liters of fluid. So every day he is getting 1 to 2 liters of fluid balance positive. So almost a total 14 liters of positive balance. So despite receiving this much of fluid balance, these patients develop AKI. So now the creatinine with 1.7, we receive the patients in our hospital. When we examine these patients, patient is almost grossly swollen, and that is edematous, and he is not maintaining the MAP. MAP is almost 60.
though we are not started in any vasopressors, but the urine output is borderline, almost 20 to 25 ml per hour. So that means, and when we examine this patient, his abdomen is distended, so our thinking was maybe patients develop abdominal compartment syndrome. So we measured the intra-abdominal pressure. It was almost 21, and its peak pressure on the ventilator is touching almost 30, the plateau pressure. So now, how should we manage this patient? So now, as this patient is grossly swollen, edematous, and abdomen is distended, so is this patient developing abdominal compartment syndrome? Because you know, when we are examining tense abdomen, it is almost 80% specific for the diagnosis of abdominal compartment syndrome. Along with, if any patients develop any of the organ failure. So why we are discussing this? Because kidney is the most common organ to affect from the abdominal compartment syndrome. Rather, it is the first organ to get affected from the abdominal compartment syndrome. So these patients, the examination, the abdomen is quite tense and he is developing acute renal failure. So our suspicion was this patient is developing acute compartment syndrome. For this, so we should have two components. The intra-abdominal pressure mostly should be more than 20, along with these patients having some renal failure, especially the AKI related to elevated intra-abdominal pressure. So with this, we should go to the what is abdominal compartment syndrome definition and the grading. So intra-abdominal pressure is the pressure inside the abdomen cavity. The normal value is almost 5 to 7, but when it is the intra-abdominal pressures go more than 20 and associated with the organ failure, we call this abdominal compartment syndrome. So intra-abdominal pressure, there is a 4 grading, grade 1, 2, 3, 4. Grade 1 is almost 12 to 15, grade 2 is 16 to 20, grade 3 is 21 to 25, grade 4, which is extensive, the severe form of abdominal compartment, intra-abdominal hypertension, then the pressure will be more than 25. But thing is, diagnosing abdominal compartment syndrome, especially in critical care unit, when we see most of the patients are sepsis, is extremely difficult because in our sepsis patients, the AKI is very common. This related to, maybe related to like sepsis related AKI. Maybe patient is hypotension developing AKI. But here, if you are suspecting abdominal compartment syndrome, the abdominal pressure is high, and this, because of this abdominal pressure, this patient is developing AKI. So distinguish patient to this related to sepsis AKI or abdominal compartment syndrome leading to AKI is very difficult. So we have to be very much clear in mind that if the patient is developing tense abdomen, the AKI should be there and it's related to abdominal compartment syndrome. So coming to the etiology, so there are two forms, like one is primary abdominal compartment syndrome, another is the secondary. Primary is the pathology inside the abdomen. The most common one is severe acute pancreatitis, any form of trauma and recent abdominal surgery, any hemorrhage like retroperitoneal, intraperitoneal hemorrhage, and any form of dilated viscera like patient is having colonic sheath obstruction, paralytic ileus, toxic megacolon, all these things like this cause primary SCS. Secondary SCS, when the pathology is not in the abdomen, but the patient is developing abdominal compartment syndrome. Especially the most important one is large volume resuscitation, especially what we see in our critical care unit. These patients, like in our cases, these patients came to us with large volume resuscitation in a span of 7 days, almost 14 liter positive balance. So what are the contributing factors, like if the patient is in high PEEP, any form of intrathoracic pressure, increased intrathoracic pressures, especially air-days patient when on high PEEP, prone positioning, obesity patients, also like pregnancy patient where the abdomen can be complex. These are the contributing factors leading to increased abdominal compartment syndrome. Now the thing is, so our thinking is, if the patient does not have pulmonary edema, then give some fluids. So like that like our saturation is maintaining, chest is clear, so we give some fluid because the BP is not maintaining, urine is not coming. But this is absolutely wrong, because pulmonary congestion is clinically obvious, because you are doing the ultrasound, there is no lung B line, your chest X-ray is clear, but intra-abdominal hypertension we are not able to diagnose. So that means it is underdiagnosed. In these cases, but patients gradually it's developing AKI. So in these cases, so you have to be very much clear. Though the chest is clear, still the patient is developing fluid overload. And one of the commonest indication of fluid overload is abdominal compartment syndrome. So how these patients, when we are going for over-resuscitation, this patient develop AKI. You see here I have shown you there are two studies, one in burn patients, one in cardiac surgery patients, where you can see when we are giving large volume resuscitation, the intra-abdominal hypertension is going up. So this is the evidence. So how giving lot of fluids, patients develop AKI. So when we giving some fluids, more and more fluids, these patients develop salt and water retention, leading to like intestinal edema, leading to visceral swelling and intra-abdominal hypertension, leading to AKI. So that means if you are giving much and much fluid and the patient is not able to excrete that much amount of the urine, so gradually third spacing will be there, that patients develop parietal edema leading to intra-abdominal hypertension and AKI. So then the question is, what are the factors contributing to AKI in abdominal compartment syndrome? So here you can see, if the intra-abdominal pressure will be high, it leads to increased intrathoracic pressure, then the basal segments of the lungs will collapse, the patient will develop basal atelectasis. This leads to hypoxia and hypercapnia. So hypoxia and hypercapnia is equally dangerous to the kidney, leading to renal hypoperfusion and AKI. Also, increased intra-abdominal pressures leading to compression of the renal vessels and the renal parenchyma. If it is compressing the renal artery, it is directly compressing the renal perfusion. If it is causing renal vessel, venous congestion, also the renal parenchyma will not get perfused. So, in both cases, like compression of the renal vein and the renal vessels, leading to renal hypoperfusion and in AKI. Also, if the intra-abdominal pressure will be high, it will cause compression of the IVC, leading to decreased cardiac output and decreased mean arterial pressures, leading to decreased renal hypoperfusion and AKI. Also, in most of the cases, like trauma cases, any type of hemorrhage and fluid loss to the third space, these patients will be hypovolumic, leading to renal hypoperfusion and AKI. So overall, these are the factors causing to AKI in ACS. The most common one is the compression of the renal vasculature and parenchyma from the compression of the intra-abdominal pressure. So apart from kidney, intra-abdominal pressure has affected almost all part of the system. So renal system already I have told you, but you can see here, like respiratory system, it increases intrathoracic pressure, increase peak aero pressures, increase plateau pressures, like in our cases, decrease FRC and VQ mismatch. In the central venous CNS, it increases intracranial pressures with decreasing cerebral perfusion pressure. In the cardiovascular system, decrease right ventricular afterload, decrease venous return and cardiac output. In the GI system, it decreases abdominal perfusion pressure, decrease perfusion to the organs, increase intestinal permeability of the and bacterial translocation, leading to multi-organ failure. So that means intra-abdominal hypertension, abdominal compartment syndrome can affect almost all organ of the body. So here we are discussing with only the renal part, but it can affect all system. Now the question comes, how you will measure? So the best method of measuring intra-abdominal hypertension is the direct measurement. So that means intraperitoneal dialysis catheter or Veress needle during laparoscopy. But this is not commonly practiced because this is invasive procedure. There is a lot of complications. So nowadays, worldwide, the most common method of measurement is the indirect measure of like intravesical measure. So here you can see how you will go to the measure of the intravesical measure. So this is the Foley's catheter is there. Here we put a ramp with 3 stopcocks. So this is the urine bag system. So one will connect to the pressure transducer, one is the 60 ml syringe, another one is the most proximal one is attached to the IV infusion pump. So what we will do, first we will stop this, clamp, we'll clamp this and we'll open this clamp and we'll take some 25 to 30 ml fluid into this 60 ml syringe. Then you open this transducer, open this stopcock to the transducer. Then you open these two transducers to the patients. That means 25 to 30 ml of fluid will infuse the bladder. Then you will open all this stopcock to the transducer. Then you can measure this pressure. With this pressure, it will attach to the monitor. Then you will see what is the intra-abdominal pressure. But for this, the patient should be supine. Patient should be relaxed. This patient should not have any UTI. This patient should not, if the patient on ventilator, should not be coughing, because any form of intra-abdominal pressure, it will cause falsely elevated intra-abdominal pressure. Then coming to the management. So treatment of AKI in ACS. So how will you manage this case if the patients develop AKI? So first thing is, the most important one is the fluid balance. Like in our cases, it's grossly fluid positive up to 14 liter. So here what we'll do, first important thing is make the patient supine position. Because if the patient is upright, the intrathoracic pressure will be high. Gradually it will compress the abdomen. So your intra-abdominal pressure will be high. After that, you will start diuretics. If the patient is making good amount of urine, that is good. Otherwise, you have to go for dialysis. In the dialysis also, you should remember your dialysis catheter should be in the neck vein. Because if you put the dialysis catheter in the femoral vein, because of the compression of the intra-abdominal pressure, you will get not good access. Also, if you get access, the flow will be not adequate for the dialysis. Second important thing is preservation of the intra-abdominal perfusion. Because you know that if yesterday the lot of lecture was telling regarding perfusion pressure of the kidney. So your perfusion pressure of the kidney should be, abdominal perfusion pressure should be more than 60. So your abdominal perfusion pressure should be more than 60 to maintain perfusion to the kidney. But how will you maintain abdominal perfusion pressure is the mean arterial pressure minus intra-abdominal pressure. That means if your intra-abdominal pressure is high, so you have to maintain your mean arterial pressure at least more than 70 to 75 to keep your abdominal perfusion pressure at least 60 for the perfusion of the kidney. Now the third one is the enteral management. Enteral management to GI decompression by nasogastric or rectal tube. Also you have to start prokinetic agents if the bowel is dilated after excluding any mechanical cause of GI obstruction. Then comes the last one is the surgical intervention. So surgical interventions like decompressive laparotomy, or if it is a surgical cause like open abdomen, then you have to put a negative pressure wound therapy. And some more other methods like sedation. If the patient on ventilator is fighting, then you have to sedate the patients, because if the patient is using accessory muscles and then your intra-abdominal pressure will be high. Then if with the sedation, optimal pain management, patient is not getting sedated properly, still the abdominal pressure will be high, then you have to relax the abdominal wall by neuromuscular blockade. Also that time you have to ventilate the patients, keep sedated properly, ventilate and make him relax. So coming to our case, now our patients after receiving from the another hospitals, after starting diuretic also, after receiving, the patient is now almost anuric. He is not passing urine since last 4 hours. Now the creatinine has jumped from 1.7 to 2.3, that means almost double. Now your case is, he is a massive volume overload and his intra-abdominal pressure is high, almost 21, and the blood pressure is up, that is borderline, MAP is almost 60. Now how to manage this case? Because in order to recover from the intra-abdominal pressure, what we have discussed now, this patient is grossly edematous and his net positive balance almost 14 liter. That means he requires fluid removal. But at the same time, his blood pressure is soft. That means blood pressure is borderline. So what we should do this case? So what we have started? So we plan squeeze and diuresis technique. That means what we have started. First we have started NORAD to maintain the MAP almost more than 60. Here we started NORAD to make the MAP almost more than 70 to make our abdominal perfusion pressures almost 60. Then we have started diuretics bolus followed by infusion. But over the next few days, the patient starts making urine. Almost 8 liters of urine is makes almost in the next few days. Gradually his AKI is recovered. His pulmonary function is improved in the term of his PEEP, and all things is come down, and he was able to wean from the ventilator. So coming to the treatment overall, so what I have told the treatment in cases of AKI, but overall you can see, so this is the, sorry. One minute. So coming to the treatment, just this slide. 70. Okay, so coming to the overall treatment, so step 1 is actually that these are the steps actually: evacuate intralaminar contents, evacuate intra-abdominal space occupying lesions like any ascites, anything is there, any tumor, any ascites, anything is there, you have remove, improve abdominal wall compliance, optimize fluid administrations, like if the patient is overloaded by ultrasound guided, you should give some fluids, and optimize systemic or regional perfusion. So this is step 1. Gradually by step 1 and step 2, step 3. So with this step 1, step 2, step 3, if the patient is not able to maintain, the last options will be surgical correction. That is, patient needs laparotomy. So nowadays, still what much studies are there? The role of intra-abdominal hypertension developing AKI, there are a lot of limitations of these studies. First one is there is low number of participants and the heterogeneity of the participants. So mostly these patients are from the medical ICU patients. Very less number of surgical ICU patients are participated in this study. So there is lack of continuous intra-abdominal pressures measurement. Whatever we are doing with the intravesical method is, there are a lot of fallacies. Lack of generalities of the result. Presence of various etiology for the measurement, development of the intra-abdominal hypertension. So there are a lot of causes of the intra-abdominal hypertension. So these studies which are we are using right now for developing the cause of intra-abdominal hypertension leading to AKI, there are a lot of fallacy. So the future perspective for the studies will be, there should be large randomized control trial, more uniform surgical patients group, development of the non-invasive and quick IIP measurement methods. Also, there should be investigations of impact of early diagnosis and different therapeutic alternatives on AKI incidence and the management. So, to summarize, intra-abdominal hypertension is common in both medical and surgical patients, but usually it is underreported. Intra-abdominal hypertension and the abdominal compartment syndrome are the potential cause of AKI, but it is usually overlooked in clinical practice despite their high frequency. Large volume resuscitation is the common cause of AKI, but it is very much neglected. Intra-abdominal hypertension may cause occult organ injury, especially kidney, because you know that this is the most common, usually the first organ to get affected if the abdominal pressure is going high. So early suspicion diagnosis are crucial, as late diagnosis can lead to high complications rates. So there should be accurate method for IAP measurement, which results precise monitoring and the treatment as urgently needed. Maintaining an abdominal perfusion pressures more than 60 might be beneficial. Even if you will start early NORAD, this doesn't matter, but maintaining the perfusion, the kidney is most important to prevent the kidney from going from stage 1 to stage 2. So the best approach to intra-abdominal hypertension is prevention by using a conservative fluid resuscitation strategy. As we are doing, like every patient is coming to ICU, we are giving fluid because this patient is not maintaining MAP. So this is usually should not be done. After a resuscitation of like 2 to 3 days, you should be very conservative regarding fluid strategy. This is my reference. Thank you. Any questions? Yeah.
That was a very nice talk. In your patients, did you measure the intra-abdominal pressure?
Yeah.
Okay, because
This
we
was
check this in a lot of patients.
no. Our patient's intra-abdominal pressure was 21. When you received this patient, this intra-abdominal pressure was almost 21.
Alright. And so do you get that three-way?
Usually you don't get it, but by like some connector is there where you use this three-way parallel, 1-to-1 parallel you use and make this usually.
So it's not very difficult?
No, it's not much difficult.
So can this vexus be used as a surrogate thing?
Yes, definitely. Now with this vexus, now I think the things will be very easy for measurement of the what Dr. Tadekar yesterday was highlighted. So we should use this because this is very much important, especially our cases like intra-abdominal hypertension, like fluid overload. If we use vexus, so that we should be very much conservative in our fluid strategy, so that intra-abdominal hypertension related to volume overload, it can be very much easy and to prevent this.
Also, is it safe to say that intra-abdominal hypertension is like same as volume overload, or?
Not always I can tell that. So see, like what I have told that it's.
I'm asking from a nephrologist perspective. I'm asking from a nephrologist perspective. So a lot of times we face the situation and we don't know what to do.
No, so basically if this patient is like volume overload, there are a lot of for volume overload we have to assess clinically, also we have to like lot of measurements are there. But intra-abdominal hypertension, we are calling this patient is intra-abdominal volume overload leading to intra-abdominal hypertension leading to AKI. For this, your intra-abdominal hypertension measurement should be very precise, because whatever we are using this is like this is intravesical method. For this, lot of fallacies is there. So after correctly measuring this, and after that, if you are reaching this intra-abdominal hypertension is there and the patient is developing like AKI anything, so then you can tell that this patient this intra-abdominal hypertension is mostly due to volume overload.
No, but see the other primary causes you mentioned, like acute pancreatitis or say
Yes, so definitely before going to that, this is intra-abdominal hypertension causing AKI. Before that, we have to rule out all the causes. So if this patient is like primary abdominal pathology, like this patient is bowel is dilated, and the patient is grossly that like paralytic ileus, this patient is hypokalemia, the bowel is dilated, then you cannot tell that this is related to volume overload. Maybe simultaneously over this span of the year, the patient may be volume overload, but before that we have to like negate all the contributory causes like paralytic ileus, like colonic pseudo obstruction. If this patient is developing like toxic megacolon, all these things we have to rule out before we tell that this volume overload leading to AKI.
Very good presentation, to Sir's question. Intra-abdominal hypertension is rare in medical. It's a surgical problem. That's the first thing you look at. What is there in the abdomen physically? Either it is a dilated bowel, fluid, pancreatitis. And in addition to that, fluid overload or fluid resuscitation add to that aspect. One of the treatment measures is make the patient negative, which is that is now and call the surgeon to open the abdomen or after that. But primarily as a fluid resuscitation causing intra-abdominal hypertension is rare unless you have 50 liters of fluid in the next 6 or 8 hours. So, but as a management strategy, one of the things that we can do is to make the patient negative to do obstruction or repercussion, which is part.
Yeah, to supplement what just said, most of the time surgeries are other abnormalities that led to the blood overload. Leading to the doctor department. So, for instance, there's a big cardiac surgery, the patient has been in profound shock in the OR, and they have been pumping a lot of blood and fluids to keep the patient alive and resuscitated. And you see the patient back in the ICU, and now we are 25 meters positive. And yes, getting the patient on CRT and getting the volume off would be one way to take care of that, but again, it may be somewhat limited because of the blood pressure and some of the other hemodynamic factors. So it's not uncommon for just because of the elevated abdominal compartment pressure, you may have to do a decompressive lobotomy to bring down the abdominal compartment pressure.
Question basically, I understood correctly now. Suppose pancreas will take the organ, this is retrograde. So it will really reflect the interpretation of suppose you are retrograde hematoma. So whether these two organs, the things which are in the abdomen, that's fine. Therefore, retrograde.
Even
it will reflect the same thing.
so only in pancreatitis, it's not like that. Is pancreas is swollen is causing like intra-abdominal pressure. In the pancreatitis, there is harsh response, and this patient starts leaking capillaries. This patient is grossly starts, even in the pancreatitis patient, especially after 48 hours, if starts resuscitating volume, then this patient starts developing leaky capillaries. These patients like bowel walls get edematous, and this like parietal edema, bowel edema, all these things, even if pancreatitis is a retroperitoneal organ, so not only pancreatitis, because the organs per se is increased the intra-abdominal pressure. So because of a lot of things contributing, especially volume overload is causing pancreatitis. Anything? Any question? Or?
Thank you.
Thank you. Thank you, Dr. Mohanty. Moving on to our next speaker, I would like to invite Dr. Gunjan Chanchlani. She has done her MD Anesthesia, IDCCM, FNB, IFCCM, EDIC, Chief Intensivist, Critical Care Medicine at KJ Somaya Medical Hospital, Mumbai. She is a faculty critical care for various critical care training programs. She has also been applauded for her selfless work in the COVID pandemic by Mr. Amitabh Bachchan. She is a founder director at JP Homes, a company to provide advanced quality medical and nursing care for the comforts of the patient. She is also an author and has been part of many research projects and written many articles as a subject expert. She is here to give you all an insight about rhabdomyolysis. Thank you. Over to you.
I think I need to first thank for this extensive introduction. Thank you so much. So good morning everyone and welcome again. So my topic is rhabdomyolysis and I want to thank Nephro Critical Care Society and the team who allotted me this topic because I could actually revisit it after a good 12 years after I gave my exam. So thank you again, and so we begin. It's a very dry topic. I'll just try to cover it in short, the best we can. So as the name suggests, rhabdo means a striated Myo means muscle and lysis means breakdown. So we are going to talk about rhabdomyolysis, how the muscle breakdowns and how the reactions happen in the body, how we can prevent the complications and treat the whole condition. So it is, in simple terms, it is a breakdown of skeletal muscle fibers, a potentially life-threatening syndrome. Though it is rare, it is not so rare, and we need to be aware of it to really know that it has happened. The breakdown of the muscle fibers causes leakage of the muscle contents into the circulation and the whole syndrome or the pathophysiology. Let's go through a quick case when we have a 20-year-old male who was with his friends doing cocaine. The police break up in the party and the male runs from police but collapses. And he states that his legs have been very weak and he just fell down, was admitted to the ED and complains of extreme lower extremity weakness and pain in the legs, which is the most common symptom of this syndrome, the weakness and the severe pain. These are the symptoms that patients present with. The ABG on admission showed a severe metabolic acidosis and a potassium of 6.7 with a high creatinine, BUN, a high phosphorus and a low calcium, as you can see. So these are again the most important electrolyte changes that we see. And when we send the enzymes, we see the CPK levels high, almost 4,700 with a high LDH. And of course, there are other parameters which are deranged. And this is his color of the urine, which is cola colored, which the reddish brown color with a low specific gravity, low pH, and the casts which are present. So this is the typical color this we see in rhabdomyolysis. So what is rhabdomyolysis? As I said, it is a serious life-threatening condition which occurs due to direct or indirect injury which happens to the skeletal muscle tissue. So it is specific for the striated muscle tissue. There is rapid breakdown and the death of this skeletal muscle fibers which release potentially toxic cellular elements into the circulation, and the whole pathophysiology starts from this point. It has to be distinguished from many other conditions which may give pigmentation in the urine, like presence of other drugs, hemolysis, or even porphyria. Most important here is that the creatinine kinase levels start rising to a very significant level. The normal levels of creatine kinase are 40 to 320, and in rhabdomyolysis they are at least more than 5 times the upper normal limit. It may even go up to 10 to 20 times higher, and there have been patients which have shown values above even 1 million per liter. It can be a single event, and in some patients who have some genetic abnormalities, it may be a recurrent event after even a little muscle strain like just working out in the gym. And if there is a recurrent event that is happening, it is very important that we rule out a genetic disorder. So very surprisingly, that was first reported way back in 1881, which is in the German literature it is mentioned, and only in 1910 was it recognized as a syndrome, where it was first named as a Meyer-Betz syndrome after a German physician who described the typical triad of this syndrome, which occurs in muscle pain, muscle weakness, and the change in the color of the urine. It is then first described in the victims of crush injury during the World War II, and then in various animal models, the whole myoglobin as an offending agent was found out and the final treatment was planned. And in 1950, finally it was realized that dialysis could significantly reduce the mortality in this condition from 84 to 53%. The important aspect that we need to remember that it is, though rare, it is not a very rare disease, and we need to be aware. It accounts for almost 8 to 15% of all new cases of acute renal failure that we encounter. So up to 40% of patients who have rhabdomyolysis will have acute renal failure, but the new cases of ARF, almost 8 to 15% are secondary to rhabdomyolysis, and the overall mortality rate of this condition is approximately 5%, which is very high. It is more common in males, and it can occur in all age groups, whether it is infant, toddler, adolescent, adult, or even old age if there are risk factors. The causes again are quite extensive. The most often is the traumatic cause, which can be related to any multi-trauma, a crush injury after major surgeries, coma, immobilization, or it could be non-traumatic cause, wherein often we see patients having some heat illness, even heat strokes that we are seeing these days, extensive exertion, working out in the gym, continuous seizures, status epilepticus, metabolic myopathies, malignant hyperthermia, neuroleptic malignant syndrome may cause it. Many drugs and offending agents are also implicated, and the most common that we see is statins, which we commonly use, and statins can cause rhabdomyolysis, especially in the elderly. Various infections and electrolyte abnormalities can also be a causative factor. Here, as you can see, there's a chart to see which is the commoner factor, and viral myositis is the commonest and followed by trauma, or which is the common cause after it. Exercise follows very close to the third cause of rhabdomyolysis. So this is just a list of drugs. Extensively, it is basically to suspect it. For us, we need to remember that antipsychotics, statins, and LSD, alcohol, cocaine, these are common implications to cause it. Amongst the antibiotics, we have itraconazole, zidovudine, erythromycin, which are common causes. Even corticosteroids can cause rhabdomyolysis. So we have to suspect when a patient presents to us, especially with cola color urine. Here I want to highlight the cola which goes back into the flush, which indicates the cola color urine, and that is where the cola should lie eventually. So it is breakdown of the muscle fibers, especially the sarcolemma, which results in release of myoglobin, and this gives this color of the urine, the brown color or the cola colored urine. And this myoglobin precipitates in the renal tubules, which eventually shuts down the renal system, and there is intrinsic renal failure with oliguria, and this oliguria is often due to the hypovolemia which develops because of the shift of the extracellular fluid into the injured muscle and leading to underperfusion. So there is intrinsic renal failure as well as underperfusion, which both contribute to eventual development of the acute kidney injury. The clinical manifestations, as I said, the triad is very important, though it sounds very non-specific. The patients present with muscle pain, weakness and dark urine, and they may often ignore this fact that it is just a regular muscle pain which I had after the gymming exercise, and they may be asymptomatic and just present with severe acidosis and acute renal failure, or even in DIC. There may be local features sometimes which may present as the local muscle pain, stiffness, swelling or tenderness or bruising. Sometimes after trauma, there may be evidence of compartment syndrome. Now, compartment syndrome itself can cause rhabdomyolysis, or rhabdomyolysis can lead to compartment syndrome. So we do not know whether the chicken came first or the egg. But the muscle and limb weakness is what is quite pathognomic for this. There may be systemic symptoms like cola-colored urine, which results from myoglobinuria, generalized weakness, confusion, unconsciousness, fever, nausea, vomiting, tachycardia, less frequent urination. In severe cases, it can lead to acute kidney injury and DIC. The pathogenesis involves the process wherein there would be factors which lead to cellular hypoperfusion, hypoxia of the tissue, which initiates the death of the muscle. Now this death leads to decrease in the ATPase because the ATP is required for the muscle contraction, and this causes failure in the pump of the muscle, leading to release of the inflammatory mediators, platelet aggregation, vasoconstriction and increased vascular permeability. So there is eventual ATP depletion in the dead tissue, which increases the intracellular calcium, which usually is a extracellular, and this leads to hypocalcemia, which we often find in the condition, triggering a series of proteolytic enzymes, myositis, destruction and leakage of the cell components in the stream. The lysed muscles release potassium, phosphate, creatine kinase and myoglobin in the tissue. All these levels are very high in the serum, and they start retaining water and calcium. So there is hypocalcemia, and the retained water can cause swelling of the compartment, which can lead to acute compartment syndrome. So eventually we have electrolyte imbalances with hyperkalemia, hypocalcemia, hyperphosphatemia, hyperuricemia, and of course metabolic acidosis. If after revascularization, often all the fluid which is trapped in the damaged tissue now gets released, and there would be more cytokine release which may aggravate the whole process. Otherwise, because of the if the resuscitation is inadequate, it can cause to hemoconcentration, shock and hypovolemia, and the whole myoglobin, potassium, phosphate entering the venous circulation and leading to acute kidney injury and severe metabolic acidosis. The complications usually which develop in the first few hours are related to the fluid and the electrolytes, which is hypovolemia, hyperkalemia, hypocalcemia, and often many patients who are unaware or delay their presentation can also present with cardiac arrhythmias and cardiac arrest. And the late complications which develop after the first 12 hours to 72 hours is kidney damage, acute tubular necrosis. The acute renal failure, as I said, new acute renal failure can account for up to 15% of the new cases. Then there could be DIC, ARDS and sepsis as well. Mechanism, as I already discussed, there's the death of the muscle cell which explodes and the protein enters the blood. The muscle protein enters the blood, which clogs the tubules, causing kidney failure. There's hypovolemia, which causes renal perfusion, renal hypoperfusion, which and renal vasoconstriction. There is cast formation in the tubules, which blockage of the tubules. Direct myoglobin itself can cause nephrotoxicity, and the heme products also which are released can act as free radicals and oxidation process which can damage the kidneys. So as I said, it can also lead to sudden cardiac death, especially in patients, many patients who are young athletes, who can have a sudden cardiac death, which is often related to the high potassium release, which is there in the circulation, and the high catecholamines, which can cause arrhythmias and sudden cardiac death in this condition. So kidney failure is not really a cause of the cardiac arrest. The cardiac arrest is secondary to the electrolyte imbalance, which presents acutely. Patients who present to the hospital can have laboratory findings, which again I already discussed, the creatine kinase levels, which has to be at least 5 times the upper normal limits, and it can go to as high as 1 million units per liter. And this creatine kinase again is of, as we know, is of 3 types: the MM type, the MB type, and the BB type. We may also see that some amount of creatine kinase MB is high, which we often take a marker of the cardiac injury. But in rhabdomyolysis, it may be high despite no cardiac injury. And this is basically some amount of the MB factor, which is also released from the skeletal muscle. This creatine kinase starts rising very early, within first 2 hours itself of the onset of the muscle injury, and it reaches its maximum around the 24 to 72 hours and shows a decline after the first 3 to 5 days. There is myoglobin may be detected in the urine with high potassium, high phosphorus, high uric acid in the blood, and low calcium in the blood. Again, there would be various differential of high creatine phosphokinase, but the severely or very high levels are classically seen in rhabdomyolysis, and the differential involves a brain injury or the stroke with convulsions, maybe myocarditis, lung disease, muscle dystrophies, and other conditions like hypothyroidism, hyperthyroidism, and malignant hyperthermia also. So the main factor to have a good survival to rhabdomyolysis is the prevention. So any strenuous exercise or moving on the heat requires a good amount of hydration. Always have a balanced diet and exercise. Know the risk factors or the risk drugs. Never over exercise in extreme heat condition. Take drugs and alcohol. Keep well hydrated to maintain a color of the urine. On the right side, we have this urine chart everywhere in our hospital, and to highlight on the summer part of the dehydration and can lead to even rhabdomyolysis and heat stroke. And of course, replace electrolytes. Any patient presenting to us in a severe rhabdomyolysis, the treatment involves for us is always ABC, and fluid resuscitation is the main stake of the treatment, or the main step which you cannot forget. So early aggressive fluid resuscitation can change the outcome to a great extent. Replacing electrolyte, alkalization of the urine, which I'll come to in a few slides. Treat hyperkalemia actively. Treat hyperphosphatemia actively. Treat the underlying cause, again very important. If there's a compartment syndrome, do a fasciotomy, and some role of free radical scavengers and antioxidants may be present, which we'll see in the further slide. So fluid. That is the treatment for this condition. You cannot forget fluids. Always obtain a large bore peripheral IV access and start fluid resuscitation. In the first hour, a fluid resuscitation of more than 1 to 2 liters may be required, and later on the fluid resuscitation may be as high as 400 to 500 ml per hour, and our target should be to have a good urine output of minimum 3 ml per kg per hour. That should be the minimum targeted urine output that we should target, because this amount of fluid resuscitation and the diuresis allows us to flush out the myoglobin from the tubules, and preventing the clogging of these tubules, and improves the survival of the kidney as well as the patient. So optimal fluid and rate of repletion, again there is no data which will say what is the optimum rate and the optimum fluid that you should give. There are no studies which compare the efficacy or the safety of different types of fluid that are used or the different rates of fluid that are used. But yes, close monitoring and replacing fluid in a patient who's producing urine should be continued. But a patient who's already oligoanuric, we should be very cautious with our fluid resuscitation, or we may land up in compartment syndrome because of over-aggressive fluid resuscitation, or maybe even an abdominal compartment syndrome at times if there is another coexisting factor. So early appropriate aggressive fluid may prevent complication by removing the myoglobin out of the kidneys, and isotonic crystalloids are what are preferred, NS or RL depending on your potassium levels, and balanced fluids also may be considered once we have very high fluid resuscitation or very high fluid requirements. Studies of patients with severe crush injuries which have resulted in rhabdomyolysis suggest that the prognosis is better when we start fluid resuscitation at the pre-hospital level. So resuscitation of fluid started as early as possible is a turning point. So isotonic saline, titrate your fluid, and target to flush out the creatine kinase levels as high as possible. Once the creatine kinase levels come low than 5,000, we may consider to not stop the treatment, but yes, decrease the fluid resuscitation to a little moderate levels. The role of bicarb, again, the role of doing enforced alkaline diuresis is not very clear, but producing alkaline urine may again decrease the precipitation of myoglobin in the renal tubules and decrease the incidence of acute kidney injury. The target is to maintain a urine pH of at least 6.5 to 7 by administering bicarb. If the pH of urine is very low, we may consider to give 5% dextrose with 100 ml of bicarb as a maintenance fluid alongside with our fluid resuscitation if required. So bicarbonate of forced alkaline diuresis reduces renal heme toxicity. It decreases the release of free iron also from the myoglobin and formation of the vasoconstricting cytokines, that is F2 isoproteins, and the risk of tubular precipitation of uric acid as well as myoglobin. Again, there is no clear evidence that alkaline diuresis is more effective than a plain saline diuresis in preventing AKI. So when I say diuresis, often patients may be oliguric to present with. So we may initially require some amount of diuretics also in the form of furosemides or maybe metalazone to flush out the urine. Earlier, mannitol was used for forced diuresis, but again now it is not used because of its own risk of producing nephrotoxicity. It was found to have minimized the intratubular heme pigment deposition and the cast formation, and as well as acting as a free radical scavenger. The net clinical benefit is uncertain, and therefore it should not be routinely administered in patients of rhabdomyolysis. If in patients who are already oliguric or have severe life-threatening hyperkalemia or severe metabolic acidosis, in those cases dialysis is our treatment of choice, and use of dialysis at the right time to remove the myoglobin, hemoglobin, uric acid, potassium, phosphorus, and to correct the metabolic acidosis is very important. The use of dialysis to prevent kidney injury is not proven. Dialysis has to be used as a treatment in your patient who has oliguria, who has life-threatening hyperkalemia and metabolic acidosis, and not as a preventive measure for your acute kidney injury. Free radical scavengers and antioxidants, again the role is not very proven. The magnitude of muscle necrosis, in experimental studies it has been shown that administration of free radical scavengers may reduce the magnitude of muscle necrosis. It may help minimize the amount of nephrotoxic material which is released from the muscle if we give as an early treatment. Pentoxifylline, vitamin E, vitamin C, 21 amino steroids, minerals like zinc, manganese, selenium, all have been studied and may have a role. Again, this role is not very clearly proven. The prognosis varies depending on what is the extent of kidney damage that has occurred. And as you can see here, patient who presented with no early and had no treatment had a complete acute kidney necrosis with poor survival of this kidney. And patients who were treated very early with fluid resuscitation had a good decent kidney to survive with. So early fluid resuscitation is the mainstay of the treatment. So outcome varies largely on how you treat on arrival, how you fluid resuscitate, and how you treat the complications which are arising because of the rhabdomyolysis, especially the electrolytes and the acidosis correction. So to conclude, it has a varied etiology. A high index of suspicion is very important to treat or to diagnose the condition on time and to treat the condition on time. The focus should be fluid resuscitation. The consequence is acute renal failure or intrinsic renal failure, which has to be tackled at the right time, and dialysis is as a treatment rather than as a prevention. So thank you very much. And for all the guys, please don't try to make rhabdo very aggressively, because it is a very common condition which can happen if you try that in the gym. Thank you so much. I'm open to questions if any.
How do we prevent it?
So there is no way to prevent it, just good hydration immediately if you're going like in the heat. If you're in the heat and you're forced to do exercise, maintaining a good hydration is the key. There's no really role to prevent the condition of rhabdomyolysis. There's
The morning exercise induced hyponatremia you were talking about, so which you said not to give isotonic fluids.
No, that's a different context, ma'am, altogether. So exercise associated hyponatremia, so you have a high vasopressin level also that time.
Okay.
So this, the urine chart that you mentioned, dilute urine and then concentrated urine, drinking water according to that. So in the new guidelines for exercise associated hyponatremia, there's precisely mentioned not to do that.
not to maintain urine chart. So I think there are two different conditions. I doubt whether they would coexist. But yes, if somebody is aggressively exercising, especially forced to be in the heat for long, maintaining a good hydration with the electrolyte replacement. So it is not just plain water What I would suggest, but maintaining an electrolyte replacement together will probably prevent the hyponatremia as well as the rhabdomyolysis. Or maintain the flushing of the kidneys, rather, I would put it that way. Not that we can grossly prevent the rhabdomyolysis. Yes.
What's the incidence and whether it's dose related or
So it is common in older age groups, the statin-induced rhabdomyolysis, and a lot of old people often do complain of muscle pains after the initiation of the drugs. And if it is ignored, then it can lead to higher levels of CPK levels and the whole consequences or the cycle of rhabdomyolysis. So a lot of patients, especially when they are old patients who are given higher doses of statins, up to 40 milligram, also can have a predisposition to develop muscle breakdown, a high CPK level, and acute kidney injury. So to be very honest, I am in a very poor hospital, rather a resource-limited hospital. So we prefer normal saline, but then if the potassium is normal, I prefer ringer lactate, but because that is the poor balanced fluid that we have for a poor person. But patients who have a very high chloride in their blood, then I switch to balanced crystalloids that we have currently. Isotonic bicarb. So 100 ml of bicarb, no? How much? 75 ml. Okay. Yeah, that is one option that we can use. 5% extra to 75.
So basically regarding the rhabdomyolysis, the most important part for the CRT prospect actually, so it is a medical emergency that we need to realize. The hyperkalemia is so fast and so life-threatening, even with lot of dialysis to try to do dialysis, still the patient has refractory hyperkalemia. So there are centers, particularly in the Australia, I think in Dr. Sanat, there are double CRT machines sometimes they have used with a dialysis rate of 8 liters and they do the dialysis. That is one of the medical emergencies.
Intermittent I was going to comment the same thing.
This is not about the patients who are stable, like patients who are hemodynamically unstable and the patient who are ongoing CRT is there. So those kind of patients with multi-organ failure, like polytrauma with shock, with dual vasopressors, those kind of patients.
But the problem I think there is the life of system.
Yes.
If you don't get the actual life generating the first person out. Yes. So it's very difficult to actually.
So that's why the first index of suspicion is very important. You have to suspect and then you have to treat. Thank you.
Thank you so much.
And just to add one thing, CK is a usual thing that we get as a panel of investigations around values of 5,000, 6,000. If you take 100 patients, 50 of them will be like that, critically patients. So you have to put the context into the kidney functions you not put. So, like, if you find a CK of 3,000 on day one, that's not rhabdomyolysis. Probably there is a little bit of that, but I will cover. You have to have an open mind to look at it first. Second thing, we always see rhabdomyolysis as a kidney failure, but it is a multi-system disorder. If you look at the outcome data, people don't die of renal failure. People die of something else. Either it is a hyperkalemia illness or like a bowel dyspnea or severe shock, which is a multi-system disorder, which is an inflammatory process. It is not similar to sepsis or severe sepsis. So your mind has to be like managing the patient in a multi-system model, because the patient will end up into the ARDs because of resuscitation. The patient will have bowel ischemia because of over-resuscitation, compartment syndrome. All those things happen together. So it's not only about the kidneys.
Right. That's a very important point taken. Right. Thank you.
Thank you, Dr. Chanchlani, for that insightful lecture. Now, I'd like to call Dr. Sanjit Sasidharan to felicitate Dr. Viswa Vikas Mahanti. Also, I'd like to call Dr. Gunadhar Padhi to felicitate Dr. Gunjan Chanchalani.
Our next speaker is Dr. Sanjay Chaudhary, Senior Associate Consultant, Department of Critical Medicine, Transplantation and Internal Medicine at the Florida Mayo Clinic. He is also an Assistant Professor of Medicine at Mayo Clinic College of Medicine and Science. Today, Dr. Sanjay will deliver a lecture on cardiac surgery associated AKI. Over to you.
So this is the point. This is slide change. Next.
Thank you. Good afternoon, everybody. So I have been tasked with delivering a talk on cardiac surgery-associated AKI, and unfortunately it falls right before lunch hour. I hope everybody had a good breakfast and is still in good spirits and ready to go for another half an hour. So first of all, let me congratulate Dr. Sahu and Dr. Gunadhar for putting up this wonderful conference, and it has been an absolute delight for me to be here and learn about different topics that were covered during this session, bringing the two critical care specialties, nephrology and ICU medicine, together. So it's been an absolute privilege for me, and I think you have also enjoyed these sessions. So I don't have any relevant disclosures. This will be the outline for our talk today. And so let me start with a common clinical situation, probably that most of you, the nephrologists, as well as the ICU physicians may encounter, where a patient is being prepared for a cardiac surgery following a recent diagnosis, has got some risk factors for AKI, and certainly does not want his kidneys to get affected and go on dialysis. So how are you going to handle this? So first of all, let's look at the magnitude of the problem. Now, AKI after cardiac surgery is very common, second only to sepsis worldwide. The incidence, if you look at the different studies, it's been reported widely between 5 and 42%, but then again, it also reflects the case mix in the studies. It's in the United States, the number quoted annually is more than 300,000 cardiac surgeries. Of them, 80% utilize cardiopulmonary bypass. Now, with India being number one in population and certainly being number one in cardiac disease, I'm sure we will have a lot more surgeries here in this country. Most importantly, though, it comes with high short-term as well as long-term mortality when AKI complicates cardiac surgery. And not only that, the risk of death persists even after the surgery is over. The subsequent chronic kidney disease and cardiovascular disease being the main culprits. So there are many studies on this topic. One of them was this, published in 2016, which involved adult patients after having isolated coronary artery bypass in northern New England, and they involved 513 patients, and what they found was there was a high incidence of readmission as well as mortality with stage 1 AKI, which increased by many folds if the patients had stage 2 or 3 acute kidney injury. However, most importantly, the cause of all these readmissions as well as the mortalities, it wasn't primary kidney disease. It was all cardiovascular. So it is also points to the nature of the pathology we're dealing with and what leads to the acute kidney injury. So, which brings us to the pathophysiology aspect of AKI following cardiac surgery. So this is a cartoon from the ADKey website, and this is depicting what a post-op or perioperative acute kidney injury is contributed by. So this talks about the AKI, AKD, and CKD continuum that is associated with any perioperative state. And it is, as you know, in the preoperative stage, it's mainly the pre-existing chronic kidney disease, if there is any, the medications. So those are some of the things that are contributing towards the perioperative kidney health. Intraoperatively, though, it is mainly the volume status and the hemodynamics that would come into play, and so would be the situation in the postoperative, in the immediate postoperative state. So all in all, it is probably contributing to decreased blood flow and increased oxygen demand that has been put on by the surgery. So this would apply to most of the perioperative states. Now, if you add the cardiac surgery and the cardiopulmonary bypass, it gets further complicated. Now, you also have the problems with cardiopulmonary bypass and the extracorporeal circulation here, as well as the hemolysis, production of free radicals, not to mention the sympathetic activation, the RAS, also the embolic phenomenon and the direct nephrotoxic effects, as well as the ischemia reperfusion model of acute kidney injury that comes into play. So all of these factors make the acute kidney injury possibility following the cardiopulmonary bypass and cardiac surgery more likely. This is just a diagram of what a cardiopulmonary bypass looks like, and it is also showing you all the cannulae that go into the heart and the circulatory system in a patient who is undergoing cardiopulmonary bypass with the extracorporeal circuit, as well as all these interventions and the hemodynamic perturbations the kidneys go through during this surgery. It is, you can imagine what the kidneys are subjected to and the risks that they go through. This is showing the effects of the cardiopulmonary bypass on the kidneys and the mechanisms by which the cardiopulmonary bypass could potentially cause acute kidney injury. So like depicted here, there are multiple pathways that can potentially lead to AKI following cardiopulmonary bypass surgery. So the patient asks you that, well, the cardiopulmonary bypass seems to be a problem. I have read online, like all the patients are well informed, and Dr. Google is available for everybody to consult. So he reads that if we can stay off the cardiopulmonary bypass and the coronary artery bypass surgery now can be done off pump, so why not do that and maybe protect the kidneys? So what is the evidence for that, right? So that's the question that you as his physician may have to answer. So for the longest time, that was the belief that if the patients are not subjected to cardiopulmonary bypass, then maybe the risks to the kidneys are less. However, those were all case reports and case series involving a small number of patients. There was one of these studies that was conducted involved the coronary trial, which was published, I think, around 2010 or 11 in New England Journal of Medicine, which looked at off-pump versus on-pump surgery for coronary artery bypass. And it involved more than almost 3,000 patients from 16 countries at 63 sites. And this study was a sub-study of the coronary study looking at the acute kidney injury. And they found that within 30 days post-surgery, there was definitely less incidence of AKI if you go by this definition, statistically significant, of course, and also the alternative definitions also a lot of statistically significant numbers. But then if you go on to see how these patients fared over the next year following the surgery, all these differences were not there. So now both the groups of the patients were about the same as far as the outcomes were concerned. Similarly, when they looked at pre-existing chronic kidney disease, again, they found that the loss in kidney function at 1 year, whether you had an eGFR of less than 60 or more than 60 before you underwent the surgery, it did not make a significant difference. So again, they were followed for longer, and at 5 years, again, new renal failure requiring dialysis, not any different in both those groups. So one could conclude that being on pump or off pump doesn't seem to make a difference when it comes to having coronary artery bypass surgery. What probably makes a difference is your surgical skills, the center that is being done, the volume of the cases that they handle, and the perioperative care they receive. So now the patient wants to know what is the risk of getting AKI based on all the things that he has. And how would you answer that? So we do have some clinical models that have been devised to look at identifying these high-risk patients. And they are available online for all of us to access and come up with the estimation of the risk. Some of the common ones, there is the Cleveland Clinic score, there's this META score, and there have been some newer ones as well. In addition to the one that is available on the STS website, that's the Society of Thoracic Surgery, and that gives you the risk of acute kidney injury in addition to many of the other complications that could follow. So renal failure is just one of the risk factors that it looks at. So you could potentially access this website and come up with an estimate. And like is the situation with everything in medicine these days, we have machine learning and AI also coming into play. There have been a lot of small studies looking at that. One of these, this came from Taiwan, involved more than 600 patients who underwent cardiac surgery, and they looked at a model to look at the possibility of AKI incidence. And one of the models, they saw this one ensemble, and there the AUC in the test set was more than 0.85, so pretty reliable. If you look at the other models, their performance actually is not as good as the machine learning model here. But again, this needs further validation, and there are some other studies that are likely to be seen in the next few years. However, they looked at many other variables as to which one of these are more likely to be associated with postoperative AKI. Importantly, though, 14 of the 20 different variables that they looked at were intraoperative. Now, most of the times when we are dealing with these patients, we want to know the risk beforehand. However, if we were to apply these models, this will be intraoperative risk assessment as well as the postoperative care may be guided by this application of this model. The other thing that patient wants to know is, what can I do to reduce my risk of getting AKI? Now, any thoughts? Anybody wants to volunteer? Let's keep everybody awake. Of course, that is always the case. Right. So all the things that we do will not make a difference if you go to a surgeon with historically bad outcomes and at a center with poor postoperative care where they don't have as qualified intensivists that we have here. So not a lot. Staying compliant with medications and probably preoperative holding of the ACE inhibitor ARB would probably be helpful. That being said, we can, from the medical team, we'll have to make some determination as to what are some of the preoperative things that we can do. Anesthesia, and the surgical team will have to look at the intraoperative interventions, and then the intensivists will have to look at the postoperative care. So preoperative risk optimization, these are pretty much what would be considered as best practices. You probably have more time to work on things if you have an elective surgery, less so with the emergency admission for surgery. Nevertheless, if you have an elective admission, then you can look at these interventions, the possibility, and also use a risk prediction score before you get the patient ready. If you have an emergent admission, some of the things that you can potentially look at is make sure that your hemoglobin is optimal in addition to many of the things. Try to see if there is any need for kidney replacement therapy before the surgery that may come into play more often with emergency surgery. Now, intraoperatively, besides, so there will be a lot of need for coordination between the cardiac anesthesiology team as well as the cardiac surgery. But the mainstay of intraoperative management would be maintaining hemodynamic stability during the surgery. And that would be required to maintain renal perfusion pressure and renal blood flow. That would be imperative to prevention of AKI. Now, the MAP target during the surgery is important. If the patient is hypertensive during the surgery, then there is a higher risk of bleeding. Your surgeon would want you to lower the blood pressure. But then you probably don't want the MAP to drop below, let's say, 55 or 60. So that's important. Extremes of volume are more likely to precipitate AKI. Similarly, use of vasopressors and inotropes would be needed to maintain the hemodynamic stability. Now, cardiopulmonary bypass, the longer the cardiopulmonary bypass, there is probably higher risk of AKI. As mentioned earlier, off-pump surgery will probably not protect the kidneys, but again, that's something that is still debated. Maintaining adequate flow is important to maintain, to prevent AKI. Now, there are a lot of, there have been debates in the past about
non-pulsatile flow and its contribution to AKI, but as of now, the evidence does not support that if we have pulsatile flow, there will be any less AKI. However, one thing that has been extensively discussed and has been recommended is to avoid hyperthermia when the patients are rewarmed following cardiopulmonary bypass. As you may know, during the cardiopulmonary bypass, the temperature is dropped, and it is recommended that you should not be rewarming the patient quickly to 37, and because that has been clearly seen in multiple studies to cause higher incidence of AKI. As has been discussed multiple times during the meeting here, we should avoid extremes of fluid, whether it is hypovolemia or hypervolemia. Both can cause AKI. Intraoperative urine output measurement. Again, this has been a topic of interest among many research personnel, but as of now, we don't have any conclusive data to say that if you maintain intraoperative urine output in the desirable range, let's say more than 0.5 ml per kg per hour, that has not been shown to reduce AKI. Now, many of these cardiac surgeries, if they get complicated, they end up having a lot of extra volume on board. And with the modern cardiopulmonary bypass machines, it is most of the centers do have the provision of being able to have cell saver as well as ultrafiltration. Now, if you have that capacity, that is something that you may consider to get the extra volume off. And it has been seen in some case series to reduce the incidence of AKI. Balanced crystalloids is favored, so we have talked about it ad nauseum in the last 1.5 days. Blood transfusion. Again, restrictive transfusion, as with any other medical or surgical patients, would be preferred. But at the same time, you have to maintain the tissue oxygen delivery. So just keep what is recommended elsewhere. So keep it above 7 in most of the patients. And the patient blood management interventions that should be part of most hospitals should be followed. So the patient underwent surgery. He came out. He was extubated 5 hours after he came to your ICU, which was 8 hours ago. Now he's been on and off vasopressin. Previously he was on dobutamine, but that has also been turned off. And his serum creatinine that was sent 6 hours after he came to the ICU was elevated to 1.9, which is an elevation. So he would meet your criteria for AKI based on the serum creatinine elevation. In addition, the urine output in the last 4 hours is also low. So what will you do? Anybody wants to be brave to stand up and give an answer? Any of the trainees? No? Okay. So the question is, are you going to give fluid? Are you going to diurese because the urine output is low? Are you going to, what else can you do? And how will you assess? That's that's a great thought, but Vexus, I think POCUS. Let's start with POCUS, right? Point of care ultrasound would be helpful to start out with. Now, ideally, you would want to take a look at the heart, the IVC, the lungs, see what the volume status looks like. Most of the times, following sternotomy or a coronary artery bypass surgery, you wouldn't be able to get good cardiac windows, so you wouldn't be able to look at the contractility unless you have the ability to do a stat TEE in the ICUs. That being said, VEXUS may come in the future, but when I was putting these slides together, I didn't know a lot about VEXUS. So VEXUS is up and coming. Probably you guys here are well ahead of the 99% of the medical community when it comes to VEXUS in ICU. So the question is, will you give diuresis if I tell you that the patient is 3.5 liters positive since the patient came out of the OR? Since the beginning of the surgery, intraoperatively and postoperatively, with the urine output that he has, the fluid balance is positive 3.5 liters. So will you give diuretic? Sorry? Somebody said something. Right. So like you said, I think that's important, and most of the places would not recommend diuresing at this point on the post-op day 0. Now, again, there may be individual variations, but unless otherwise indicated, diuresis is not a favored approach. And your nephrologist or anybody else would not like to go for Lasix just yet, or even your cardiac surgeon would not prefer to go for diuresis at this time. So we already diagnosed AKI in this patient. We have already talked about the serum creatinine and urine output criteria, but let's move past the serum creatinine and AKI. What about biomarkers to diagnose and treat AKI here or manage AKI? So as we look through some of the biomarkers, we had talked about the stress and damage biomarker, which precede the changes in the functional biomarker, which has been the prevalent practice, looking at the urine output and serum creatinine for the most part to diagnose AKI. But it's about time we looked at the other biomarkers, and the evidence for diagnosis of AKI and management of AKI following cardiac surgery. We have NGAL. There are a lot of papers which have talked about NGAL use following cardiac surgery, but that has fallen out of favor. The current trend is Nephro, which is the tissue inhibitor of metalloproteinase 2 and insulin-like growth factor binding protein 7. So TIMP2 multiplied by the IGF-BP7, also available as Nephro, which I believe a lot of you have access to that. So that may be something to consider. And there are a lot of studies that have looked at AKI biomarker in cardiac surgery that have been published. I won't go through that, but I will just talk about this study that was done as a quality improvement project in one of the hospitals, and since then has caught the fancy of a lot of clinicians managing AKI post-cardiac surgery, and has been gaining wider acceptance. I'm not sure we are ready for prime time, in my opinion, but this is something that is been recommended by many. And so this center, at this center, they did a QI project. They looked at Nephro, urine Nephro, the on post-op day 1 at 5:30 a.m. universally, regardless of whatever time the patient came out of the OR. And depending on the results of the nephro check, UB meaning urine biomarker, they categorized the patients as low positive and high positive. So if the level was 0.3 to 2.0, that was low positive, and more than 0.2 would be high positive. And that would lead to interventions such as if somebody had high positive, acute kidney response team had been formed. There was aggressive hemodynamic monitoring and fluid therapy, and the transfusion threshold was, I would say, lowered to more than 8. So what did they find? So this was their handout that was all around the hospital in the post-cardiac surgery care unit. And they, of course, excluded the patients who had elevated creatinine at baseline. They implemented the KDIGO cardiac surgery bundle. We talked about the bundle yesterday, which involved the other ICU bundles as well. But then, most importantly, it led to more hemodynamic interventions. So in this group of patients, they were targeting a cardiac index of more than 2.5 with a systolic blood pressure of more than 130. So that meant these patients had to have a PA catheter with continuous cardiac output monitoring. In addition, they had the central venous oxygen, mixed venous oxygen saturation target of more than 60%. They treated lactic acid. They were more liberal with the use of echocardiography, and they transfused more to if the cardiac index was low or the mixed venous oxygen saturation was low. So in this study, they were able to lower the stage 2 or 3 AKI by 89%. So this is how it was published in the paper. And they found in this group of patients that with more than 400 patients, almost 50% of the patients, or more than 50% of the patients, had somewhat elevated biomarker level. And with the intervention, they reduced the incidence of moderate to severe AKI by 89%. So the bar in blue is their number before the implementation of the urinary biomarker, and the bar in red is the urinary post-implementation of the biomarker. So with the implementation of acute kidney response team. And this is what they showed. However, as any astute clinician, you should be reading between the lines, and what you can clearly see is the hard outcomes, the post-operative length of stay, the total cost, the mortality, readmission, or even kidney replacement therapy. None of them were affected by implementation of this quality improvement project. That being said, it has made its way to some of the guidelines. And this is the most recent publication from the Society of Thoracic Surgery. This came out earlier this year. So these are the recommendations from them. If I may give my own opinion or editorialize this, I would say that I completely agree with the first 2 or 3, but then the ones below that, I'm not sure I would start phenoldiazepam or any of these mattered. But nevertheless, these are the guidelines. Even the other guideline is the enhanced recovery after surgery from the ERAS recommendation. This guideline also recommends using the kidney stress and interventions to avoid AKI following cardiac surgeries. It is a class 2A recommendation with a level of evidence of BR. So again, not a very strong recommendation, but it is recommended. So so you could use a nephro check. What else can you do post-operatively to prevent or further worsening of AKI? So again, all the interventions that you would normally do in a post-operative care unit would be applicable here. In addition to the possible use of biomarker here. Now, they also have urinary or serum NGAL, but I would personally not endorse that. The others are the prudent medical care in the ICU that would be applicable in these patients as well, in addition to the hemodynamics. Sorry. Volume up. Okay, sorry. In addition, the hemodynamic management is important as well. So maintaining cardiac output and index would be highly suggested. Now, what about if the patient comes out with the use of ECMO or Impella or balloon pump? Definitely these patients are sicker and they are likely to have higher incidence of AKI. We have talked about this in previous lectures. We already talked about the judicious use of IV fluid and diuretic, and mechanical ventilator management again stays the same. When it comes to kidney replacement therapy or dialysis, what's the evidence? Should you be going for CRRT early? Now, it's not uncommon for many places where cardiac surgeons actually put in the dialysis catheter in the OR because they expect the patient to go on kidney replacement therapy. I mean, I don't think that is recommended, and that practice should not be endorsed. That being said, that is an ongoing challenge. Should we be dialyzing these patients early? Because some of us would argue that we want to stay ahead of metabolic disturbances, and others would say you don't need to dialyze them because the patients will recover on their own. These fluctuations are not unexpected. And these questions have been on the back of our minds among the nephrology as well as the intensivists. And we have been served with multiple studies in the last 5 or 10 years, with there have been a barrage of studies that came out to answer this question, and that have been also talked in multiple discussions in the last 1.5 days. I'll briefly mention that the ELAINE trial had a lot of cardiac surgery patients. Because they were 95% were surgical cardiac ICU patients. And this study did show that early initiation of dialysis led to better outcome. That being said, important thing to keep in mind is that the trial fragility index was only 3. So what this means is that if there were 3 more patients in the other arm, the results could have been totally opposite. So I think that is something to keep in mind, and because the other subsequent studies have not shown any benefit of early initiation of kidney replacement therapy. So all in all, the early kidney replacement therapy or RRT is for all practical purposes in 2023 is dead. Now, whether it will rise from the grave, that remains to be seen. As of now, we would consider early initiation of CRRT in these patients resource-intensive and risky intervention. So the answer to the question is that we should avoid unnecessary RRT, and we should not be delaying necessary RRT. So take-home points. Even though this problem has been around for a long time, there haven't been good quality studies. Of course, this is as is true with most of the AKI studies, the heterogeneity of the disease process and the underlying pathology comes to the forefront whenever we try to conduct a good randomized controlled trial. Now, we should be taking preventive measures. The multidisciplinary collaboration is the key, and the hemodynamic optimization is the mainstay of preventive care for AKI in cardiac surgery. When it comes to the kidney replacement therapy, it would be the standard indications. So that's where I'll rest my case, and thank you for your attention. Thank you for staying around in spite of being hungry. Take care. Yes.
Thanks for that. I have a question now. This post-operative lactic acidosis. I'm sure you are reading a lot of calls about correcting lactic acidosis and starting with RRT for the sole indication being lactic acidosis. And maybe some borderline pH. But everything else seems okay. Like normal pressures, normal medical outputs, borderline reactions, and no real indication. How do you think?
So again, lactic acidosis, first of all, there is no indication to dialyze for lactic acidosis. Anion-gap metabolic acidosis, just by itself, you wouldn't be able to correct that with any kind of dialysis. Now, you would have to look into what is causing the lactic acidosis, right? Now, to me, it would be that in a patient who is post-cardiac surgery, you'll have to rule out the possibility of low cardiac output state, because that would be the most likely reason for elevated lactic in a patient who underwent cardiac surgery. So to answer your questions about initiating RRT for lactic acidosis post-cardiac surgery, the answer should be no. I wouldn't be putting that patient on dialysis. You'll probably cause more lactic acid elevation if you put the patient on dialysis. If the pH is a problem, then you could you'll have to see if that pH is causing hemodynamic changes, right? So as you know, nephrologists and cardiac surgeons go to different schools when it comes to acid-base management. So we nephrologists don't correct just the pH of, let's say, 7.32, but for the cardiac surgeon, that's a huge emergency. They want that 7.4. Nothing less than 7.4. So they will throw the base excess and base deficit at you, and they want that corrected right away. And you don't have to unless if the patient is, let's say, having multiple pressors on board. Vasopressor, so your vasopressin is at 0.04, your norepinephrine is at 0.3, and so and the pH is 7.2, and the dobutamine or epinephrine is also running. So in that case, that's a situation where it is suggested that if you improve the pH, the efficacy of the vasopressors and inotropes is better. So that would be a situation where that's how I would handle that kind of situation. Yes?
I'm Dr. Saurabh, the cardiac endocrinologist. So we have seen patients who have ordered the creatinine on board creatinine after surgery, they are more hypogenic. So the intensivist having a discussion, is it advisable to put a phase 2 cable facing wire so that we can take care of the arrhythmia and we take care of the arrhythmia post-op in emergency occurs? Or should we treat and with the situation and avoid this basic models?
It's a great question. Of course, even in the United States, there are a lot of variations when it comes to cardiac surgery and how it is done. I have worked at 3 different hospitals, and each place had a different way how it was practiced. And even now where I work, I have 4 cardiac surgeons, and they each have a different preference. 2 of the 4 routinely put pacing wires in most of their post-cardiac surgery patients. The other 2 don't, unless there's any acute emergent indication to pace. Now, there has been some recommendations about using amiodarone routinely to prevent atrial fibrillation, and there are others who don't actually agree with that approach. So again, I cannot give you a definitive answer, and probably you'll have to work with the surgeons and your intensivists to come up with a plan as to how you want to handle that situation and look at the guidelines, because the guidelines aren't quite there when it comes to this kind of problem. I would say that if somebody is at very high risk of developing atrial fibrillation, then prophylactic amiodarone may be helpful. Now, if somebody has low heart rate during the surgery, has underlying bundle branch blocks before they even underwent, before they underwent to the surgical procedure, then I think it would be advisable to have pacing wires in place beforehand, before they come out of the surgery. All right. Any other questions? No? Okay. Thank you so much for your attention, and thank you for staying around.
Thank you, Dr. Sanjay. That was a wonderful lecture. We can now break out for lunch. The counters are open. We will start our next lecture by 2:45. Thank you.
Thank you very much. Thank you. Am I audible over there at the back? Thank you. So first of all, congratulations to the entire team of Nephro Critical Care Society. And you all have been doing this work for a while, and I think this society doesn't exist anywhere in the world, if I'm not mistaken. This is the only society that does this. Tummy full, mind drifting, it's very difficult after lunch, and it's the worst session to take in a conference after a lunch session. And to start with, there is really no evidence, actually, absolutely no evidence, real hardcore, robust, super, class 1, grade 1 evidence in critical care. There is nothing like that exists per se. And if you look at a systematic review in the past, interventions to prevent hemodynamic instability during renal replacement therapy in critically ill patients, there's really dismal evidence. If you look at it, very limited evidence with respect to any particular intervention's efficacy. So does this mean my talk gets over? No, it doesn't really. Okay, so we could look at much more papers on this to understand whether there's something that we could do in this regards. All right, in this systematic review, there were only 2. All right, so this says very well that this is not a great review to look at and say that there is no evidence per se. And that's why today's topic, hemodynamic instability, how do we do it? That's the question that we have to answer. And are we worried in the first place? Are we worried if we have hemodynamic instability? Oh yes, we are. Why won't we worried? In fact, a study that was done with FAST, where we had 110 US hospitals, we looked at a whole number of blood pressure measurements. And what they did find was those patients who had pressure less than 85 and towards 60 had a higher incidence of acute kidney injury. Okay? They also had higher chances of myocardial infarction, and most importantly, they died. Okay, so less than 65 blood pressure definitely is something that causes the mortality to go up. And when they actually did time-weighted averages, they also found out as small as 5 minutes in patients can also cause acute kidney injury. These are the time-weighted averages that you see on the screen here, and hours of mean arterial pressure less than 65 actually causes an increase in mortality. So it's not wrong when our teachers have taught us keep the blood pressure more than 65 most of the times. And it's this thing that we see in general ICU patients common in CRRT. That's the first question we have to answer. Well, it is very common in CRRT. In fact, among the healthcare records of the United States, when you actually looked at 5 years across United States, what they found out was the first complication that, and the most commonest complication that we had in CRRT was actually hypertension in the first hour. So this is clear that it is not only common in the general ICU patients, it's also common in CRRT. This is very, very clear. And it's as common as in the first hour. 43% of patients, that means 1 in 2, will probably have hypotension. And when it's not only in the United States, this particular data comes from the best investigators all across 23 countries, 23 participating countries. And what they also found was the commonest complication again there, well, it's hypertension again. So definitely that's the reason that I think Dr. Gunadhar and Dr. Sahu has actually asked me to talk about this topic, because it's so common. Well, I tried to look at it in my ICU, and we had a paper that we did a while ago, and we found a very similar result. You know, it was very similar. This is the paper that came out from my ICU, which looked at systemic vascular resistance, stroke volume, and what we did find was in the first 30 minutes, I mean, they said 1 hour, I said in the first 30 minutes, I actually had a drop of stroke volume and a clear drop in the systemic vascular resistance. Of course, there was no change in pulse rate here. Okay, there was no change in pulse rate here. However, there was a change in the systemic vascular resistance and the stroke volume, portending that there is an increased amount of hemodynamic instability. This is a very, very, very large database in Japan. More than 165,000 patients over here. And what they did find was those patients who were actually receiving dopamine, dobutamine, noradrenaline during CRRT, or if they had fluid or blood transfusions, these were those patients who died. So having blood pressure on the lower side is one part of the story, but having blood pressure on the lower side does cause an increase in mortality even if it is CRRT. This is very important for us to understand, that there is also an increase in mortality if you have a low blood pressure, even if you treat it with dopamine, dobutamine and noradrenaline. That means avoidance of all these things is very, very important. So when you say low blood pressure, we're being very general. So what really is the right target? I mean, here is where a lot of autoregulation and targets come in picture, and we really don't know what is the real target. And I think the real target would probably be very, very personalized. I think it's going to be personalized. I mean, if you look at this particular data, 2,290 patients, okay, in the United States, they underwent this particular this study, which actually said that those patients who started with a blood pressure less than 82.7, less than 82.7, their survival was much lesser than those who had a mean arterial pressure of more than 82.7. This is the data. And when they look at logistical regression analysis, somewhere close to 65 is where the magic mark was. And that's why the surviving sepsis guideline definition of keeping blood pressure more than 65 becomes extremely important here. So if you ask me, it's not so easy just looking at a number 65. The target is definitely something that is very, very personalized, because it all depends on the presence of autoregulation in that small organ down there, the kidneys, isn't it? If the autoregulation is intact, it's a different story. If it's not, it's a different story. That's why, obviously, these particular targets have to be personalized. There's no doubt about it. So what is this HIRRT? This is what we are discussing today. Hemodynamic instability during renal replacement therapy is called as HIRRT. In the realm of dialysis, we know this is defined as a drop of blood pressure of more than 20 plus symptoms, or a mean arterial pressure drop of more than 10 millimeters of mercury in the realm of dialysis. Alright, however, we can't really club this in our critically ill patients in CRRT because symptoms are almost non-existent. They're mostly on the ventilators. So it's very difficult to actually club this definition and say this is the definition of CRRT. I think the Nephrology Society of India should actually come up with a definition for this. There is no definition. If you ask what is the definition of HIRRT, the moot question is why? Why does the BP go down? Only if we know why does BP go down, we will be able to understand what to do to prevent it from going down. And for that, there's a whole lot of reasons as to why this would occur. And going from the top to down, it's lighter and lighter, because the lighter reasons are the ones that probably may not be even really remotely connected. So it looks excessive ultrafiltration, temperature alteration, cardiac causes, QDQR related, mode, vasopressor clearance, rapid oncotic shifts, and dialysis blood flow. Let's go to point by point, because each of those points are responsible for actually preventing hemodynamic instability. Well, what is the commonest reason for CRRT? Well, it is fluid overload. There's no doubt about it. That is one of the commonest reasons for actually conducting a CRRT. And we know also that the net ultrafiltration rate would actually determine the intensity of the CRRT, which will actually improve mortality. That means anything more than 25 ml per kilogram, net ultrafiltration would actually be the way to go to improve mortality, is what it is understood very clearly. However, too much of a good thing is never good. Okay, too much of a good thing is never good, and that is the reason that maybe it's the excess ultrafiltration that is actually playing the spoil sport over here. And when we talk about it, how does ultrafiltration, if you're rooming of fluid, how the hell is the blood pressure still getting maintained? Well, it is getting maintained because there is a huge amount of movement from the interstitium and from the intracellular region. That is how the ultrafiltration is preventing, that small amount of ultrafiltration is happening. It is not causing this huge amount of hemodynamic instability. That means the plasma refilling is occurring at a rate that will prevent the hemodynamic instability. So anything that actually prevents that would actually cause this patient to go into hemodynamic embarrassment, is what it appears. That means if I were to increase the amount of ultrafiltration to a very, very large amount, the plasma refilling may not be adequate enough. This is one of the reasons that problems might occur when it looks at it. And that's the reason that we have to identify where this plasma refilling is not occurring. So one of the ways to do that is actually to look at something called as the PVPI. The PVPI is Pulmonary Vascular Permeability Index, and this can be calculated from any of your thermodilation monitors. And if the PVPI shows that it is high, it means that this particular patient is preload dependent and is leaking. This is one of those patients where there is going to be hemodynamic embarrassment. IPPV, when you have intermittent positive pressure ventilation with a high PEEP, there is going to be reduced intrathoracic venous return. This per se on the background of the ultrafiltration may also lead to hemodynamic instability. Being critically ill itself prevents that plasma refilling. They work well. And that's the reason that this ultrafiltration might become a problem over here. And yes, those patients who've got left ventricular hypertrophy and vascular dysfunction, unfortunately, are those patients that will probably have cardiac stunning. And we'll come to that in a few minutes from now, to understand how they cause hemodynamic instability. Well, that's the concept, preload dependence. The concept preload dependence is so important, which actually is defined as a PLR-induced rise of cardiac index that actually predicts the hemodynamic instability. You can actually predict HIRRT by doing a PLR and understanding preload dependence. That's why if you have a patient who's having hemodynamic instability, it's important to prevent it in the first place. But otherwise, if there is, you have to prescribe the UF net very conservatively. That means prescribe the ultrafiltration very conservatively. And if there is preload dependence and there is hemodynamic instability, then probably I will kind of reduce the ultrafiltrate. Otherwise, ultrafiltration is not the cause. Is not the cause of hemodynamic instability, and you'll require a vasopressor. So that's all about excessive ultrafiltration. And let's go to the next talk, which is basically temperature alteration. Oh, cardiac cause. Go to cardiac. All right. So in a study that was done by Slesaraf, 11 CRRT patients were taken. And you'll be surprised to know, only one patient did not have a cardiac problem during CRRT. That means out of 11, 10 patients had got myocardial strain patterns and showing that there was regional wall motion abnormality very similar to stunning of the heart. And out of that, 8 of them had it within a 4-hour window. 8 of them had it within a 4-hour window. It's amazing, isn't it? And surprisingly, this might be the reason that we don't have studies that actually show benefit over intermittent modalities. This might be one of the reasons, is what I feel. Is there something that we can do about it? It looks like the next thing, that is temperature alteration, may be something that can be done in order to prevent this, is what it appears. So this particular data that comes in around 14 years ago has these 10 number of patients who were on CRRT. And what they did find was those patients who were maintained, this is not CRRT, this is hemodialysis, sorry. This is intermittent hemodialysis. What did this show that when they were at 35 degrees temperature, they actually had very less number of unaffected regions in the heart. Very less number of unaffected regions in the heart, indicating that myocardial problems are not occurring or occurring less when the temperature is maintained less. Similarly, you see the ejection fraction also on those patients who are at 35, they are actually on the higher side. And importantly, here down there, the peripheral resistance also is different, indicating very clearly that the blood pressure is higher in the event that the temperature is low. This is the scene with intermittent hemodialysis patients. Now, what's the situation with CRRT? Okay, this intermittent hemodialysis patients has been actually done twice. Okay, this has been done again. Okay, but what about CRRT? Well, CRRT also has the same kind of story. Look at that. The systemic vascular resistance index is higher in those patients who were colder. And in the other study down there, they actually compared 36 degrees, so 36 degrees with a 38 degrees. And what did they find? They found that the systolic blood pressure was higher in those patients whose temperature was maintained at 36 degrees. In fact, the fluid infusion and the use of dopamine and adrenaline that we were talking about in the earlier slide was used much lower in those patients who were kept at a 36 to 36.5 degrees. These findings were replicated in a couple of more subjects. So that's why one of the things that you could probably do is keep them between 35 to 36 on the CRRT. It kind of makes a lot of sense to do this. And what we normally do is we try to keep them 0.5 less than the actual patient temperature. Well, this is the third thing that we went through. Let's look at QD and QR related. Okay, dialysis fluid and replacement fluid related. Does the composition of the dialysate or replacement fluid even matter? I mean, does the sodium make a difference? Does the potassium make a difference? Does calcium or the buffer make a difference? That's the question we need to answer here. What we know now is lactates have negative effects on metabolic parameters, on hemodynamic parameters. The conversion of lactate to bicarbonate, if it is diminished, there's a problem. Liver failure has issues with lactate. Lactate causes an increased protein catabolic rate, and an increase of LP ratio can impair oxygen delivery and left ventricular function. So is bicarb the answer? That's the question. Do we convert to bicarb fluids? So this is one study that came out around 20 years ago, which actually looked at bicarb-based solutions. And they looked at a sick group of individuals. The Purchase scores were quite high, 69 and 51, very well-matched group of patients of CVVH for acute kidney injury. And look at what they used. They used bicarbonate poor and lactate-rich fluids to compare. Okay, and what did they find? Well, they found very clearly, they clearly found that the frequency of cardiovascular events was much lower when you actually use bicarbonate-based solutions, and the mean number of hypotensive episodes were also lower when you actually use bicarbonate-based solutions. It didn't change anything in the outcomes. There were no changes in outcomes, but it did do something like this. It actually kept the hypotension much lower, and cardiovascular events did come down. So I think this is probably one of the answers. It might be something that you could probably use. This was replicated in another 3 more papers. 3 more papers went ahead, and when you have so many papers, you'd like to look at a systematic review. So Cochrane actually went ahead and did a systematic review on this particular topic of bicarb versus lactate-based solutions. And what they did find is that out of these 4 papers that they looked at, bicarbonate-based buffered dialysis solutions reduced cardiovascular complications and hypotensive events. However, these results were only reported by one small study, and that's the study I talked about, 117 patients. Alright, so that I would say this way, that there is absolutely no harm in using it, so why not use it if you want to avoid cardiovascular problems and hypertension. What about calcium and potassium? We know calcium has been one of the beautiful ions that we can use to actually improve hemodynamics and other outcomes. So increasing dialysate calcium may be a viable strategy, but there's a lot of other things that happen. You have the CICA and a lot of other things that's happening on CRRT. So we can't be certain about it because the studies are not well done, and there are not much studies that were done in critically ill CRRT patients. Till then, maybe keeping the calcium at a higher level within normal would be the right answer over here. What about sodium? No data. The data is very great in intermittent hemodialysis when you look at data of sodium, but however it's not great for CRRT. And potassium, there is absolutely zilch data when you look at sodium and potassium. What about these? Mode. Well, I always felt there were different kinds of modes, and these different kinds of modes will probably have different hemodynamic changes, but really there's not much to talk about modes, apart from the fact that if you have patients, so this is the data that says that there is absolutely no change, whatever mode you use on hemodynamics. Apart from this data, we actually looked at middle molecules and larger molecules, where we use convective forms of therapy. There was a removal of interleukin 1, 6, 8, and 10, which are those molecules that might benefit when you have sepsis on the background. So maybe the mode might matter when there is sepsis. Maybe that also is, we need to have more data on this. Maybe convective clearance modes may probably help to take out pro-inflammatory, larger molecular weight mediators. What about the rest? What about vasopressor clearance? This is something that's a technical problem. you tend to put in a central line, and then you put in a dialysis line, and both the lines very close to each other. The venous ports are close to the central line, and you draw off all the vasopressors, which might cause the problems over here. So vasopressor clearance is a technical problem which might cause hemodynamic instability, and nothing, rapid oncotic shifts or dialysis has absolutely no reason, there is no reason to believe that any of these causes hemodynamic instability. So to cut the story short, when you have hemodynamic instability, prevent it by what we just discussed. Use a conservative net ultrafiltration rate. In the event that there is hemodynamic instability, do a preload dependence test and figure out whether it is preload dependent. And if it is so, reduce the ultrafiltrate. Otherwise, probably start a vasopressor is what it looks like. The second thing you'd probably do now with all this that we talked about is to keep the temperature 0.5 degrees less than what the temperature of the patient is, or maybe get to 35 degrees. It's very difficult to do that though. Only change the machine on 35 degrees, but unfortunately the rectal probes actually show you something else. And use bicarb based fluids maybe because it doesn't cause any harm, and there is data that actually says that it may not cause hemodynamic instability. And probably use convective therapies at a faster rate in sepsis. Most of all, optimal monitoring is the answer. I think by the end of today's talk, I've given you something at least that we could do to prevent hemodynamic instability. Thank you very much. Yeah. So if there there have been number of studies that have looked in sepsis where a higher blood pressure has not been better than a lower blood pressure. The sepsis study, there are many studies that have looked at it. And we know that if you start a vasopressor when it's not required and you try to change the elasticity of the vessels, there definitely are problems with respect to mortality. So if it is not required and if you start it prophylactically, probably it may not be a wise thing to do. That's why optimal monitoring in the first 4 hours is probably one of the best things. If 4 hours pass by, then unless you have not treated the disease, if you treat the disease, everything will go on well. Yeah. Yeah, so it depends on what cause you're doing this for. So if you're doing it for just for the sake of control of metabolic control, then probably you may want to give fluids, but if it's for fluid overload, you'd probably not want to do that. No, so that's a $1 million question that we are unable to answer, which is the blood pressure we need to maintain, but at least going by the Surviving Sepsis Campaign guidelines, it doesn't seem wrong to maintain somewhere more than 65. We are doing that. Thank you very much.
I'd like to call Dr. Santanu to present her dissertation on appreciation. Start the next session soon. There's just a technical issue. Dr. Niranjan? Okay.
Thank you, Dr. Sanjit. Moving on to our next speaker, I'd like to invite Dr. Niranjan Panigrahi, MD Anesthesia, FNB Critical Care Medicine, EDIC, FIDM, University of Liverpool, Senior Consultant, Head Corporeal Life Support, Hyderabad.
Good afternoon. Good afternoon.
Slide changer.
Thank you, team Nephro Critical Care. Thank you, Dr. Gunadhar, Dr. Tapas Sahu, and the entire team for inviting me over here. So, after such a extensive discussion, so we'll go into little lighter mode and we'll try to understand how actually it works with patients. Okay. So, no more controversies with the patient. Either you have to use or not to use. Okay. So, you should not be confused with the patient. So I'll start as because I see the ECMO unit in Apollo Hospital, Hyderabad. So this is a real case. We'll be discussing with one of my ECMO patient who went into AKI and how we manage the patient. 58-year patient, weight 90 kg with diabetic, hypertensive, post PTCA. So patient we airlifted from Bhubaneswar to Hyderabad. It's a post-COVID patient. Then patient with history of ARDS, some 7 to 8 days back, patient was on ventilator, came to us for further management. Now, then the real story starts. So patient came with a absolutely fine kidney with good urine output. Now the doctor sitting over in Bhubaneswar, they told ki only lung is the problem. Now go to Hyderabad, probably things will improve. And in Hyderabad, we added one more problem. So that's. Now, patient came to us, we initiated ECMO. So, for respiratory distress, we initiated VV ECMO. Patient was stabilized for 1 or 2 days, patient was fine. Then the story starts on second day. So, patient start having hypotension. So, then we attributed maybe it's an infection. So, it's not uncommon in ICU. Started with some fluids, around 4 to 4.5 liter fluid was given during ECMO, and subsequently we gave near about 1 liter fluid for hypertension with 100% ECMO and 100% ventilator. The patient was there with heparin some around 5,000 units. Patient started developing low urine output. So this is not an uncommon thing. It happens. But if these things happen with a complicated patients, now the story alters. So patient comes, the attendant comes with a mindset that, okay, the problem is there, we'll go for solution, because there should not be new problem added. They cannot accept that thing. So for 6 to 7 hours, the urine output started falling. Now the team tried to try to get an answer, what's happening. ECMO patient, apart from the normal causes, what you see in ICU, like hypertension, drug-induced XYZ or contrast things. So there are certain dedicated set of causes which also can cause AKI in that case, subset of patients. So we stopped sedation, stopped paralysis, patient was conscious. Sometimes we extubated also patient on ECMO. So BP 100/80 with some noradrenaline, some vasopressor going on. Respiratory rate 30 to 40, acceptable for ARDS patient. Bilateral Krebs, abdomen is fine. Now, these are the investigations. TLC 19,000. Even a non-infectious patient in ECMO, also they can have the TLC, sometimes in the range of 20-25,000. That's absolutely fine. Platelet 98,000. That's also acceptable. With a heparin, with circuit consumption, all those things are acceptable. LFT was fine. OTPT, everything was fine. So, then we try to understand what is the DD going on with the patient. So we started from the bottom to top. Okay, always whenever a patient on ECMO with one added circuit, So everybody tries to, starting your nephrologist to the family, they try to blame the ECMO, the circuit and the machine and the ECMO team. Okay. So we started working on that line. So maybe ECMO circuit, maybe the circuit, maybe the consumption, maybe the hemolysis in the circuit, or maybe the heparin, maybe the medication what you are giving for running the ECMO, they sometimes can cause this problem. So try to rule out. Sepsis, always possible. Hemolysis, drugs, contrast. This patient got some contrast in outside hospital for CT scan. Then shock, hypovolemia. So apart from the usual set of causes, so there are this dedicated set of causes which can add to the existing problem. Okay. So till now the patient is in low urine output. Now again, as per the definition, so 6 hour, like the cutoff says, rifle or echin or kidigo, stage 1, whatever you say. So patient was having low urine output for 7 hours. That means it's going to the echin stage 2. Okay. So maintain a mean arterial pressure of 70. Then again the team thought, okay, let's give some fluid. Okay. So another 500 ml fluid was given. By now we have given near about 6.5 liter of fluid. Okay. Now, so here the confusion starts. What to do? So I like to discuss with, like you have already attended 2 days conference. Fluid, further fluid, or diuretic, or RRT. Now, so some can tell, okay, diuretic. Okay, though there is no great evidence. Okay, everybody in this hall may be practicing diuretics. Even we do practice. Okay, so furosemide stress test. How many among you do not practice furosemide or do not give diuretic in AKI patient after resuscitation? Even if there is no evidence, even if all evidences are against, 99% of people, they will try. Okay, there is some evidence. So the same thing. So furosemide stress test or the furosemide challenge test, what we do? The text mention 1 milligram per kg to be given, then monitor the urine output for 4 to 6 hours. If output more than 200 ml per hour for next 2 to 4 hours, they are responders. If less, they are non-responders. Again, the treatment line for responders is different. Treatment line for the non-responders is different. Now, if you are fortunate, then probably your patient will respond. Suppose you are not fortunate, then probably patient may not respond and immediately you have to think of renal replacement therapy. Fortunately, the patient responded. Again, we gave some good news to the attendant. We told, oh, no, it's not a big problem. Okay, there are some kidney issue. We try to address that thing with some fluid, with some diuretic. Now, the urine output is 350, then 400. Okay, super excited. So we told, okay, fine, the kidney is working. So the furosemide test basically it gives you some idea whether some functional glomeruli are there or patient has gone into ATN. Okay, if patient has gone into ATN, then probably the answer will be renal replacement therapy. If patient responds to diuretic, that means still you have some breathing space. We can wait for some more time and further treat the sepsis, remove the drugs causing the AKI or other causes in our patients. So there is some other 4 to 5 so many things like the cannula size, the circuit length, the oxygenator, type of oxygenator, whatever you are using, they all may be sometimes responsible to develop a AKI in that patient. So coming back, now the patient responded, but you can see the trend 400, 300, 200, 120. Now this trend tells us something. Immediately after giving the diuretic, the patient responded, but soon after that the urine output started dripping. That means even if there are some functional glomeruli, but a significant part of the kidney is in intrinsic renal failure, maybe a ATN. So next another 2 to 3 days we try to maintain. Now the patient's urine output again started dipping on the day 5. So this is the day 5 story. Okay. Again, we have to go back to the patient attendant, and again you need to tell that probably right now again the urine output is falling. Okay, now we need to do something. Okay, obviously the attendant will not be happy. The team is, you have to give some solution. Right now again the question comes, should we give more fluid? Should we try different diuretic? So there is some answer for the diuretic resistance. In my previous lecture, they have already answered how to address a diuretic resistance patient. Okay. Or should we go for renal replacement therapy? Now, why we should think so much before starting renal replacement therapy? Had not this patient been on an ECMO, then probably we would have thought immediately to start. Now, ECMO patients are slight tricky patients. Okay. Now, already they will be having two big veins connected to this ECMO machine. Now, you may not have that luxury to use the rest of the veins. Maybe you need to reserve the rest of the veins for the further cannulation or for the line. Okay. Second, some people they say, okay, so we can use the ECMO, so ECMO circuit to take the blood, dialyze and return it. But till now, FDA has not approved to use the ECMO circuit blood for dialysis. Though different units do practice, even we do practice, but it is not as per the FDA. FDA says you need to use the dialysis separately, a parallel circuit, not from the ECMO circuit. So now, in this tricky situation, we can go for urine microscopy or urine electrolyte analysis. Okay, so this can give you some clue or some light in that gray zone. Okay, so if the patient's urine contains coarse granular cast, urine sodium more, urine osmolality is like less than 300, so then probably your kidney is failing. That means this is the high time to go for renal replacement therapy. Now, with these parameters, with the urinary sodium 30, osmolality of 310, so this is the time we need to do. So, without any absolute indication for the renal replacement therapy, this patient fits to go for a dialysis. So, here onwards, you need to write a dialysis prescription for this patient. Okay. Now again, how a dialysis prescription varies. I kept this atypical case because everything is slightly different from a normal patient when we go for dialysis. Okay. Now let's start with the modality. Okay. Now what is the difference in modality? So same CBB, H, HD, HDF, what we are using, we can use the same thing in hemodialysis patients. Probably not exactly right. Okay. Though we extrapolate those data and use here. Usually ECMO circuit or patient with ECMO, even if they are not in sepsis, not in shock, the inflammatory load will be very, very high. The cytokine level will be very, very high. Cytokine comes into the middle molecule or the larger molecules around 50,000 kilodalton. So CBBH, CBBHD is not a reliable way of dialysis in that subset of patients. So here the modality is not decided by the pure patient's profile by virtue of using the extra circuit, extra machine. We have to choose the modality here. Then comes the blood flow. So usually in CRRT, blood flow starts with 80 ml. When the patient is stable hemodynamically, we go up to 150, 200, sometimes 250. Okay. Now, here that's not a big problem, because your ECMO circuit will be throwing a blood at a rate of 3.5 to 5.5 liter per minute. Okay. So we have luxury to use a higher flow or high flux dialysis. So the flow we can, unlike other patients, we can use a higher flow in that patients. Now, where to connect? So that is again one more tricky. So people use in various places in the circuit. Some say, okay, so there is a pump in the ECMO machine or the circuit. Post pump the pressure is high, pre pump the pressure is low. Some argue, okay, take the blood from the post pump and put the dialyzed blood into the pre pump. Some say take from immediately post pump and put in the post oxygenator. But again, the results, they hardly differ where you put. Collection site is fixed, it is after the pump, but when you return it, either you can put in the post oxygenator or in the pre pump, The problem with pre-pump is the pre-pump part of the ECMO circuit is having a very, very, very low pressure. If by mistake also somebody opens it, it can suck air and the patient can die because of air embolism. So we need to be very, very careful while collecting, while you continue your dialysis circuit to the existing circuit. So there is, we need to be very careful about the connection. Next comes dialyzer. Okay, there is no difference between dialyzer in normal versus our patients. So we used the normal dialyzer. Then comes the ultrafiltration target. Again, it is independent of the circuit. It depends upon the patient or the patient's urea nitrogen and what clearance you want to make for the patients. Anticoagulations. So you don't have the luxury to use citrate, or you don't require to use citrate, because already your patient will be in high dose of heparin here. Okay. So many times that can pose a problem also. Okay. Now, the reason is the amount of heparin what is needed for a CRRT is in the range of 500 unit, maybe hardly it's 1,000. The ECMO patient will be receiving hourly 1,000 to 2,000 unit per hour. So it is such a high dose. So anticoagulation again differs a little bit in the patients. Then other blood and blood products, of course, you decide. Then comes the duration of dialysis. That again, it's independent of the circuit. So now coming back to the patient, we choose a modality CBB-HDF. Okay. Now, whenever you use a convective flow, a replacement fluid is must. That's what is taught in all the previous lectures. Without a replacement fluid, we cannot run a convection. Okay. So wherever there is a CVVH or HDF, that means there is a convection, there is fluid loss, we have to give the replacement fluid. Again, so the previous lectures, they told the replacement fluid should be divided equally into pre-membrane and equally to the post-membrane. Now, pre-membrane is not a problem. The post-membrane part of the dialysis circuit is a problem because that enters into a positive circuit. So, the post-membrane replacement is problematic. Here, the replacement will go into pre-membrane. But if you are running the flow at a very low rate, suppose you are running at 1 to 1.5 liter or 2 liter, then you can give equally pre and post. So, these are the some variations, so which was atypical to that patient compared to normally what you do for other patients. So, then he was connected then same way in a post pump and a post oxygenator. We run so these are the things, blood flow, we decided to run at 250. So that luxury you have, you can run at 250 up to 400 flow we can go up to. Then replacement fluids, the calculation came in around 2200 ml. So divided 1000 pre, 1000 post, 200 ml blood, and the effluent dose same irrespective of the machine. So around 20 to 25 ml per kg per hour is the effluent dose, which is probably same as when you run at 30-35. So there is no great difference. So fixed at 25 ml per kg per hour the effluent dose. Blood flow, we started at 150, went up to 250 ml per anticoagulations. Then you started your dialysis. So there are some variation to in terms of the flow, the anticoagulation, and the type of setting what you do in this patient. Now, you started ECMO, you started dialysis, now the patient's bill will go high like a meter. Okay, so already they came with thinking something 30, 40, 50 lakhs. Now you added probably another 50, 70 or 1 lakh per day. Now the attendant will be behind you. Sir, we came from there here not to listen that you told one more problems. Okay, when it is going to be sorted out. Okay, now we need to find an exact time where we will stop the dialysis. Okay, so there is no great objective indication or guideline to tell when to stop, but there are some rough guide. If the patient's urine output is 30 ml per kg per day without diuretics, or it is 40 ml per kg per day with the diuretics, That is one objective indication. Probably across world everybody follow that thing. Apart from that thing, there are so many sophisticated indicators where to stop. The dynamic create clearance. Okay, I don't know how many you will be using in India. Our center, we don't know. Now to calculate that, every third hour you send the urine creatinine and the plasma creatinine. So probably that is a very cumbersome. Then patient's renal recovery, patient's well-being, lung clearance, and you see how the patient is improving clinically. Now, after 13 dialysis episodes, out of that 6 CRRT, some 7 were SLED and hemodialysis. Slowly patient started producing urine. Then we stopped RRT. Then, of course, we discharged the patient with a good urine output. Now, the take home is every patient differs. Now, by virtue of one more circuit, there are so many factors where limited. Your access, your anticoagulation, where do you connect the dialysis circuit, how your flow should be, how your dosing should be. Everything changes. So, because it's like a atypical case, so I wanted everybody to know. So, yeah, thank you. I like to take any question. It's not working. Last few slides were left.
Okay, just I think presentation got disconnected. Done? This one?
Thank you, Dr. Niranjan, for this excellent presentation on some of the interesting case. And now it's time. I would like to introduce Dr. Arindam Kaur. I would say I am honored to have him here. And this is not a general introduction. I specially came to the stage to introduce, I would say, my mentor for my critical care training and education. Whatever I am, I would say that Dr. Kaur is one of the guiding factor for many of us. It's not only me. So he's the current chief intensivist at Sir H.N. Reliance Foundation Hospital, Mumbai. One of the forefront in taking critical care to the next level in India as well as abroad. Thank you, Dr. Kaur, for accepting the invitation.
Just a second, I will just
We had a deferred lunch or something? Little late lunch? Yeah. Okay. So, very difficult time to speak actually. Everyone, all your blood circulation is diverted into the GI system, not kidney. Kidneys can be anyway, you're hypoxic at that level. So, brain hypoxia, other organs hypoxia, and obviously. And also when you have a tropic like dialyte trauma, right, it's very difficult to make people sort of attentive to it. And in fact, the first time, I think Shantanu is here. Yeah, Shantanu and me wrote a chapter on this, I think way back in 2020, 1920, something of that sort. No, not 19/20, not 1920. I got the joke. So we thought that whether this is trauma happening to a patient going for dialysis. So something of that sort. So patient going for a dialysis center towards and then met with the RTA, and that is dialyte trauma. Initially we thought that. Then when we read about it, and then we came to know that this is something on the analogy of what we call your ventilator-induced injuries or something of that. So we can colloquially say dialysis-induced injury, but not specific to the kidneys, but it could cause a lot of So my statutory disclaimer most of the times that I'm not a nephrologist or a basic researcher, but I am a intensive care practitioner with a good we can say varied experience over 2 decades now, and maybe you can call me, I've mellowed down with age, but the adventurous part is still there. So I do take a lot of good inspiration. So this is what anyone can tell. I've tried to make, because most of the times to get a good lecture or to captivate the audience, you have to build up your PPTs depending upon that what slot you get. If you are in the morning slot, you are very serious on that part. But if you are post-prandial slots, right, you have to connect to the audience in that way. You have to have a good chit-chat with them. You have to speak to them, talk to them, reach out and all others. Anyone can tell? Gunjan? But then this is not about the sugar. This is how you adopt newer things, adopt concepts, adopt technology. It's called Bell's adoption curve. Right. So someone who is super enthusiast, maybe like me, and very Sanjit is, and we are the enthusiast guys. So if anything new comes, we jump into it, right? So we are in this part. And some people could be, you can say, skeptics who are the last to adopt sort of way. So this is a very interesting slide, and that too. So this concept of dialyte trauma, you may or may not accept, because it is not that old one. It's only the first. It was in 2014 or 15 by a Spanish nephrologist. So you try to find out which part you are in the Bell's adoption curve. And I will try to keep shorter so that we fall within your attention span itself. So CRRT is obviously now the leading form, depending upon, obviously, we still are managing the indigenous jugaad by extending SLED. But if you say that CRRT is the predominant form in developed countries, and it is slowly picking up, provided the cost goes down, right? There are practice variations in the application of it. And we know that the dosage, I will come to that, it should be around 25 to 30 at the max, and adjusting for the downtime and all others. And it is the most appropriate therapy for vasopressor dependent patients, and obviously 2 specific indications, ALF and traumatic brain injury, because of you do not want the osmolar shift to be there because of the cerebral edema. So in those cases, if you need dialysis, CRRT is the choice. A number of aspects of CRRT require a further detailed analytics and research, particularly the threshold timing, and obviously how to prevent dialyte trauma. And obviously, as I told you, the cost is one of the most So these are the issues. Dose, we know that 25-30 is good for day, unless you are specifically looking into high volume hemofiltration or where you need more convective clearance, like having a higher lactate. We know that it is better in hemodynamically unstable patients, as I told you. Timing is still unresolved, right, and early or late. I think it's like some of the controversies which would never end, in whether to use albumin, whether steroids. We will always, otherwise how can we come for lectures and meet you guys, right? So some controversies would be always present on that part. CRRT outcomes, with more and more understanding, we know that it's helpful, and it can be utilized for in many different ways. And modalities are also unresolved, because now more complex. Previously it was plain, then it was hybrid, now hybrid. I think these were all covered, right, Tapas? These are more or less all covered, so it's still an unresolved issue. But one thing had happened. If you see, this is This is almost 12 years of study from Taiwan itself, entire Taiwan. If you see in this study what they have shown, that the mortality out of AKI patients receiving CRRT has improved over time, over a decade time. So that means that maybe our understanding and application both has improved, understanding of the AKI and application of the RRT itself. And if you see the predictors for short-term weaning, so now that you have saved the patient, whether he had been able to wean off from the renal replacement therapy, and what are the predictors, there we have seen that the sedation is, the three predictors were important. One was the existence of CKD itself, the urine output at the cessation of the RRT, how much it was, and also the creatinine, the baseline creatinine what we started. This was an interesting slide on the mortality. So this is pure, these are your predictors, independent predictors of mortality in patients in AKI requiring RRT. These are use of catecholamine and others. But this one was very important or interesting, is that mortality was higher in a lower Apache 2 score patients. That means unexpectedly patients who were coined according to the Apache 2 classification, that low risk patients, if they develop AKI, they have a higher risk compared to the higher Apache patients. So that means apparently well patients, lesser sick patients were having more mortality on this. So this is a little interesting finding that they have, and it has been also been found in many of the subsequent studies itself. Oh, sorry. Yep, this is another one. I think just to mention that the median delivered, as we know, that people stuck to it. This is around 500 patients from Dina Cruz, is a very good guy who has led the Doremi study group. They have done a lot of work on AKI itself. And only 22% of the patients actually got an intensive dose. Mostly patients has got a moderate dose or the standard dose. And crude mortality was around 60% in CRRT and 24% in intermittent RRT. So this makes sense because obviously you will do CRRT in more sicker patients, unstable patients itself, right? And but on multivariate analysis, when you adjust for the sickness of the patient, there were no significant association between the dose and mortality itself, right? So if properly applied, both can be safer on that part. But among survivors, a shorter ICU stay and a shorter duration of ventilation were observed on a more intensive dosing in the CRRT. And I will come why these slides are important for a sort of a. And lastly, before I come to dialyte trauma, so less is more we know, but how much less? So this is the dosing curve. So when we started in 80s, right, those doses went up. So you see, up to 40s it went up. In fact, where they used to call it the Ronco dose, because Claudia Ronco used to give this much of dose on that part, and giving 40, 50 ml per kg per hour was almost a standard. It was a sin to us that whether to give this much of dose. People, it was almost like an universal truth itself. Till the time in the first 2008 trial in NEGM published, and it showed that higher dose of dialysis is actually non-beneficial and it was giving counterproductive results when we looked into it in detail itself. And that's where the first concept of dialysis trauma came. Same analogy, if you remember in 96 to 99, multiple trials came from all over the world about the ventilation. Suppose you remember, right, from Brazil, from Italy and from Canada. Tapas has worked in Canada. Slutsky has one of the lung labs, right, where you do video microscopy. They put microscopic video in the alveoli to see how the higher tidal volumes are actually damaging the alveoli itself. So in 96 to 99, they came up with the idea of ventilator-induced lung injuries. What is the volute trauma itself? So first when your 2008 trial came, we came to know the concept of dialyte trauma itself, right? So these are the complications associated with CRRT. I might take 2 to 5 minutes extra. I'm trying to make it little interesting in that sense, and I'm trying to see how many people are sleeping. It seems to be that I'm being able to keep you awake on that part. Okay, so this is a CRRT cycle, right? The initiation and outlines goals of therapy. So if you initiate, you have to put a line. And the first thing the complications can happen is due to the line related, the access related. Then you have to maintain the line as well as the circuitry and others. So there could be a lot of problems like electrolyte imbalances, hematology, nutritional. I will showcase on one of the complications itself. Then you have euglycemic ketosis, cardiac stunning, the hypothermia, deconditioning, muscle deconditioning, and one of the most important component of dialite trauma is the drug clearance, accentuated drug clearance, because you have a higher dosage, higher convective flows and higher clearance of the drug. And then when you try to wean off, then particularly late complications of the vascular access, mind it, these are the most of the access are long standing. Many of the people may have your permacats, right? So they are all your CRBSIs or embolization or all other blockade problems would be there. But also we can have a complication which is surprisingly or uniquely more common in dialytic patients is AR embolism. And I think 2 of my colleagues are here. We just had detected an AR embolism, I think 2-3 days back. I will showcase you the photos itself, right? So these are your major complications of CRRT: electrolyte, drug clearance, nutritional, physical deconditioning, volume overload or volume related, also cardiac stunning, hypothermia, hematological complications, and the vascular access related complications itself, right? So you can have those slides. Unfortunately, I have not given up my Sanjeet slides, Dr. Sanjeet ... right? So you can have it from me. And also I couldn't have I told Sanjeet, I'm taking your permission that I will mention this. He has got a lovely accent, and the accent accentuates when he is on the stage. Unfortunately, I do not have that UK accent, but anyway, I hope I can still manage the part. So you can take these slides. These slides are very useful, sort of that what to deal with. These are all basic critical care stuff. I'm not going into that, the longer list, but let's see the incidences. You see, these are the incidents. This is over what we call the serious adverse events, right? That particularly the major hypotension or arrhythmia or arterial puncture or bleeding, right? So these were the serious adverse events, and it was close to around 10 to 60% at instances. So if you take all together itself, so the incidents are not so less, it's rather quite high. Particularly if you see the incidences of your the electrolyte imbalance, particularly the hypocalcemia, and both hypo and hyperkalemia were quite high. So despite whatever our understanding, there are significant hemodynamic, mechanical and biochemical complications of RRT itself. So this guy, this Maynard Molinar and Honoro, right? These are all 2 friends from Barcelona, France itself, and they started and Honoro is he's from Malaga, and Honoro is from Belgium itself. They coined the term of dialite trauma first time in 2012, I think, if I'm not mistaken. Yes, 12. They published parallelly in Angium and Blood Purification Journal, and there they first came out with the concept of dialite trauma. Right, so they are saying that this is a newly proposed concept that encompasses all the harmful adverse event related to CRRT, particularly CRRT, while providing a framework for prevention or at least early recognition of these events in order to attenuate the consequences. A mainstay of this approach is the utilization of dedicated checklists for improving CRRT quality and patient safety. And also you need to understand why they have specified only CRRT, because these are what they call ICU nephrologists. So nephrology who visits ICU and take care of that part. There is a very clear demarcation. First 2 weeks, mostly intensivist will manage the renal replacement therapy, right? They don't even call nephrologists to come and see. Right? I think Sanand, would you like to comment?
Yes, it will be a good
Mike, you can, yep. See, this is the practice. Here you cannot even start dialysis without involving a nephrologist, right? Yeah.
It will be a fortune when you see a nephrologist in ICU. That's it. And only when we transfer the patient to intermittent,
Right.
go into the ward, then only we ask them to.
Or your patient, you cannot win off the patient. You are thinking of maybe that it would require a long-term dialytic therapy. Then you involve a nephrologist itself. So these are where the rare ICU nephrologists, right? And most of the times the ICU modality is CRRT because the financial issues are in developed countries are not that prohibitive in that sense. So that's why most of the dilated trauma, in fact, the other name for dilated trauma is CRRT trauma itself. But I think principally these are same except in one difference. So the outcome may not depend of any intervention. The outcome may not depend only on the efficacy of the organ support, but also on the side effects and morbidity related to that support itself, right? So if you have a very effective organ support, but the very high rates of complications, will you adopt it? I don't think so, right? Because it has to match up, that your intended benefit must have to be much more than the unintended harm, right? So that's the basic rule for any of the organ support itself, right? So this is the concept of dialite trauma. Then I will show you that there are correlation between the hemofiltration dose and frequency and magnitude of such losses, all of them being potentially harmful if not timely recognized and corrected. And CRRT trauma or dialite trauma encompasses acid-base disorders, but also loss of heat, electrolytes, nutrition, particularly carbohydrates and nitrogen, loss of water-soluble vitamins, trace elements, and particularly antibiotics. So why? Because if you are giving more convections, so a lot of these important molecules are also lost. So in CRRT, what you want to do? You want to take out the solutes, which are not good for the body. But what you are inadvertently doing, you are also taking out these molecules which are important for your body, right? So if you don't preserve them or replace them, right, there are going to be an undesirable effects, and that is the concept of dialite trauma, besides the other complications also. Septic patients are specific high-risk group. They generally receive a higher CRRT dose because you want to remove the middle molecules, that means the inflammatory cytokines. Often have depleted both macro and micronutrient store. So smaller loss of micronutrients can have exaggerated effects, and worsening of the septic process when antimicrobials become underdosed. That means you are continuing with the dose of renal failure, and now you start CRRT and you don't increase the dosage itself. So what would happen? Whatever lesser dose you were giving, they will be out through the CRRT, and the patient would be severely underdosed. And the patient won't survive by CRRT. The patient would have survived by proper antibiotic and that too on a proper dosage. Right? CRRT will buy you time. It's not going to sort of deal with the infection itself. If a septic patient, your mainstay is to give antibiotics itself. And see what happens. So this is a concept of dialite trauma, say in short. And so these are also the arterial hypotension and all others, all hemorrhagic complications and others, but mostly this is the checklist. And that's why you have an inverse relationship between survival difference of high dose, low dose RRT, right? So in a higher dose, see the survival this is sepsis prevalence, and this is the Ronco dosage, and these were the other doses. So what happened? It was sort of a bell-shaped. If you have give very low, below 15, the survival was bad. You are giving on the 25 to 35, the survival is the best. But when you go above 35, you have got a very poor survival, because now you are removing most of the important molecules and antibiotics out of the system itself. So that's an NA. But there is also one theory is called that whether with higher clearance, with higher dosage, higher convections, what would happen, many of the molecules will go and stuck to the flux, the membrane of the dialyzer itself, high flux dialyzer, and they create what we call a protein cake layers, and that reduces the efficacy of the membrane itself, the dialysis process itself. So what happens, initially it is good, but then the convective clearance goes down, and your middle molecules, that means what we call the inflammatory cytokines on NA, the clearance goes down. So the efficacy of the dialysis goes down. And if you have a higher dosage of that convective clearance, quicker is your dialytic membrane getting blocked with those protein molecules. Okay? Can I be able to explain it? Anyone, Sanant, you want to explain any further or add a comment on it? Yep.
I think that's a practical issue. When you run the dialysis dose very high, you tend to block the filter very quickly.
Yes.
And you have
Do you use citrate on that part in Australia?
Yes. All of them are citrate unless we are having some.
So that's a big difference. You see that if you are using heparin, this blockade of the membranes are not very effectively done. But if you are using citrate itself, right, you see what he said, that unless specified, it is by default regional citrate anticoagulation, because they can effectively prevent this clogging of the dialysis membrane. Yep. And also, if you see that if there is low phosphate, this is a very practical tip I'm giving you, not these guys have given, that if you have a low phosphate, that means your dialysis dose is inappropriate. That means you are clearing more molecules actually than required. So if you have a persistent lower phosphate, that means your practice of dialysis is not that way. And regarding the antibiotic dosage, these are the factors that predict the clearance of the pharmacokinetics while on RRT. I'll very quickly say that what we do is that we actually give on a higher dose. And we also consider that on an CRRT, the dosage has to be a little bit of the supranormal. So if you are interested, I think we have a lecture on drug clearance. I'm not going into that. So the basic funda is that you have to give higher dose, and in particularly the drugs which are cleared by kidneys itself, here you are replacing the function of the kidney itself, you may go for what we call a therapeutic drug monitoring. Again, Sanant, are you doing regularly, or there's a costly?
Only for vancomycin.
Maybe aminoglycosides if you are here.
So there is a fixed regime in Australia, 3 doses of aminoglycoside and that's it. If you need to give more than that, you have to have therapeutic drug monitoring, which we usually don't go for.
Okay, but vancomycin you are regularly doing. And obviously for other like your tacrolimus and your anticonvulsant drugs and all others. So initially, when I think 5-8 years before, it was very difficult. I think it is quite in Mumbai now. We get quicker. Gunjan, do you get quicker results for therapeutic drug monitoring whenever you send? 24 to 48 hours on that part. Okay, so these are the drug dosing approach. You will look into that. So, but the rule of thumb is that you have to give higher, and nowadays initially those dosing were not inserted on the package and the internates were also not there, but now you can find out a lot of way, and Sanford has also included the drug, particularly antimicrobial drug dosing, what would be during CRRT, that is also given itself. But here an interest concept is there. This is a very important slide. I want you to have a little bit of focus. Is that initially when we was not understanding that CRRT is removing more of the antibiotics, so we were underdosing. But now when we understand this concept, why not take advantage of it? That means this is a situation where आप दिल खोल के बैटिंग कर सकते हो. You can give a higher dose of antibiotics more confidently, because now you can achieve a supranormal therapeutic concentration without harming anymore. Because if your body is functioning more than your native kidneys itself. It is removing more drugs. So that's the funda itself, that now you have a better proposition to give your full dosage of antibiotics, which you wouldn't have dared with the native kidney itself. Okay, so that's the concept itself. So I'm not getting into that. You guys can look into it. There is the nutrition and metabolic alterations. There is a new concept also coming, the concept of nutri-trauma along with dialyte trauma. Because if you are giving more nutrition, what are the harm it can cause, right? So that you have to prevent. These are your certain these are your checklist into that and all others. So you can take this and this is the quality parameters to ensure that the RRT program is optimally functioning. You can have your AKI pathway. We are trying to start that. You can have these parameters checked in, and these are your the feedbacks for your filter functionality, then how your average filter life is, how less is your downtime. That means your CRRT is functioning 24/7 and all others. So these are all your parameters for what we call that whether your program is working well, right? We all know that structure, process and outcome parameters, right? Donabedian concept on that part. And these are your some rare complications or dialyte trauma can also happen from the water itself and some mechanical aid. So maybe a good program, and this is a prerogative of a nephrologist, to look into that, the water purification, the RO component, the circuitry, the connections, the infection control, all those things has to be also optimal to have a good outcome of it. Vascular access, these are all standard processes that we all know. But venous air embolism, right? So please look into that. This is a very dreadful as well as almost 100% fatal complications, and this particularly happens mostly when you are trying to take it out. So there are standard processes and checklists or that how to strategies, how to put, not only how to put line but how to take out line. So that is also very important. Intradialytic hypotension, Sanjeev was speaking about, one of the most common happening in during both intermittent and CRRT itself. So I will ask you to only read about a concept called sodium profiling, that how you can use sodium profiling, which is integrated into the software of all the newer dialytic machines, and how you can sort of play with your thermostat by reducing the core temperature itself, how you can prevent hypotension in a dialytic patient. You please read about that, right? And regarding temperature, there are incidences of severe hypothermia. I think my colleague Reshma is there. You remember that we had a 29 degrees centigrade temperature itself on a patient on CRRT. So despite everything, at times there can be dangerous hypothermia itself. So these are the 10 commandments. I'm not going to that. This is the book that we had this publication itself. So I'm open for questions itself, right? And there would be times that a rational withholding of enthusiasm will provide gains for the critically ill. So that's the concept of less is more, less is better. That sometimes you have to hold your horses, think about, be rational and do less but still do better for the patient itself. Thank you. Any idea of this one? These are classifications of the delegates in any conference. Some are freeloaders, some are outstanding, right? Then stalwarts and all others. This is a little bit. One concept is called age of the rumors. Someone who is always standing and doing that. This is disruptives. Someone who is always asking questions, right? Disruptives. And one is the anxious one, the nail biters. Maybe he is next on the line to give lectures. Easy riders, someone who goes everywhere, is free all through the thing. Then one of the best well-dressed, preferably girls, that we call the social butterflies. So no references, please. So this is the newer classifications of the delegation itself. Thank you for your time. You have a question?
Dialytic trauma is same if you use the filter
filter like the extracorporeal cytokine removal filter with the CRRT? Is the incidence same, or is there any reduction in the?
It's a difficult question because Gunu said it very quickly. I have to find it out. Yeah.
So the incidence of diuretic trauma remains same if you use the extracorporeal removal filter with the CRRT machine. Studies on that?
No, I haven't come across through
because
principle.
Yeah, what the concept you told, it was very interesting because once you remove all those inflammatory mediators and cytokines, the filter don't get clogged and the life is prolonged.
Now, I said the concept is that your idea is to remove the mid-range molecules itself, which are inflammatory cytokines, but also in that range you have number of other important molecules in the body which needs to be retained. So you are losing them also. So how to be selectively losing the inflammatory ones and retaining the pro-inflammatory ones or the beneficial ones. So that's the major A. Only way we have tried to adjust with the positive, negative or cation anions and all those combinations and others. You know that in many of those cytosorbs or the Torres and all others, they also have tried to put the charged anions or cations itself so that they can repel unimportant ions into the body system and they can filter out and others. But I will look into it. I have not come across on that part. Yes, we can play with the flux of the membrane, the pore size or the pore diameters, but most important is the dose and duration. Because more the dose, more the loss, more the duration, more the loss. So either you have to be careful or change this, which is a difficult one, but the more easier one is to be aware of this condition and replace whatever you are losing, particularly the important. Sanand, you want to?
Yeah, so you touched the right point, the duration actually. So it is seen that the middle molecules are more cleared if you run it for a longer period of time, and you start to lose albumin and every important things if the duration is prolonged. So that's one of the demerit of CRRT. The second one talked about the phosphate, which is really important because in clinical practice in our unit also we look at phosphate very diligently, because if you have low phosphate then you're overdoing things and you're harming the patient. Not only because you're clearing things, but also it makes the patient weak. First of all, one, it increases the duration on the ventilator. That's a practical thing. You will see the patients feel worse after the dialysis compared to before the dialysis. Very quick response to the dialysis you can see there. So that's an important thing to look at. And we have seen, there was a slide earlier which showed that there is a cardiomyopathy.
Yes.
So,
cardiac stunning.
And practically it may be related to the low phosphate actually. If you replace the phosphate, sometimes the blood pressure gets better, their cardiac functions get better. So few of the things we don't know how we can harm the patient with just dialysis or CRRT, but there is evidence clinically. If you look, they feel worse after dialysis. Then once the phosphate is replaced, with time they get better again. So prudent mention of the phosphate levels, it is very important.
Thank you, Dr. Arindam. Our next speaker is Dr. Bharat Jagiasi, Director Critical Care Medicine, Kokilaben Dhirubhai Ambani Hospital, Mumbai. He is the Secretary of Indian Society of Critical Care Medicine, Mumbai. He has also authored various chapters in books of critical care medicine and has been on review board for several medical journals. He was honored with President Citation Award for 3 consecutive years and Mumbai's Young Talent Award in the year 2013 by ISCCM. He will take a session on albumin and diuretic in AKI. Over to you.
Thank you for the kind introduction, and thank you whole team, Tapas, Gunatha, everyone for having me over here. So I thought there's one more talk. I was planning to have a tea with Sanjit, but it was planned that way. So bye, Sanjit. Yeah. So before we start, as the talk is, as you all know, it's diuretics and albumin in AKI patients. So it could be the easily thing I can just go through the slides and tell you this should be done this way, this shouldn't be done this way, but I have made it interesting. As Dr. Arindam said, this is the time when you involve the crowd and you get it from the crowd. If it was a morning session, it would have been a different slide altogether. So if you look at this, we'll go through it. So we'll start with it now. So diuretics are commonly used in critically ill patients, as we all know, and especially when there's an AKI and a fluid overload. So there could be the distinct varied dialysis, right, from acetazolamide to toloptan, what we've been using, and the most commonly that is being used is the furosemide. We all know that in almost 90% of the patients. All agree with that? Yes. But the problem in the ICU is heterogeneity. I mean, it's totally different patients. So there will be a patient with the hepatorenal syndrome having different pathophysiology, patient with the cardiorenal syndrome with different pathophysiology, trauma patient totally different pathophysiology, sepsis, no one knows what the pathology is as of now. So this is how we have the different set of the patients. So we cannot be using a rule one. Yes, we should be using furosemide in one case of patient, and we should be using albumin in different set of, in a same set of the patients as well. So we have to identify, we have to look at what exactly they do and why are we using it. Looking at the pathophysiology, then only we can decide whether we should be using for the certain set of the patients or not. And this is actually true for all the patients. So if you see publication in the last 20 years focused on the AKI due to the hypotension. Initially we thought hypotension is the only cause of the AKI, though no one knows what the real right BP is. But still people said hypotension causes AKI. But now we know AKI is not actually because of only hypotension. It's a complex syndrome and it's because of the very thing. With sepsis, something else plays a role. Rhabdomyolysis, something else plays a role. There are some nephrotoxic drugs. So it's not hypotension actually causing it. So it's been common practice in ICU to give fluid. So always when there's a hypotension, fluid. Oliguria, no one understands. 50 chal raha tha, output 30 ho gaya, fluid. Creatinine 0.9 का 1 point हो गया, fluid. So this is why we have learned to give fluid, selected higher fluid. So first trigger, first reflex is always being a fluid for us. And this practice was reinforced by the reverse study. Early goal directed therapy 2004 में sepsis guideline took over it. पूरे जगह में famous हो गया sepsis guideline. Everyone started pumping in the fluids. And though it's been proved by major RCTs thrice that no, giving extra fluids is not right, but still we continue to give it. The reason being it's easy to learn in our society, but it's very difficult to de-learn. So we have learned to give fluids, but it's not important. We are not able to de-learn it not to give fluids. So this is what is causing a problem. And liberal fluid is also causing a congestion. So it's been a number one enemy in the ICU in 2016. This is what we know. It increases the problem. Patient gets difficult to wean. Fluid, in fact, increases the AKI. This is also what has been proven. So since a number of observational studies have consistently shown that a positive fluid balance is an independent risk factor. It's a different thing. By giving fluids a positive balance doesn't cause harm, but that's an indicator of a mortality. So it's an independent indicator. So if patients requiring lots of positive balance over a period of few days, that means this patient is not doing well. It's not because you're giving fluids and he's not doing well. It's an indicator, like we do procalcitonin. It's high, that means patient is infection. Not because the procalcitonin is high, there's an infection. So positive fluid balance over a period of certain days indicates patient is not doing well, whatever could be the reason. So especially the one with AKI, with high central venous pressure, and surrogate markers of other inflammatory disease. Those are the patients really you need to look into. And ultrasound is proven into it. We have the access score which shows association between the systemic congestion and the AKI. Now furosemide is the most commonly used drug in the critical care patients. So this is why most studies in the critically ill patients among the diuretics are done on the furosemide patient, are done with the furosemides. So now when you look into the fluid bolus diuretic use and mortality in acute kidney, this is what Morgan Graham said. So what they did is, there was a fact trial. So fact trial actually was not done for this. It was done for some other reason. So they randomized, it was done for the liberal versus the restrictive fluid. That is what the fact trial is, which proved that restrictive fluid was better than the liberal fluid strategy. So they took the 1,000 patients from the fact trial and they found out the patient having AKI. So they used the Akin criteria. And now in those 1,000 patients, they found around 306 patients which fit into the Akin criteria. And they said, yeah, these are the patients who are having AKI. So there were two different groups amongst liberal group and restricted group. What conclusion they made was, a positive fluid balance after AKI was strongly associated with the mortality. And the patient who received furosemide post AKI had a better outcome. So they kind of said in a subgroup analysis, patient who received furosemide is doing well. So if you look into this, can I have the pointer here? So if you look into this, there are various stages they looked into. This is liberal fluid and restrictive fluid, and around 306 patients were used. So 7 days of the creatinine was more in the liberal fluid than the restrictive fluid. Dialysis within the 7 days was more in the liberal fluid than the restrictive. And the mortality, if you see, this is how it is. So this is what they came up with. Post AKI furosemide had a protective effect on the 60-day mortality. And patient who had higher furosemide dose was negatively associated with mortality. So this is what they said. They said maybe the furosemide who received is better in a ICU patients. Now came the another one, Picard study. This is also very well known, and Picard study was very clear in that population who received diuretic use was associated with significant mortality. So it was bang opposite what the other study of Morgan proved it. So Morgan was a subgroup analysis. Subgroup analysis are always not to be taken to be seriously. For example, if I was doing a certain study saying fluid given in a patient. So we did a fluid given in a patient, and I realized a patient who received fluid A did better and patient received fluid B didn't do well. Then I do the subgroup analysis looking at those set of the patients. One was in trauma, one was in emergency, one was in ICU. So I would say more patient died in ICU. That is what the subgroup analysis was. But that is not right. Obviously, trauma guy shifted the patient to the ICU, didn't do well, and after 2 days died. Doesn't mean that ICU was bad. So this is how the subgroup analysis works. Subgroup analysis always never give you the dictate that this is how it gives you an idea, you should work it out. Then I'll work it out and saying, yes, I'll study the patients in trauma and I'll study the patients in ICU unit. So subgroup analysis is always not a dictum. So there it was a subgroup analysis, this is different. So now recommendation, these are very clear. From the crushed rhabdomyolysis, we all know there's a CAS form. So if we use loop diuretics, then it induces AKI. Dr. Gunjan must have spoken on that. So this is very clear over here. Then meta-analysis came in. So I'm sorry. Meta-analysis came in. So meta-analysis, what always we have a different set of studies. So one has 100 patients, another has 200 patients. We combined all that and we look into the set of patients, heterogeneity of patients, and we come with an answer. So meta-analysis said, initial one, it included 6 studies where the furosemide was used in this dose. Look at the dose, 600 milligram to 3400 milligram per day. When used as a preventive or therapeutic drug. So there are guys who also use as a preventive drug empirically, didn't reduce the risk of requiring renal replacement therapy or hospital mortality. So this is why it should. So meta-analysis are taken more seriously than the other IRCTs because they are combination of RCTs and they take up all the heterogeneity. But the problem in meta-analysis is one. Suppose one study with the 100 patient proved something and another study with 1000 patients proved something else. So obviously the data will be skewed towards the 1000 number of patients because it takes an average out of it. Then Sampath and all also proved it. Loop, it was again a Bayesian evidence, it's a kind of meta-analysis. So they said loop diuretics were not associated with improved survival. So now one study showed yes, then another one said no. Meta-analysis said it's neither harmful nor helpful. There was no change in the mortality, there was no change in the outcome of the patient. So again we look into the one more bigger meta-analysis which are 20 RCTs. It's quite good. 20 RCTs, 2,600 patients. So they said 7 studies on AKI and 13 studies on AKI treatment with Lasix. So furosemide had neither an impact on mortality and no impact on the RRT. So it's very clear, furosemide in ICU, when used, it doesn't have any impact in RRT and it also doesn't have an impact on mortality. But it's not recommended to treat AKI per se, but are suggested to treat volume overload. So this is one of the conditions where you can actually use this. So now again this is the NEGM study which was actually done for some other reason, but also it was done actually to look which vasopressor is better, norepinephrine versus dopamine. So now what they did is in the same study there was a subgroup analysis where they used continuous versus intermittent and low versus high doses of furosemide. So what they found is whatever the use was, so if this is the creatinine level and this is the bolus and continuous, there's no change, p-value is not significant. Same is with the low dose and high dose, p-value is not significant. So they came with a conclusion, no significant difference in patients' global assessment of symptoms or change in renal function when diuretic therapy was either by bolus or by the continuous infusion or high versus low doses. So we are clear about now the diuretics. Adverse effects of diuretics, extracellular volume depletion, hyponatremia, hypokalemia, hypomagnesemia, metabolic alkalosis, hyperuricemia. There's something called a diuretic resistance as well. So it's defined as failure to achieve therapeutically desired reduction in edema when a maximal dose of diuretics is used. So common factor is we don't understand the pharmacokinetics very well. A non-compliant patient, role of hypoalbuminemia, and recent hypothesis is role of proteolytic enzymes. We'll come to it. And there are various ways to correct it, to approach it, not to correct it, to see whether the patient is compliant, adequate blood volume is there, adequate salt restriction is there, and ensure adequate diuretic dosing. So why this concept came in? Because it's also been said when we use furosemide, it's to be secreted in the tubules, and it's a very good, highly protein-bound drug. So to get secreted in the tubules, protein needs to be good, albumin needs to be good, otherwise it will not get secreted and there won't be an excretion. So this is where the question of albumin comes in ICU. So Cochrane meta-analysis 1998 proves that albumin is harmful. There was hue and cry all across the UK and global nations, and everyone stopped using. Almost, there's a trial, it takes years to follow it. But this was a trial where within 6 months, 40 to 45% of the usage of albumin came down. And even the US FDA, for the first time in their life, they issued a letter saying, "Dear doctor, you shouldn't be using this is harmful." But it was not taken very well by the society, and the expert committee came up and they wrote a note saying this is insufficient evidence of harm to warrant withdrawal of albumin products, and we need to have the better studies and better ways of analysis to prove it. So again, the Wilkes came in as a savior, and he did a meta-analysis of 55 trials and number of patients around 3,500, where he found use of albumin was indifferent. Again, it was also proven by the next Vincent, who said albumin was beneficial. So it was altogether different areas. Cochrane said harmful, Wilkes said indifferent, and Vincent said it's beneficial. So no one knows what is to be done with the albumin. Then came the SAFE study. We all know this. It's about the 6,000 patients. Again, it was to study saline versus albumin, what is better. But there was a subgroup analysis of the patient with severe sepsis and septic shock, which found albumin was associated with lower mortality rate as compared to the saline. Again, the subgroup analysis. But overall, if you look, there was no difference in the heart rate, mean blood pressure. There was no major difference in the central venous pressure. And you see the KM estimates, the curve is totally linear when both are concerned. So relative risk, there is an issue over here. If you see the odds ratio, in the patients with severe sepsis, it favors albumin. In the patients with trauma, it favors saline. So these are the two sets where there's a problem. So when it's trauma, albumin was to be harmful. When it was trauma, saline was favorable and albumin was harmful. And when it was severe sepsis, then maybe the albumin was favorable in that. So again, the mortality, if you look into with sepsis, without sepsis. So after this Albio study, after the SAFE study, the US FDA had issued a statement in 1998. They changed it. They said, issued a notice and said now a SAFE study had resolved the safety concern raised by Cochrane in 1998. So this is how long it took to make the FDA realize and change the statement and release a note of it. But the volume replacement in trauma patient, we all know that it's a problem. So when we use in trauma, that is trauma with TBI and trauma without TBI. So this is an albumin group. Mortality is higher in the TBI section, but not without the TBI section. So albumin is definitely harmful when we use in the case of TBI. Albio study came in, again, which was a multi-center around 1,800 patients. We did not find any difference in the two groups when it was studied in albumin plus crystalloid versus crystalloid alone. Now the 18 network, the multi-center randomized control trial that was used for RRT versus this, I think must have been definitely discussed. This was to be versus the intensive therapy and non-intensive therapy of RRT. But again, it had the subgroup analysis which showed when the albumin was used in a certain case of patient who received albumin versus those who received crystalloids, there was a subgroup. They found the study didn't find patient who received albumin had higher incidence of pulmonary edema compared to those who received crystalloid, but there's no significant difference in the mortality. So though the pulmonary edema incidence are higher in the albumin group, but there was no change in the mortality amongst the two set of the patients. And the use of albumin as a resuscitation fluid is only for the certain conditions. This is what it should be looking at. But this is a different condition, cirrhosis and hepatorenal syndrome. So albumin may prevent AKI, those treated with antibiotics for spontaneous bacterial peritonitis. And the bridge therapies which have been used along with the albumin, like talipressin plus albumin, octreotide and midodrine along with albumin, have found to be more effective when albumin has been using in those drugs, because these are the albumin binding drugs and presence of albumin helps them. So when it's about albumin, it's just useful in the hepatic patients. It's not to be used in the trauma cases, and others is the gray area. Now one more area is left. We talked about diuretics, we were clear in that. We talked about the albumin, we came up to a decision. Now it's a combination of both the things. As I told you, furosemide is a drug which gets bound to the protein, needs to be secreted in the tubules to be effective. So the thought process is, if the albumin is low, obviously it will not be enough secreted in the tubules and it will not be effective. So they combined albumin in certain case of the, and this is why the role of hypoalbuminemia comes in play. So this is a study in a patient with hypoalbuminemia. It is thought that infusion of furosemide and albumin complex increases direct delivery to the kidney by keeping the drug within the vascular space. So this is why they say in patients with nephrotic syndrome, found that combination therapy produced a moderate increase in sodium excretion. Similar lack of demonstration was seen in the cirrhotic patient, and the infusion of furosemide and albumin are to be used in those patients. So this is a study which was done, which showed diuretic response is suboptimal in patients with hypoalbuminemia. Same was proven by the Raj Mohan in 16 children with a nephrotic syndrome. So here's the meta-analysis which was done where the furosemide along with albumin was used. So what they found is in 13 studies with 422 participants, the effect of albumin was better in a participants with low base albumin. So there's a heterogeneity in the study. So it was effective only when those albumin was low and when the prescribed albumin infusion was more than 30 grams per day. So the effect was more significant within 12 hours after administration. So it was not for everyone, it was for the certain set of group. When the serum albumin was less than 2.5 and the dose of the albumin was more than 30 grams. So co-administration of furosemide with albumin might enhance diuresis, and according to the present analysis, furosemide therapy alone in patients with baseline albumin less than 2.5 and receiving higher albumin dose is going to be effective, is not for everyone. So when you look into the patient section where to use furosemide, where to use albumin, whether to use combination, we need to know the set of the patient where we have to use it. Is not for everyone. One last slide or last study which I want to cover is about the mannitol furosemide combination along with the albumin. So mannitol is supposed to be the renal protector. It was supposed to be used because it dilutes the tubular cast, and more commonly it was used in the rhabdomyolysis. But many studies have been done related to the mannitol. It's been same, it's not at all renal protective, but it was studied in certain set of cases. Again, it was found that variables such as central venous pressure, peripheral edema, urine volume, all these were studied. But what the conclusion was, it was better in improving the diuresis and improving the oxygenation and reducing the peripheral edema, but has little effect on the renal function. So when the mannitol was used alone or mannitol along with albumin, diuresis was better, oxygenation was better, but renal function always remained the same. So this is what everyone looks for. Every nephrologist wants this way. But again, as I told you, there's heterogeneity in this. If you get this kind of a urine output in such a smaller patient, again, it's not a good sign. So always never go with the one size doesn't fit all. It's different set of the patient. So I cannot say furosemide should be useful or albumin should be useful. You need to know your patients, need to know other parameters and find the way out. Thank you very much.
Sure. Thank you, Dr. Bharat. Before moving on to our next session, I'd like to call Dr. Viswa Bikas to kindly felicitate Dr. Niranjan Panigrai. Now I'd like to call Dr. Shubhadeep Sen to kindly felicitate Dr. Arindam Kar. Thank you. Moving on to our next session, I would like to call Dr. Akhilesh Tandekar, Head of the Department, Critical Care Medicine, Wokhard Hospital, Mumbai. Sir is also the visiting consultant for Apollo Hospital, Navi, Mumbai. Sir is here to join us with the topic AKI in burn trauma and drug-induced AKI.
Hello, good evening everyone. I know this is the end of the program, kind of, and it will be very difficult to get you engaged. I hope you all are really eager to go home, probably after this busy 2 days exhaustive program that we had, and I think you must be very much full of knowledge at this point of time, and I really don't need to teach you at this point of time probably. So it's better that we get interacted and discuss these topics. I know these 3 topics are very difficult to be, covered within this 20 minutes or 30 minutes. So I will try to give you some, clues or hints. If we can discuss together, I think that will make a lot of sense. So we all see, since last 2 days, we must have discussed a lot of guidelines, a lot of recommendations, and we must have learned hands-on on workshop also how do we initiate dialysis, when to initiate dialysis. So it's good to summarize, all whatever we have learned in last 2 days. I think it will be good to have a good discussion on this. So I'll begin with my case presentation basically. Okay. So this was one case which, 58-year-old female presented to me in the ICU. She had a stove burn. And the burn was involving the abdomen and the chest and both lower limbs. She was very tachycardic. Her heart rate was more than 130 and blood pressure was around 90/50 and the saturation was 96%. Patient was little often dead also. She presented almost 4 hours after the burn because she was far off from her from the hospital. She was in a village. She traveled for 4 hours, and when she was brought to us, she was in a little hypotensive state. And then her ABG was also showing little acidosis. pH was 7.1. Her PCO2 was 52, and bicarbs were 14. And then we started, as we intensivist, we jump up with the fluids, because what we learn with the burn injuries is like these patients are fluid responsive. They will have a lot of capillary leakage. There will be a lot of insensible losses also, and then we keep on giving fluid. And we started fluid resuscitation in this patient with crystalloids, and then patient became 3.5 liters positive next day, and then we were happy that we have at least resuscitated this patient with optimum fluids and kept 3.5 liters positive. But in spite of giving these fluids, the lactates were rising, potassium was also a little high, 6.2 around, and then anticalemic measures were given, and creatinine was 1.8. And then
considering this as a burn case, we did a CPK and the CPK was also elevated. So it was around 1200. Next day, the creatinine shot up from 1.8 to 3.2, bicarb were 12. Again, we tried to keep the positive balance of 4 liters. Fluid resuscitation was going on. And then, the CPK again got elevated to 24,000 from just, 1200. And then X-ray started showing bilateral pleural effusion. He was on noradrenaline. And then the urine output was around just 25 ml. So I was happy that, at least urine output is around, acceptable range, 0.5 ml per kg per hour. We wanted, that is enough. And then we fortunately did, we wanted to evaluate whether this patient has pre-renal component or this is a renal injury. So that's why we did exhaustive urine analysis and then serum sodium, and then urinary sodiums were also sent. Urinary sodium was 25. Urine osmolality was quite high, 319. And then we thought still patient is probably hypovolemic, fluid responsive, and probably this patient is 7.5 liters positive and still he is intravascularly dehydrated to continue fluid. And as usual, we whenever we feel that patient is not responding to crystalloids, we jump up to the colloids. And my previous speaker also told, there is a lot of rationale behind using albumin because it has oncotic pressure which will draw fluid from interstitium into the intravascular compartment, and that will maintain the blood volume to all the other organs. So I also started albumin and all that. And then simultaneously fluid resuscitation was going on. Usually in ICU, we started feeding this patient, but day 4 again, in spite of this 7.5 liters, the patient was again, not able to maintain a good urine output. It was a downtrending urine output, 15 ml per hour, NORAD requirement was up. And then, we had to add vasopressin. The cultures were all negative, WBC was 19,000 and creatinine was again climbing up 3.6. So in this situation, what would you do? As a clinician, we have learned a lot in last 2 days. I would like to hear from you all also as to what will you do in this situation. Given this scenario, 4 days, patient is 7.5 liters positive, and then his all cultures are also negative, though WBC comes to 19,000, what will we do? Can somebody please help me with the situation? I am confused as to what do I do. Do I give diuretics? I don't know whether it will help. Do I need to start with dialysis? Which dialysis, Slade versus CRRT? So what do you think will be the best option here? I would like to hear from you. Whether it is right or wrong doesn't matter. You also must have faced this situation in your place. Being a nephrologist or being intensivist, you all must have gone through these phases. I think like me, you all are also confused. Okay? So we need to understand the risk factors for patients who develop burns. So these are the risk factors, elderly patients, and percentage of burn is very important. So higher the percentage of burn, above 30% of burn, these patients are likely to develop systemic inflammatory response. They will be hypovolemic, they will have capillary leakage, and they will develop acute kidney injury, which will be initially pre-renal. So within first 3 days, these patients will have pre-renal cause of acute kidney injury. And then if they have concomitant comorbidities like diabetes or hypertension, and if they have undergone surgery or debridements, multiple debridements, they are likely to develop acute kidney injury. And then inhalational burn is supposed to be more toxic compared to your scalds, warm water, high temperature burns and all that. So inhalational burn is associated with more body surface area involvement, and probably they are more harmful. So studies have shown that higher the body surface area, higher is the risk of developing acute kidney injury, especially in patients with the burn. And then within first 3 days, patients basically develop acute kidney injury due to hypovolemia or inflammatory response and third will be rhabdomyolysis, because there will be some amount of muscle injury also, especially with the burns more than 30%, they will have rhabdomyolysis. Myoglobin will be released, and myoglobin will lead to acute tubular necrosis. So initially, though these patients will look, like having pre-renal azotemia, but later on, due to this myoglobin deposition and all that, these patients are likely to develop tubular necrosis, ATN, acute tubular necrosis. So you will see that these patients will have both pre-renal and intrarenal components as far as pathophysiology is concerned. So we'll have to assess whether your patient is fitting into pre-renal or a renal component, and accordingly we'll have to judiciously advocate fluid therapy versus dialysis. And then late onset burns will definitely have sepsis, and then organ hypoperfusion and organ dysfunction will lead to multi-organ failure. And if these patients are not de-resuscitated, or if there is ongoing fluid resuscitation, these patients are likely to develop fluid overload. Okay, and on top of that, we use a lot of drugs. We use antibiotics, we use analgesics. So these drugs also contribute to development of acute kidney injury. And then Mindwell, we need to understand that we have discussed a lot about different scoring systems to diagnose acute kidney injury. Rifle criteria, Akin criteria, and KDIGO. So all these criteria doesn't work well when you are trying to assess acute kidney injury in patients with a burn. KDIGO, which relies more on the urine output, and creatinine measurements, these are falsely elevated, or urine output will be low, and then you may overestimate acute kidney injury in these patients. So that's why these markers like urine output and creatinine are not useful. Probably biomarkers may have some role. So NGAL, which is not available in most of the places, cystatin C. So these biomarkers can predict inflammatory response and acute kidney injury much ahead, much better, earlier than probably creatinine and urine output, because creatinine may take 12 hours to rise, or urine output also may drop after 12 hours or so, but NGAL and all that these are inflammatory markers which can be raised within 3 to 4 hours. So a quick assessment with the help of NGAL or cystatin C will help you to identify the acute kidney injury, and you can institute therapies for that. And then NGAL not only tells you acute kidney injury, but it also tells you about the extent of systemic inflammatory response, and depending upon that you will be able to establish whether your patient has hyperimmune response or they have compensatory response. So many studies have shown that these compensatory mechanisms like hyperimmune response is more as a culprit for development of multi-organ failure. So these are different markers. None of these markers are really available. All these are studied in various literature, and studies have shown that the availability of these markers is also not there, and we don't know at what part of injury in the kidneys these markers will be elevated. But if you read carefully, so you have the markers when the glomerulus is affected, you have the markers elevated when proximal convoluted tubules are affected, and you have the markers wherein distal convoluted tubules is affected. So we need to assess these markers, and these markers guided therapy will help you to assess acute kidney injury, and then you will be able to assess your patient whether your patient is at low risk or intermediate risk or high risk or very high risk. So higher the levels of these markers, biomarkers, and then with the advent of artificial intelligence and machine learning techniques, so there are algorithms set in where different parameters are also taken into account. Not only the biomarkers, the creatinine, urine output, and patient demographic profile is also taken into account, and you can establish whether your patient has acute kidney injury which is high risk or low risk or intermediate risk. So that's why there needs to be update or amendment, or probably you need to refine these guidelines again and again, because we always feel that acute kidney injury may be due to sepsis. So KDIGO guideline may be useful for sepsis, but it may not hold true in patients with the burn, especially when you have a lot of capillary leakage, extreme inflammatory response. So these guidelines doesn't help. But and then there is high proteinuria. If there is high proteinuria, okay, with burns, that itself is an independent, marker of assessment of the severity of injury. So that's why proteinuria, urine protein, can give you an idea, 3+, 4+. Okay, higher the proteinuria, higher is this patient is at risk of acute kidney injury, and preemptive steps should be established. Not only this, burn will also lead to a lot of electrolyte disturbances, hyperkalemia, myoglobinuria. So hyperkalemic, injuries and myocardial injuries can also, will be associated with arrhythmias. So that's why it is very important that you need to just support. Do not do harm. Do not just give diuretics, but just support the system. Judicious use of vasopressors. Monitor fluid responsiveness with different hemodynamic parameters. There are a lot of hemodynamic parameters. You can't just be dependent on clinical tools. You have laboratory, biomarkers. All these tools, have to be used together to assess the hemodynamic condition of the patient and what hemodynamic support is required. So basically, burn patient will also be vasodilated. You need a good vasoconstrictor. If you use good vasoconstrictor, the capillary leakage will be prevented, because in a vasodilated state, the endothelial spaces open up and there is more and more of capillary leakage, and these patients will go into third spacing, and no matter whatever fluid you give, that fluid goes into the interstitium, and these patients will have third spacing. Not only the fluid goes into the skin, subcutaneous tissue, but the fluid goes into pleural spaces, pleural effusion. They will have ascites. So that's why it is very essential that you have to use all your hemodynamic tools, clinical tools, laboratory tools and biomarkers together to assess the patient's, hemodynamic response and response to the treatment with the help of fluids. The fluid therapy with Parkland formula is quite useful. I think that will help you to avoid excessive fluid resuscitation. Okay, and then other measures also are very important as the burn. The staging of the acute kidney injury, increases, and if the patient goes beyond 1 week or so, you will have to advocate nutritional support. Infection control is very important, and it needs a multidisciplinary approach. So as we discussed, rhabdomyolysis is the commonest complication of acute kidney injury with the burns. We can calculate McMahon score, which incorporates the level of myoglobulins and urine output and creatinine. So all these various factors are taken into consideration. And if the McMahon score is more than 66, so this patient is likely to develop acute kidney injury, and patients will need fluid resuscitation and preemptive dialysis. Early institution of dialysis is very important. Rather than bumping these patients with the diuretics, early institution of dialysis will help you to remove these toxic elements, myoglobulin. High flux dialysis also will be useful in these patients. So it is very important that how soon you institute dialysis is very important. So we end up starting dialysis only when the urine output has dropped to nil or something like that, and you feel that we have to keep waiting maybe for 6 hours till the acute kidney injury set in, and you institute dialysis. That is the most foolish decision that we may be taking at that point of time. So similarly, when we talk about trauma is the major cause of death, and then trauma associated acute kidney injury, we call it as TRACHE, is associated with acute kidney injury. Especially the factors associated with the trauma are, microcirculatory disturbances. These patients will have hypovolemic shock, hemorrhagic shock. They will have hypoxemia, and they will also have electrolyte disturbances, and they will also receive a lot of blood and blood products which may also be toxic, because these blood products will also lead to hemolysis, and hemoglobinuria will also lead to acute kidney injury. So these are the factors we need to understand while dealing with the trauma patients. So patients will also receive different nephrotoxic drugs, painkillers, NSAIDs also. They may receive NSAIDs. They may receive antibiotics, which also may be toxic, and then ventilator support, which will reduce the preload of the heart and will cause hypotension, and overall it will also reduce cardiac output, and that can lead to acute kidney injury. So that's why it is very important that we need to understand that the immune response which is associated with the trauma can also lead to acute kidney injury. And then these are the factors. The patient may develop spinal shock, we keep giving fluids in these patients. A simple dopamine or probably a noradrenaline may help you in these patients with the trauma, and we can prevent acute kidney injury. If the patient has abdominal trauma, abdominal compartment syndrome, abdominal pressure monitoring can help us to reduce incidence of acute kidney injury. And then early institution of control of intra-abdominal pressure, like probably exploration or reductive surgeries will help you to reduce intra-abdominal compartment syndrome. If the patients have hemothorax, they will have ongoing hemothorax. Okay, if you can't control hemothorax, this patient will remain hypovolemic, hypotensive, and then these patients will develop acute kidney injury. So there are different factors. Bleeding is the major factor in trauma patients. Unless you close the tap, these patients will never get settled, and then you will keep giving fluids and blood products. So the first dictum in trauma patient is to stop the bleeding with whatever means it is. If there is an external bleeding, stop it with the external compression. And if you want to stop with invasive procedures, embolization, especially with the arterial bleeds, you may have to intervene, especially with the thoracic injury, thoracic trauma, you may have to intervene with the vascular surgeons. So trauma is definitely associated with acute kidney injury. The causes could be, multifactorial, and then, the inherent activation of renin-angiotensin system can also be culprit in patients with the trauma, because whenever there is an hypovolemic state, renin-angiotensin will be released. That will cause vasoconstriction of the afferent arteriole. The blood supply to the glomerulus will be compromised, and these patients will develop acute kidney injury. And then moving to drug-induced acute kidney injury, there are various drugs. We all know many. I need not list you all these drugs, but so majority of these nephrotoxic agents will have variable effect. Some of them may have effect on glomerulus, some of them may have effect on proximal convoluted tubule, on distal convoluted tubule, and all that. So depending upon that, you can predict whether this patient is likely to develop acute kidney injury of what type, So these are the various drugs which act on various, places on the nephron. And then drug-induced toxicity will be associated with formation of the crystals. These are the, drugs which can form different crystals, and that's why urine analysis is very important. What type of crystals, what type of cast are identified in the urine routine microscopy is very important. And then acute drug toxicity can lead to interstitial nephritis. It can also lead to tubular epithelial injury. It can also lead to allergic interstitial nephritis. Okay, so these are the findings which are seen in ultrasound. I mean, you will see the medulla will be distorted, the cortex will be well preserved. Okay, and then the size of the kidney also will be increased initially as a compensatory mechanism, but later on, as the stage of acute kidney injury progresses, there will be shrinkage of the kidney. So these are the molecular probes which are also used. Isotope scans can also be used to identify drug-induced toxicity, nephrotoxicity, and can help us. So basically, prevention is the biggest strategy that we should be advocating in any kind of injury, whether it is burn or trauma or drug-induced toxicity. We need to preserve renal functions. Supportive care, maintenance of the perfusion of the kidney is very important. Maintenance of the mean arterial pressure to around 60-65 is very important. And elderly patients, a little higher MAP is very important. But supranormal maintenance of supranormal mean arterial pressure also may be harmful. That can lead to arrhythmia. So 60-65 of MAP is very essential. And then we also need to understand the physiological changes that may be happening due to burn or trauma or drug-induced toxicity, and we need to address that immediately. If we don't address or prevent or remove these offending agents, that will lead to irreversible injury to the kidneys, and it will also lead to prolonged stay in the hospital and increased requirement of renal replacement therapy. So non-pharmacological strategies will be volume resuscitation based on mean arterial pressure, urine output, and hemodynamic parameters. So volume therapy is what type of fluid you are using, crystalloid versus colloid. There is a lot of debate upon this. And then various studies have shown that colloids like hydroxyethyl starch may be harmful, and then probably balance. There is a role of balanced crystalloid which is more popular, which was more popular, but now again, new studies have shown that even normal saline also may be sufficient enough, to help resuscitation in this patient. So any fluid, whatever you are using, you have to keep continuing your fluid till your patient is fluid responsive. But if the patient is fluid responsive and then he is persistently hypovolemic, probably you need to reduce the third spacing, and you may have to add vasopressor and reduce the capillary leakage. We need to minimize nephrotoxicity. So whenever any aminoglycoside, amphotericin B is used, whether even liposomal amphotericin B is also toxic. So we need to understand, and we need to adjust the dosages, and we need to reduce the offending agent or remove the offending agent to prevent acute kidney injury. So, and the drug frequency or the drug dosing also has to be adjusted. Especially gentamicin, which is just concentration dependent antibiotic, but people use it twice, thrice, which will again cause injury. So a single dose of these aminoglycosides is also sufficient. So whenever amphotericin B kind of drugs are used, probably these patients also need to be hydrated well, and then the drug toxicity can be prevented. Radio contrast agents are blamed for acute kidney injury quite often, but preemptive steps for if you hydrate this patient, and probably some centers use N-acetylcysteine to prevent radio contrast induced injuries, and but there are no studies which have proven any beneficial effect. But these are the preemptive steps that you can use. Loop diuretics are quite abused. I mean, diuretics, any patient whose urine output is low and he is still volume responsive, we give fluid, and this diuretic induced acute kidney injury also is precipitated. So we have to use diuretics very judiciously. Dopamine is also used in quite a lot of centers as a renal dose dopamine, and basically after starting dopamine initially the urine output improves, but later on it causes acute kidney injury, acute tubular necrosis. So dopamine has to be used only when there is a documented bradycardia, or probably your patient is not responding and bradycardia, and he has some myocardial dysfunction. But if he has bradycardia, then only probably the dopamine is used. The role of dopamine is debated a lot, and then probably it has gone out of the market also, and popularity has also lost. And then N-acetylcysteine, in centers where the contrast have been used, it has shown that it is not harmful in N-acetylcysteine, but probably it may prevent acute kidney injury preemptively. But after giving contrast, you give N-acetylcysteine, it may not help. So there are so many studies pertaining to dopamine which are negative. So that's why it should not be used. And then N-acetylcysteine, there are so many studies. Some studies are positive, some studies are equivocal. But N-acetylcysteine should be used only when preemptively, not the post-injury. So mainly supportive treatment is very important. And then we need to control the infection. Okay, so ultimately everything is how well we handle the patient, how well we give good nursing to the patient, and how well we review the drugs on the daily basis. These are all the steps which will help us to prevent injury to the kidneys. And then maintenance of mean arterial pressure of around 65 is an independent factor which may contribute prevention of acute kidney injury. So many studies have shown that maintenance of just MAP of around 65 is quite important. And there are level 2 recommendations. Severe randomized control trials have shown that noradrenaline in initial stage of acute kidney injury can be very useful maintaining MAP. Okay, there are studies comparing noradrenaline with dopamine, and noradrenaline is most favored, and the outcomes and the mortality have also been improved with the use of noradrenaline, whereas dopamine is found to be more arrhythmogenic, and there are a lot of case fatalities after dopamine. So given a choice, if the patient is fluid responsive, volume responsive, judicious use of vasopressors agents like noradrenaline will definitely help us. Fluid therapy is, fluid is like a drug. It has to be used judiciously. When you are aware that this patient is continuously fluid responsive, he is developing third spacing, we need to, curtail fluids, and probably vasopressors can be instituted. So we need to have a global approach when we are assessing fluid responsive. We have to use our biomarkers, hemodynamic markers, laboratory markers to assess whether this patient is likely to be benefited with the intervention that we are trying to give it to the patient. And then renal replacement therapy has to be instituted at the earliest. Okay? And then, so these are the factors which will help you to guide whether your patient needs renal replacement therapy. So urine output, and then electrolyte disturbances, urea clearance, these are the factors which will help us to guide about renal replacement therapy. What mode of renal replacement therapy, I need not talk to you about this. You have learnt it a lot in last couple of days. So these are the factors when we are starting dialysis. We need to take into consideration earlier dialysis is very important. If the patient is hemodynamically unstable, renal replacement therapy with continuous mode, convective therapies will be very useful. And then simultaneously the fluid management also is very important, and anticoagulation. And then how do we start weaning patient from renal replacement therapy is also very important. These are the factors which we have to take into consideration while we are dealing with patients with acute kidney injury related to burn or trauma or drug-induced toxicity. With this, I would like to stop because of the time constraint, but I would be happy to take your questions, and if you have any such similar confusing cases, I would like to have a discussion right now, or we can discuss it on the tea break. Yeah. Pardon? Yeah. So we are basically not measuring McMahon score, so this is for the theoretical importance, but very, very simple tool actually. We just need to know what is the myoglobin level, urine output, creatinine, and then patient's other parameters like urinary sodium is also taken into consideration. So you need to have urine analysis. It's not very complicated, but we are not practicing it, so that's why. So these scores are very important, and we need to incorporate it into daily practice to prevent further injury, and we can prevent abuse of diuretics, and then we can avoid late institution of dialysis if we have these scoring systems in place. Okay. If there are no questions, we can conclude. Thank you very much.
Thank you, sir. Before moving on to the next session, I'd like to call Dr. Ravindra Nikhalji to felicitate Dr. Bharat Jagyasi. I'd like to call Dr. Gunjan Chanchlani to give the memento to Dr. Sanat Das. I'd like to call Dr. Arindam Kar to felicitate Dr. Akhilesh. I'd like to call Dr. Gunadhar Padhi to felicitate Dr. Shantanu.
उसके बाद है क्या डॉक्टर शांतनु का ये है तो एनीवे फेलिसिटेट कर देते हैं इसके बाद शांतनु yes no problem so we'll felicitate then we'll start with this
Dr. Shantanu.
उनका टॉपिक है
Case-based discussion.
So I hope everybody of you somebody has already received the book, right? Those who have not received the book, just tick besides your name. The books are outside, okay? And get the books. Not right now. All of your books is reserved. Don't worry, okay? So we'll give you everybody, and then. And also please give the feedbacks. Scan the code and give your feedbacks. Very, very important. Yesterday we have received some feedbacks. So today also you give the feedback so that we can modify the program next time. Santanu, your PPT is there? Or can we do the Zoom session right now and then follow your PPT? And so
recording in progress.
So now we'll be just doing a Zoom session with Dr. Jatin Kothari sir. So he is not able to come today physically, and he has begged the apology for that. So after this session we'll have the last lecture of today, okay, and then we'll go for the tea, and if time permits, everybody agrees, we'll have a series of 5 to 6 very interesting cases on toxicology, okay. So I request all the DNB and trainees particularly to remain there for that session. Actually, it will be going to helpful for your exams. So these are all covering the practical aspects, case-based and interactive one-to-one discussion. Okay. So now we'll be going forward, and we'll do the Zoom meeting virtually, connect through the screen with Dr. Jatin Kothari sir.
Good evening all, am I audible?
Yes, sir, you are audible to us. Please go ahead.
1 minute. Sir, I'll just introduce you, sir. 2 minutes. So, Dr. Jatin Kothari is the Chief Consultant, Renal Transplant Medicine, Nanavati Max Super Speciality Hospital, Mumbai. He is the Consultant and Section Coordinator Nephrology before PD Hinduja Hospital. He is the Director of very well-known Apex Kidney Center, and he is one of the founding trustee and treasurer of Apex Kidney Care Foundation. He has a large, vast experience in the field of nephrology. So let's hear from him. Okay, and welcome, sir. Please, you can start. We are able to hear you.
Thank you very much. Sorry, I have to reiterate my talk, and I'm very thankful to the whole team, and especially Dr. Gunadhar, to accommodate me in this late evening session. To be honest, I have to actually go through a little bit of literature while preparing for this talk. It is in some ways very helpful for me also. In the next 15 or 20 minutes, I will try to share with you some of the evidence as to how particular drug poisoning, etc., can be dealt with by a combination of ICU and nephrology together in an ICU setting, and especially aspects of renal replacement therapy and how renal replacement therapy can help patients who have drug intoxication. These are my disclosures. Opportunity for this talk, I have no conflict of interest. At the outset, I would want to say that most of the slides that I have made are actually from various online presentations that I saw, and of course referring to our Bible, which is uptodate.com. So, as a nephrologist, always when we are called in the ICU, we are looked upon as people who provide dialysis. I don't think nephrology should be looked at only dialysis. They should be looked at, partners in treatment of all critically patients wherever there is AKI, or in some selected situations, even toxicology and drug poisoning. So classically, you all know, and I'm sure that during this course over the last 2 days, you have not heard from Ravi and Ashwati and all the other nephrology colleagues that there are ways, there are specific indications why we look at dialysis as a renal support for patients in the ICU. We are all aware, and this is taught to us in the undergraduate age, that hyperkalemia, refractory metabolic acidosis, and again refractory pulmonary edema which doesn't respond to diuretics, are the main indications as to why people require dialysis, whether in ICU or even in the general non-ICU setting. For this talk, particularly, we are going to look at the aspect of looking at drug overdose and how dialysis can help. So, straight away going to the topic of extracorporeal treatments, we all know that the understanding of extracorporeal treatments has emerged, and our understanding has improved over the last 2 or 3 decades. But essentially, it is quite complex. And my attempt here in the next 10 minutes is to try and simplify it for all the people who are attending these sessions. There are traditional ways in which we provide renal replacement therapy, and in the ICU it is not different. So the traditional hemodialysis, the new version is hemodiafiltration and hemofiltration, which has now become a tool for patients who are unstable in ICU and can also be used in poisoning, and I will cover that aspect in the next few minutes. Hemoperfusion is also helpful in selected drug intoxication situations. Just a word on peritoneal dialysis, because that's not the favored modality of replacement therapy nowadays. Whenever there is access to...
Excuse me, sir. Sir, can I interrupt?
I
think it's not audible there. Not audible.
And as nephrologists, yes, we are not much trained in terms of handling patients with drug overdose, and it's not a very common thing that nephrologists come across. But yes, whenever a patient is in ICU with critically ill condition, then sometimes we get called in for the support for extracorporeal or renal support. That's the reason why I think this course has included my topic, which I'm going to cover. Just some general guidelines in terms of how we look at patients who have poisoning. First of all, obviously, we want to see whether that poisoning has really led to significant symptoms or organ dysfunction. The first line of treatment, obviously, supportive treatment and things like gastric lavage and post-alkaline diuretics, etc. But when patients are very, very sick and they are defibrillating in the ICU with severe intoxication leading to brainstem injury or for some reason respiratory failure, that's the situation where we actually discuss the whole role of extracorporeal treatments. The basic premise is that impairment of normal drug excretory function usually happens when patients have hepatic or renal dysfunction. We know that these are the two main organs which are required for metabolism and excretion of all these toxins. So whenever there is impairment of these two organ systems, that's when sometimes we are called in for renal support. Intoxications of certain agents do lead to metabolic complications, especially the alcohol, which leads to refractory metabolic acidosis. And that's where we essentially come in for renal support or dialysis to correct the acidosis itself. It's not per se only to remove the toxin, because probably the removal of the toxin is way, way beyond the time when we get called in most of the time. But even the acidosis correction usually helps tremendously in terms of improving the clinical condition of the patient. We also need to understand that there is some endogenous elimination of all drugs by the liver or the kidney. So whenever patients have liver or kidney dysfunction, that's where we are called in for the dialysis support. The whole purpose of providing extracorporeal treatment is to essentially reduce morbidity and mortality of these patients, because some of these patients actually are quite young and they otherwise don't have much comorbidity. So you would expect that if you are able to clear the drug and prevent the metabolic complications, then you would be able to reduce mortality and morbidity. Obviously, you are looking at reducing hospitalization and all the complications that would occur with multi-system organ failure, etc., with drug intoxication, and that's the purpose of supporting these patients with dialysis or some form of dialysis. When we look at removal of poisons, the four main concepts that we need to understand is to how a particular drug is going to be eliminated is based on four factors. And I think this is probably the most important slide of my presentation, that the molecular weight of the substance that we are dealing with. Second is, what is the extent of protein binding that a particular drug has? Thirdly, what is the endogenous clearance in that particular patient? As I mentioned, if they have liver dysfunction or kidney dysfunction, that's where the endogenous clearance may go down, and that's where dialysis may be required. And of course, last but not the least, one of the most important factors is the volume of distribution of that particular drug in the body. So let's look at this one by one, because this is very important from a physiological standpoint as to where we need to intervene with early dialysis or renal support. This is on the left-hand side.
Hello, Dr. Jatin. Sorry to
Yes.
interrupt you. We are not able to view your screen, sir, actually. I think
You're not able to see my screen?
Yes, we are able to view your screen only. I mean to say your camera feed only. We are not able to view your presentation, PPT screen. Can you share it again? Or if it not, please share the screen.
Let me try that again. I thought we did share screen, host disabled participant screen sharing.
Okay. Let me make you host.
Maybe you can disable me and then connect me again.
Make host. You can check it now. Check now.
No, it shows host disabled participant screen sharing.
Yes. Yes. You can check it now. Can you check?
Yeah, I can see now. Yes. I'm sorry for that. Are you able to see my slides now?
Yes, we are able to view your slide now.
So I think we've covered half the talk, but just to summarize as to what part we have covered, we were talking about the four main factors which are responsible in terms of trying to eliminate a particular toxin from the system. So the four critical determinants for supportive treatment like extracorporeal dialysis or renal replacement is dependent on four factors: molecular weight of the substance that we are dealing with, the extent of protein binding, what is the endogenous clearance, and that's something that we need to look at in terms of a patient having hepatic or renal dysfunction where the clearance may reduce, and of course the volume of distribution. If drug has a large volume of distribution, then you are not going to be able to remove that drug by doing dialysis or CRRT. So this is probably the most important slide of my presentation, looking at the molecular weights of the common things that we talk about. And in nephrology, we have an understanding of dividing molecules in terms of, depending on the molecular weight, as small, middle molecules and large molecules. So when you look at the bottom part of this graph on the left-hand side, you can see all these are small molecules which are traditionally removed by dialysis. Things like urea, potassium, phosphorus, sodium, even creatinine, glucose, and uric acid. So these are all the small molecules that we talk about, and this is where dialysis is helpful. When we start up talking about various drugs and their molecular weight actually goes up in thousands, that's where we are talking about the middle molecules. So anything that is between so-called 1,000 to about 10,000 is labeled as middle molecules, and beta-2 microglobulin also happens to be a middle molecule. And when we talk about large molecular weight substances, the predominant one obviously is albumin. Now when we talk about looking at modality of treatment based on molecular weight, on this side you can see that the low flux dialysis or high flux dialysis can really remove the small or middle molecules. But when you have to remove large molecules, you would have to use either CRRT or sometimes even high cutoff dialysis. Now this is not very easy to get. There is some companies which are providing high cutoff dialysis, but it's extremely expensive. Some of our colleagues from hepatology obviously do the albumin dialysis using the MARS system, which can remove molecular weight substances of up to 60,000. And there are some other advanced forms of renal support like plasma exchange, which can actually remove even light chains and large molecules which are protein bound. So depending on the molecular weight, most likely you will have to select the modality of renal replacement. The second important point is talking about protein binding. And as I mentioned earlier, if a drug has extreme affinity for binding to albumin and has got a lot of binding, then the removal on dialysis or hemofiltration is very poor. And that's where you would have to go in for CRRT or something like a Mars system or the Prometheus system, which is a new system now, which can help to clear these particular toxins which are heavily protein bound. Other than that, you will not be able to remove these molecules. This is a cartoon, this is a schematic which I took from one of the papers and seminars of dialysis, which clearly shows that based on these two factors of protein binding on the x-axis and molecular weight on the y-axis, depending on where the particular drug fits in, you would either do hemodialysis or hemofiltration or even hemoperfusion, and if they are very, very large, then therapeutic plasma exchange may be required. So these two factors are probably the most important in terms of our decision of deciding what renal replacement we want to offer. I've covered this aspect of endogenous clearance, but just to state that any drug which essentially has a very good clearance per se can get compromised when the patients have kidney injury. So if they've got acute kidney injury, then sometimes the endogenous clearance really goes down, and that's where supportive treatment like dialysis could help. Coming to volume of distribution, and again, volume of distribution largely is 0.6 times the body weight. So if somebody is a 60 kilo person, you would roughly estimate that the volume of distribution is about 36 liters. And it's calculated, it's a calculated number. There is no real estimation of volume of distribution that we can do. And depending on how much this drug is distributed across the ECF and the ICF is the basis on which you can decide whether in a particular poison this form of renal replacement will be helpful. So if drugs have a very high lipophilicity and bind to proteins like albumin, or they have a high tissue concentration, that's where with a large volume of distribution, you may not be able to eliminate this drug by doing even prolonged dialysis. On the other hand, if the volume of distribution is slightly lower, then these toxins can be very effectively cleared, and I will show you a few examples of how we deal with this. So looking at some common drugs that we encounter in terms of clinical practice where patients end up having organ dysfunction. On the left-hand side are some of the drugs which have a large volume of distribution where dialysis or any renal replacement therapy is unlikely to help. On the other side, drugs like all the alcohol consumptions, methanol, ethylene glycol, even lithium, the barbiturates and salicylates, all these drugs have a very relatively small volume of distribution where renal replacement would be able to help. So this is a schematic in terms of how, in the ICU setting, how you will decide on what form of renal replacement. Based on the four factors that I mentioned, you first have to assess the risk and benefit of the extracorporeal treatment itself. If you are certain that you are going to be able to give an antidote and reduce the effect of the toxin by itself, then you may not need to even do dialysis. For example, if the patient's endogenous clearance of the drug is also very good and the kidney function is actually preserved with a low volume of distribution, then you may not need to do extracorporeal treatment. At the same time, when the drug is very heavily protein bound, then you would have to look at plasma exchange. As I mentioned earlier, the protein bound molecules cannot be removed by the other forms of renal replacement. For some reason, if they have a particular toxin which clears better with hemoperfusion, then you would want to do with hemoperfusion. And depending on the molecular weight, as I showed you a few slides back, what form of renal replacement you would use would be decided based on the molecular weight. So just a word on peritoneal dialysis. This was traditionally done as the main renal replacement therapy probably 30-40 years back. But now with access of hemodialysis and renal replacement therapy in the form of CRRT, we are using less and less of peritoneal dialysis. Not that peritoneal dialysis is bad, but just that the clearance is not very effective. And when we are talking about a short duration in terms of trying to remove as much toxin as possible, peritoneal dialysis may not be very effective. It's very, very slow in terms of removing the toxin. So in resource limited settings where you have no other option, yes, you may end up doing peritoneal dialysis for some small molecules, but other than that, you would not want to do peritoneal dialysis. These are some of the drugs where, based on the serum concentration itself, you can decide as to whether you would provide hemoperfusion versus hemodialysis. So phenobarbitones, theophylline also is something that I've encountered a couple of patients in my career. where we had to dialyze because of the toxicity to the CNS. And methanol, some of you might be aware about the methanol outbreaks that had happened across Mumbai many years ago, where dialysis units across all municipal hospitals were filled with tons of patients who had methanol intoxication and renal failure and blindness. So these are some of the examples, the common drugs that we usually end up removing by doing CRRT or hemodialysis. Methanol is one of the commonest, and fortunately we have the ability to measure the serum methanol levels, and you need to continue the renal replacement till the level or the concentration goes below 25 milligram per DL. One thing that you need to guard against is that methanol, there might be a rebound effect when the metabolites of methanol are excreted by the organs, and that's where you may have to repeat the renal replacement therapy when you deal with methanol intoxication. Similarly with lithium, patients who are bipolar, who are taking lithium for a long period of time and have accidental ingestion or a higher dose than prescribed by their psychiatrist, that's where sometimes we end up doing CRRT to remove the lithium from the system. Looking at other common drugs, valproic acid and theophylline, as I mentioned earlier, in this, since these molecules are not that big, you could get away with intermittent hemodialysis or even hemoperfusion and stabilize the patient. A renal replacement therapy in theophylline again needs to be continued for a longer time, and you need to watch out for rebound even with theophylline. One other common drug, and a lot of hype about metformin and its benefits. Obviously, we all know that it's the first-line drug for diabetic patients. Rarely it has been reported that lactic acidosis is a complication of metformin, and this is specifically seen in patients who have renal dysfunction. So you need to be a little careful about giving high doses of metformin for anybody who's got a GFR of less than 45. But sometimes if there is accidental consumption of metformin, then these patients are not able to excrete the metformin, where standard or high flux dialysis would be helpful in obviously correcting the lactic acidosis which is because of metformin, but even remove some part of the drug which has been consumed. So metformin is one other indication where we have started using and seeing maybe a couple of patients every year or two where dialysis support is required. Again, one drug which is very commonly used in the ICU, and I specifically wanted to mention that vancomycin and even isolated use of vancomycin and its nephrotoxicity is emerging, and we are using vancomycin as the first-line drug for gram-positive infections, something that you need to be aware of. And again, if vancomycin accumulates, and fortunately again for vancomycin we are having drug levels which we can estimate, if the levels are very high, then doing a convective clearance with high-flow CRRT might be the best way of removing vancomycin. So these are some of the drugs again which I have mentioned in this table. So in the interest of time, I don't want to discuss every drug, but these are the standard ways in which you would want to remove some of these drugs from the patient. And hemodialysis, hemoperfusion, and hemofiltration, these are the three treatments which are required for specifically a particular drug as mentioned in this chart. So my concluding remark, friends, is that we don't deal with drug toxicity, fortunately, that commonly. But whenever you come across, you always will have to work with your ICU colleagues, and nephrology colleagues would be involved, especially if there is organ dysfunction and acute kidney injury, where some of these drugs can actually lead to a lot of mortality, where sometimes removing these drugs by all the mechanisms that I mentioned about hemodialysis, hemoperfusion, hemodiafiltration, and even plasmapheresis in extreme circumstances would be helpful. We also need to be aware that sometimes patients take multiple drugs. So you may have to do sequential, maybe start with hemoperfusion if it's a phenobarbital overdose, and then for some other drug you may have to do CRRT subsequently. So you need to be flexible depending on how the patient is tolerating. We all know that conventionally patients are unstable. More and more patients are now put on SLED or CRRT. We don't do the regular hemodialysis because the patients may not tolerate it. So that's something that needs to be considered, and a teamwork with the ICU consultant and the nephrologist on board probably will be able to deal with this situation and give a better outcome to these particular patients. So thank you for your kind attention, and sorry for not showing the earlier slides, but in the interest of time, I would stop here and I would ask for any questions or comments from the audience. Thank you very much. am I audible?
Hello.
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 नहीं सर आप बात कर लो.
Jatin, hi, Ravindra here. Can you hear?
Hi, Ravi.
Hey, hi. Yeah, so thank you so much for that lucid and kind of a very
Thank you for having me. Sorry, I couldn't be there in physical presence, but it was great to see your program and wonderful program. I think it's a wonderful initiative, and I think you should try and do this every year.
Yeah, thanks. I mean, we missed you. Yeah, but we'll try to do better next year. Thanks a lot, dear. Yeah.
Thank you, Dr. Jatin. Now, we'll take a case-based discussion with an intensive care perspective. I'd like to invite Dr. Shantanu Bagchi, Consultant Critical Care Medicine, Tata Memorial Hospital, Kolkata. Sir is also the academic in charge, Division of Respiratory Critical Care Medicine at Apollo Hospital, Kolkata and IMI Kolkata. Welcome you, sir.
Thank you. Just give me a second. एप्पल होने से थोड़ा इजी हो जाता है. स्किप भी नहीं होना. थोड़ा प्रेजेंटेशन ऑन कर दो. कहाँ पे? वो ड्राइव कन्वर्ट होने से कन्वर्ट होने देना. सी ड्राइव, ई ड्राइव जो ई ड्राइव ये केस नेफ्रो 2 ओपन कर दो बाद में. राइट लेफ्ट. So, good evening. Are you all tired? Don't stay. Let's go on beyond anyway. So, before we proceed, how many of you are the trainees, ICU trainees? Great, maximum people. That is my target audience anyway. But one disclaimer: who is going to do this discussion? First question to all, not in the trainees. Who is going to do this discussion? I need answers. I'll come down. No worries. Who is going to do the discussion? कुछ तो बोलो अरे. Both of us. So see, this is going to be a case which has already been discussed. Okay. And I need to go up. So you need to answer because the topic has already been discussed today. We'll be going ahead. We'll try to get some of the practical points from this case discussion. So this is an elderly lady from Mumbai itself, residing in a class Juhu, good sea view apartment, but alone. She's staying alone. Lot of maids are there, but none of the maids are staying with her all the way. So she is staying alone, she is otherwise active, does all morning works around regularly, and now she has some comorbidities also. There has been an undiagnosed arthritis of the, she has some hands pains, small joint pains and all occasionally. She is not on medication for that. She had a history of TIA around 10 years back, and at the same time she got diagnosed with some hyperlipidemia also. So she is on some medications like ecosprints, Atrova and all. Those common things are going on. No proper treatment, as I told, for any other thing. Now, this lady has been brought to your ICU. Consider this as your case in the exam, real case in the exam. Actually, that has been made in that way only. So this lady has been brought to your ICU first with a particular history. What is the history? See, she used to stay alone. She just fell down at her home in the toilet or washroom somehow, and there was no one. She could not get up. She fell down yesterday evening or yesterday afternoon somewhat. And entire evening, night, no one was there. She could not call anyone because she was in the washroom and all. Next day morning, the first morning mate came, and that lady found her in this condition. So, now, when the patient has been brought to your ICU in the emergency, then got shifted to ICU, one thing you notice, there is no active bleeding going on, right? Your discussions will be coming, your part is coming. Let me do the initial part, you will be answering subsequently, don't worry. So, one of us, imagine I am doing the initial examinations. So, she is otherwise conscious, alert, and she is a little bit anxious. She has some generalized diffuse marks, bleeding marks, petechial marks, and throughout her body. It's not located to in a particular area. She has some sort of tachycardia, blood pressure might be normal because she is not an hypertensive, non-hypertensive. She is not having any breathing difficulty. Abdomen and all are soft. Extremity is a little bit not so warm and all, but okay. She has got a ejection systolic murmur also, but that is not radiating towards the neck. Abdomen and all examination respiratory parameters all are within normal limit. She is not requiring any oxygen, right? So now my part will end with describing this local examination also. See, in the right hip area, she has some bruise mark like this. Okay, so your basic history is over, your comorbidities are over, your initial examination part is over. Now comes your role. Again, I need to come down. So what will be your next step in the assessment? Imagine that is a viva question in your long or short case in the exam. Someone needs to volunteer here. We will finish it up with this. What will be your next step? Once you have done this history and examination, what will be your next step? Pardon? Imaging. Imaging part is there to be activated. Before that, imaging will be done, but not now. Perfect. Perfect. We are all fond of that age-old theories of ABCs. So in trauma, this is a case of somewhat trauma, right? She fell down and all. So in trauma, does it finish with ABC or does it need some one or two more letters? D. So tell me the full forms. Anyone? Exposure. Fine. Just stopped working. So anyway, we'll go in that way only. भैया ये सेंस नहीं कर रहे, ये कौन सा आ गया, वो जूम सेव हो गया इसलिए नहीं सेंस कर रहे. पीछे वाला स्लाइड में जाओ. हाँ ठीक ठीक. इज इट वर्किंग नाउ? हाँ ठीक. So we have done with this initial survey and all, primary survey ABCDE that you have done with. Next step, though it's a nephro conference, but not because of that, as because she was having discomfort, so she was catheterized also. Next, what you will do? Right? What you are expecting in an ABG? Maybe acidosis. Good term. What type of acidosis? Pardon? Metabolic. Okay. So you are guessing the case. And as you were suggesting, one doctor was suggesting that imaging will be done. Imaging has been done. So as the ABG sample has come, before that you have taken the samples also, like blood and urine samples. The urine was like this. This was the urine for the patient. Very characteristic. So this is your ABG sample you got. but the faculties are not allowed to answer. So what are the abnormalities you are finding in this ABG? Hyperkalemia, not answer in an exam in that way. Go stepwise. pH, normal, abnormal, acidotic, alkalotic. Acid. You cannot see. Oh God. pH is 7.31. Okay, next what parameter you want to hear? Bicarb. Why bicarb in the next parameter? Student failed. It has to follow. Yes, someone was telling? So PCO2 is 50. Then next parameter you want to hear? pH, PCO2, then PO2. Bicarb. pH, PCO2, bicarb. So bicarb is somewhat around 24, 25, like in that range. So what type of acidosis you are getting here? Is there any acidosis present? Respiratory acidosis. And as one doctor was suggesting, the imaging was done. Firstly, because there was a history of fall, so CT scan was done. And see the finding in the CT. What is the most prominent finding here? What hemorrhage you are getting? In this CT, I hope this is visible. SH. Okay. Anything else? Huh? Cerebral atrophy. Atrophy is not a pathology. Okay, good. Dilated ventricles. Okay. Anything else? Anything else? See, the intention to interact is not to demean anyone, because I have been also a student few years back. My teachers gave presentation, Dr. Kaur and all. So just to make you comfortable for your exam, today or tomorrow you will be having the practicals. Na? So it's nothing big deal. If you participate, beta. Bilateral because of this thing. Frontoparietal contusions you are finding. Okay. Anything else? Nothing else. I also having all those findings, but sadly the radiologist informed that there is a normal CT scan. Nothing was there. So we proceeded with the lab investigation that came. And one more thing, what we found in the lab, there was no fracture in the hip. I didn't share. I could not share that one. The urine dipstick was showing 4+. Right? Urine dipstick I am saying. I am not telling urine microscopy. Can there be any difference? Like urine my dipstick is showing 4+, 3+, microscopy is not showing any RBC. Is it possible? It is possible. Excellent answer. When? Done. Then there is no need for slides, I guess. So there was a sinus tachycardia and the ECG also. So before we go into that discussion about the pigmented urine, what should be your urgent matter or concern in the management in this patient? If you want, I can go back to the ABG or the lab. You want me to go back? Okay. In the lab, okay, let's focus on the lab only. ABG will be difficult to read. Done. So let's go back to the ABG also. Potassium was 7. So the correction of the potassium is your first priority in this patient currently, because airway, breathing, circulation all are fine. So it's a very easy question. Still, I am obliged to ask, what are the things you will do for potassium correction urgently? Calcium gluconate. Do you find any changes in the ECG? No. So what else you will give as a first answer? Dextrose insulin. Right. And one is dextrose insulin, second is beta-2 agonist, and this one, right? So there was a feature of hyponatremia also in this patient. Can you postulate? I don't have a correct result, but can you guess the reasons which is possible to cause a hypernatremia in this patient? Dehydration. Perfect. That is the answer. And some other causes also can be there, hyperaldosteronism and all. So coming to the pigmented urine part, as someone was suggesting very rightly, so these are the causes where you will find the urine dipstick being positive, but the microscopy is negative. So it can be hemoglobinuria, it can be myoglobinuria. So what are the other causes of a pigmented urine or a dark urine? See, the focus on this part, the hem positive, the pigmented urine can be caused by this. So there can be heme negative causes, there can be exogenous pigments also. So heme negative causes can be your hypovolemia, can be your bilirubin, direct bilirubin getting up and all. There can be porphyrins in the system, hyperporphyria, those things will be there. So those will cause heme negative dark urine. And there are other exogenous dyes and drugs. Rifampicin is pretty common, you might be aware, you have seen people having those things, nitrofuran and again another thing. So these are the causes. Coming to other investigations. First, what the other investigation we could have done or we should do now? CKD? CP? No, I am a bad examiner. I need full forms. I don't understand. You will not give you mark. Creatinine? Kinase. Correct. Anything else? Can think of some? Ultrasound also. Like can be an abdominal pathology or local pathology if it is there. If there is any CKD changes because potassium is on the higher side. And if you remember the creatinine is also not normal. So just look for that. So we did both. CK came like this, 68,000. And there was no chronic kidney changes in the ultrasound. So I don't think after Dr. Gunjan's nice presentation, you are not in this state what I was. Like so much confused about the diagnosis. No, nah. You got the diagnosis? What is the diagnosis? Perfect. So what can be the causes of rhabdomyolysis? You, the student, have to answer, mug up this many answers. Possible? Not possible for me. So I will be very happy if you kindly go through, try to go through the headings and tell me in this patient what will be or what are the possible causes of rhabdomyolysis in this case. Oh, perfect. One I got. Probably one or two are already hidden in the answer. Maybe. Ischemic. Dehydration. Okay. And rhabdomyolysis itself will not be caused by dehydration. Anyway, fine. Statins I got. Anything else? I can give you a hint. All the three answers I am looking for was in the history of the patient. One is statin, that was there in the history. Anything else? In the history. Try to remember something for which she was not on any medication. Some arthritis can be a cause. And what was the history? How did this injury happen? She fell down. And why so much complication happened? Because she was unattended. She was lying down in a fixed position unattended for more than 16 hours because of her living style. Right? So we got these causes which was responsible for this patient. Okay. Now some theory, I am sorry, but just to touch upon, this is the definitions and all. Remember this part, if you are getting a myoglobinuria, if you are getting an AKI, patient is already in severe rhabdomyolysis state. That is one. No theoretical discussion much. This is a case report, old case report in 1941 it came up, and there they have given that there was kidney changes, initial interstitial edemas and all that was present. This is an old case report. I just had to keep because of this history part. We are very fond of histories. Mechanism, not going to theoretical discussion, only this part. There is one component is renal vasoconstriction, second is intratubular cast formation, and third is direct toxicity of the myoglobin. This much you remember. Rest you can read in or write in your exam. In this triggering factors and in this another theoretical slide, only one thing I would like to focus on in this line, the classic triad. What is the classic triad? Muscle pain, loud. Muscle pain and weakness and dark urine, correct? But what is written below? It is present, you can get this triad only up to 10% of the bill, mostly absent. That is the point to be taken from this slide entirely. So, coming to the previous slide where we are discussing what investigation we can do now. And very rightly you have mentioned, very nicely you have mentioned that creatinine kinase can be done. Is it sufficient? No. I need a voting for this. No or yes. How many for no? 1, 2, half, 1 and half, 2, 1, 2. Then, so they are telling creatinine kinase is not sufficient for the diagnosis. They are telling. So everyone else is telling creatinine kinase is sufficient, na? Yes or no? अरे कुछ एक तो option तो देना है. It's sufficient. Okay, let's see. What does the evidence say? First of all, the majority, as see, I am always in favor of the majority. I am very biased. So I am showing something which majority is telling. So all the literature was there. They have taken some value of the creatinine kinase as the diagnostic part for rhabdomyolysis. But there was no consensus on the value, right? And also people have defined rhabdomyolysis solely on the basis of creatinine kinase. Mild, moderate, severe. So the majority wins. That's the apparent, but it is like IPL. Last ball, people situation changes. How it's changing? Can anyone explain this graph? Can anyone explain this graph? Very easily visible, I guess. There are two things being shown. One is the creatinine kinase and something else is there. What is that? Myoglobin. Why this comparison has been made? It rises faster. Creatinine kinase is late to rise. So it will not give a proper diagnosis every time. Diagnosis get delayed because you have a cutoff, 1000, 5000, that the value will come after 2 days. So diagnosis will not be made. So no. Let's come into this more. So that what we have discussed now. So other than creatinine kinase, what else you can get? You can get some features like tumor lysis syndrome. So what are the features you will see? There will be some hyperkalemia. There will be some initial hypocalcemia. There will be some increased phosphate. Can anyone tell why this difference of color has been made between BUN and creatinine, urea and creatinine? Is it by mistake or for some reason? Probably by mistake. Huh? Much more. The reason is being given below. The urea creatinine ratio changes because the rise of creatinine because of the muscle injury is much higher than the urea here. So the urea creatinine ratio also changes. And this one I would not ask you to remember much because this is more of a theoretical. The AST part, because source being the muscle, so it rises and all. It's more of a theoretical. So remember, there will be electrolyte changes, there will be creatinine kinase changes which are more late, and there is compared to urea more rise in creatinine. This much is clear. Have anyone heard of this scoring? Yes, no. Again voting. All no. All no. Even the faculties are also saying no. I am sure faculties know. Oh, you are neutral. Okay. Now one of the, anyway. Everyone know. I don't believe this. Because everyone is like me. During my residency I also didn't hear of this one. Sure, no one has heard of this scoring. Seriously. Okay. अरे भाई ये क्या हो रहा है एक एक बार में? See, this is a scoring. This is basically epidemiological scoring. It is basically based on the age, sex of the patient, some of the on-admission parameters, phosphate, calcium, and on those. Based on those parameters which you can see on the admission of the patient, you can do a scoring. I will not keep it much like undisclosed. You can develop a scoring, and that scoring can help you in what? Not in the diagnosis. That scoring can help you for two things. One is your management plan, like fluid and how much fluid you will be giving, and it can prognosticate also. Like if the score is higher, the cutoff Ddavp is around 6. If it is going more than 6, then one is the chances of AKI is more in that patient, and secondly, the fluid requirement should be more. Remember that, because there is some complex part in that. These parts you try to remember. This is practical part. This will be asked in your exam. So try to clear out your doubts. That will be easier for you. So this score, these are the parameters: age, gender, admission, creatinine, calcium, creatinine kinase, phosphate, bicarb. All those parameters you need to see, and you need to get a score whether it's more than 6 or less than 6. Can anyone would like to volunteer? What was our patient? What can be? Just in our patient, what can be the score? More than 6, less than 6? More than 6. Very good. From what parameter you are telling? You are right. Age, gender, and good. Okay. So This paper came in 2013 and all. Now, this has been validated very nicely in this 2016 article. What is the validation? The validation is whether, again to the same question, whether creatinine kinase is enough for the diagnosis. So what they have said is that creatinine kinase is not very sensitive for the entire diagnosis. Compared to that, if you calculate this McMahon score, you will definitely get a better sensitivity for the diagnosis of the condition, as well as it will be helpful for your prognostication also. So, when you will be using this scoring more? When this creatinine kinase, see, it has to be used in comparison, in tandem with your creatinine kinase value. So whenever you are getting a baseline creatinine value which is little bit borderline, then try to calculate this score and formulate your management plan. So is it so straightforward? Again, I guess, no, it is not. Anyway, ideally what you need to do is that before going into the management, ideally what you need to do, you need to check the creatinine kinase as well as this McMahon score. If the score is more than 6, if the kinase is more than 5000, then definitely the more fluids has to be given. We will discuss in the management part. And even if the score is more than 6 and your creatinine kinase which starts to rise late, so you will get an initial lower value of creatinine kinase of 1000 to 5000. There also, in that borderline range of creatinine kinase, if you are having a McMahon score more than 6, then definitely you can think of giving fluids more. Patient will probably be requiring fluid more. So what does the volume depletion creates problem? This you should answer, although it's written here. But why volume resuscitation is important in this rhabdomyolysis patient? Instead of bleeding, you can tell yourself only. Cast. One is preventing cast, far away, and anything is correct. Anything else? Perfusion, hydrate the pathway, clear it out. So how much fluid? Who will need fluid? There that McMahon score part is also will be coming. So there are so many queries like how much fluid, which fluid. Very many people, you will see most of the studies they have done compared with normal saline. Am I very fond of, anyone is very much fond of normal saline? You should say proudly yes. No. Yes. Who said yes? Ah, great. Excellent. I also love to disagree with you. Anyway. So how much fluid? Who needs fluid? First, see the role of creatinine kinase and McMahon score here. See how they have defined this thing. So you are having a creatinine kinase less than 5000. See this box you follow. McMahon score less than 6. Creatinine kinase less than 5000. Try not to hydrate more. That doesn't mean that rhabdomyolysis you have to hydrate always, because overhydration will go into additional kidney injury, right? Second, the other end of the other end of the spectrum. Creatinine kinase more than 5000 and McMahon score 6 or more, definitely hydrate. This part is clear. One end both are low, don't do overhydration. One end both are high, so definitely go for hydration. And there is something in between where the creatinine kinase is borderline. There look for the McMahon score. If the score is more than 6, go for hydration. Right? This is how the combination of McMahon score and creatinine kinase is important. So how much fluid? Any guess? Perfect. Almost. Perfect. Almost. Because urine will come once you are giving fluid. So initially how much fluid you will give? You don't have any ultrasound machine in your bedside. Nothing. You are working in a PHC. Any values, anything, any guess? Don't give that kind of answer. No. Something about hour, minute, that is more comfortable. बोलास कितने में दोगे 30 minutes में फिर बैठ जाएंगे ऐसा तो नहीं.
300 to 500.
Perfect guess. Anyone who have told is very good. So although in this diagram, see, this is not my choice, this is not my opinion. Who has given this opinion? This is 2022. Emergency medicine and surgical people have given this opinion. You can download this article also. So they have given this volume challenge of around 150 to 200 ml per hour But practically, in this same article, if you go inside, you will find you can start with 400 ml per hour. So the guess was absolutely correct, 300 to 500 within that. And the target urine output you should initially will be very high. Why? The answer has been given here. Anyone can tell. Why you should target a higher urine output? Cast 1, and if you don't get a higher urine output, what you will do? Means why urine output part is important. The urine output part is important because if whatever you are giving and nothing is coming out, then that edema will further worsen the AKI. Right? So which type of fluid? As the majority was telling. And we have some evidence, again, not my choice. So in this study, they have found that there is not much mortality or any outcome difference when the possible cause like Ringer's lactate with the potassium content was compared with a fluid which used to be very favorite, and even nowadays also in the western countries it's pretty favorite that normal saline to be used, but it doesn't give any advantage. Normal saline doesn't give any mortality or outcome benefit when compared with Ringer's lactate. So you can safely go ahead with Ringer's lactate, right? When to stop fluid? They have given this guideline of 5,000. Fine? Agree with that? Happy? No. Perfect. Why you not happy? I am also not happy. But can we explain why we are not happy, like this baby, me and you, all three of us are not happy with this cutoff of 5,000? Something with the creatine kinase discussion we did now. Not going to the score, only creatine kinase. The draft. Late. So if you just sit for this value, it will not fall soon. Unnecessarily you will keep on overhydrating. So that is why following a blanket value of creatine kinase is never advisable. So what should you follow? Urine color, okay? And I have given this. Urine output, clinical features, and whether any features of volume overload is there. Then you should be cautious. Now, these two things, diuretic bicarbonate beneficial, there are a lot of theories that it will flush out the kidney, it will help preventing the pigmentation to precipitation of the pigmentation, all those things. There are theories on this, don't take this snap, because I will not agree on this. See, these are the studies, and as I was telling, most of the western studies, they have compared the normal saline with bicarb, and what they have found? They have found nothing significant, no specific benefit. At the end, I'll give you the final recommendation from 2023. So you will see what are the recommendations. So other corrections, potassium, your calcium, phosphorate, all those things correction should be done. But you need to remember calcium correction is a double-edged. There will be hypercalcemia towards the end. So you need to be very careful for this correction. Role of any dialysis in this patient? What is the recommendation? No recommendation. In favor of mode, in favor of your dialyzer, in favor of indications, no special recommendation. This is like other patients only. Same thing. So you will follow both. What will be your choice in an ICU? This you should answer. What will be your choice in an ICU unstable patient coming with this problem where you need to dialyze? Perfect. So the course has been very much fruitful for sure. I fully agree with this, happily. CRT, because this myoglobin, what is getting washed out, that will be again come back with a small duration of dialysis, intermittent dialysis. So anyway, I need hardly 5 minutes more. So CRT is your of choice. These are the clinical conditions where dialysis has been found to be useful. Again, this is a reference from 2019 only. They are like your Ddavp, toxins, long-term confinements. In these areas, you will find that the use of dialysis has been useful. So this patient also SLADE was done because in that setup CRT facility was not there, and those are the parameters, positive parameters we got. These are the different complications, not going into it, skipping this slide. This is the different prognosis, again skipping this slide. These are the summary of the problems you can find in this patient, and this is my last slide where you will see the recommendations. This is 2023 Kidney International Journal recommendations. So this is rhabdomyolysis induced acute kidney injury treatment. and they have given only one recommendation, that is intravenous fluids is the only properly recommended choice, like hydration depending on the scoring and values. This is the only given recommendation for this condition. Rest all are controversial. With this I would like to conclude today's discussion. Sir.
That was really enlightening.
Sir.
I learned again all
Sir,
over.
please.
This mode of RRT, what's the rationale of using CRRT?
Sir, see, it is assumed that there will be an ongoing trauma going on. Patient who is needing that bad, needing an RRT to be induced or implemented, so there will be myoglobin injuries going on. So if you are going for a short correction, then it might not be sufficient. So when the patient is initially coming with that much instability, if you have the facility of longer duration, you can go for CRRT or long-term SLADE also. It is about the duration what we want to focus.
No, but are we removing the myoglobin and then that will
No, but it can cause harm little bit. So that's why being on the CRRT, you will be clearing out all. That's why. No, but the other toxins which will be there, that will be useful. That's why.
During my residency, there was one patient with fibromyalgia. I remember we used to dialyze him 2 times a day.
2 times a day. So you.
So catabolic.
That was I mentioned also.
That high. So even before we would stop the first session of dialysis, we would ensure the potassium is less than 5. And in the evening, on repeating once again, we would find, it has gone up to say 7.
This is the reason.
Once again dialyze him.
Okay, that is the reason, because it will come back again. So once it is in a continuous process, the corrections become better, because ultimately you are treating the metabolic acidosis and the hyperkalemia, right? So that corrections become better when it is in a continuous modality. This is the reason, as far I understood. Yes, sir, madam. Query है sir, एक question है. Please, it's great to get questions now.
Hyperkalemia is going to kill the patient and CRRT is not going to correct the reaction very fast. So why not we are considering SLAD here? Because
see, hyperkalemia, other corrections are also going on. See, the CRRT term is coming as an interchangeable factor with SLADE, like you were seeing in this machine there, where you can plan the SLADE for 24 hours. So the idea is to keep the correction process on in the initial part, so that this acidosis and hyperkalemia doesn't come back fast. That is the idea. So that was my intention to say. Not a short duration, 2 hours of dialysis, not that. So you need to repeat. What madam was telling, the same thing happens, that you need to repeat the dialysis procedure again. That will be more cumbersome than setting a longer duration, 12 hours, 16 hours like that. That was the intention to explain. Is it clear?
No, but still starting CRRT, I'm not getting convinced with that.
The
Starting
duration, it can be SLADE also.
Yeah, exactly. SLAD for 6 hours or to 8 hours also.
10, 12 hours
because
also.
that is going to correct the life-threatening hyperkalemia fast. But
See,
CRRT
other
will not correct it
hyperkalemia
fast.
corrections are going on. You are correcting the acidosis also. Everything will be going together. So there with an unstable patient, that will be your first choice in an ICU patient. But if you are imagining in a stable patient coming in an emergency, going to elective dialysis, then you can go for only SLADE for 4 hours, 6 hours like that. But that also will be a longer duration.
So it's just a duration, prolonged duration.
That is the focus.
You can do even like a normal dialysis for a prolonged period of time. Then heavy catabolic will generate more potassium.
Yes.
So just keep on removing, because they will not recover soon. So that's the idea. It's the duration of dialysis. I don't think it's one therapy or something. Give them prolonged.
Right. Absolutely.
The basic principle is you start very hard. Like you have to do a large exchange. In our setup, sometimes we put 2 dialysis machine or 2 CRT machine, exchange around 10 liters. May not be possible everywhere, but whatever the max you can go, if the patient tolerates it, you should be going for that. There may be a situation that you're still not under control of potassium, so you have to play with the dialysis bag also. So make sure that there is no potassium in the replacement, no potassium in the pre-filter, no potassium in the dialysis. So usually it does work, and if you put the high dose CRRT for first 8, 10, 12 hours, then situation is under control. But the clue is to continue it for longer period of time. Otherwise, they will bounce back again.
If they will not put goal is not achieved.
Yeah. Yeah. See, it depends on where you are working. If it is not a resource poor situation, I would go for dialysis early. If you are not able to correct metabolic acidosis, hyperkalemia, if the patient is worsening, dialysis early. I'm not a very good big fan of achieving a urine output and clearing the myoglobin or whatever. It rarely works. If the patient is in ICU for rhabdomyolysis, he will require dialysis. That's what happens. You cannot treat them with only fluid.
What are you doing?
I would not. Because we have facility to start the dialysis early, I will not go for diuretic. Unless you are like life-threatening hyperkalemia where you require high dose of loop diuretic to buy some time.
So, very important concept what Dr. Sanath has just elaborated. So, my one question to all of you, so how much maximum dialysate you can set on the CRRT machine? Now, almost you have finished your CRRT station. Can somebody answer? And this is one of the conditions where, you require a high dialysate flow actually. So, how much can I know? Sorry? Oh, any other answer? So you can go up to 8 liters. And he is actually right. You can at least join 2 machines, achieve a dialysate of 8 liters. So the idea is rhabdomyolysis is not a single organ system involvement. There is a component of cytokines term. 90% of the patients, the patient come with inotropic support and he is in multi-organ failure after 24-48 hours. So you have to have the capacity to handle that situation also in your ICU. So you can do an extended slate just like sir told, or if you don't have the facility for that, like for example patient is already in triple supports, bad liver failure along with multi-organ dysfunction with AKI, you can consider CRRT and with a very high dialysate, because potassium is the only thing which is removed by your dialysate, higher dialysate. The more higher you keep, the more potassium you will be able to remove. That is what is the main crux of rhabdomyolysis. So thank you. Any other questions? Any other questions regarding this? So I think with this we come to the end of the lecture. Now the question is, we have 4 to 5 stations of this toxicology, but in the interest of time, I feel we should let's postpone it, because most of them have gone and most of them look tired also. So if you agree, we can take 2 or 3 sessions. Otherwise, I think we can come to the end of today's session, and we can do some 5 to 10 minutes of interaction, and then we'll disperse. You will be okay?
We can connect the Zoom meeting tomorrow.
Again, see, so since last 3 days actually we are in the either Zoom meeting or physical meeting. Okay, so at least give 1 day break. Sunday, I think everybody should enjoy. We can definitely do it, because every weekly we do Zoom meeting. I can request all the faculties to take 1 session on this case discussion, and we'll send you the link. That is for sure. Okay, that we can assure. So with this we come to the end of this 2 days extensive course on CRRT, hemodialysis, nephrocritical care, and I would now request Dr. Tapas to felicitate Swapnil. So Swapnil, please come to the stage. I think you are the only person who has left for felicitation, because you are also yesterday not available. So Tapas, please, to Swapnil.
So one thing I would describe about Swapnil, he is the man behind the show, and whatever you can see now, it's not only that who are on the stage, they are only controlling. He is the man who is controlling from the ICU, he is the man who is controlling from his home, he is the man who is controlling from different areas. So thank you Dr. Swapnil.
Just 2 or 3 minutes I'll take, if you can all sit. Now just a genuine feedback from all of you. If some of you who are coming from outside Mumbai or inside the Mumbai any hospitals, they want to give some feedback or they want to say something, they are most welcome. Can I expect 1 or 2 of you to come to the stage?
Very over.
Omkar, where is Omkar? let one or two from nephrology side also tells us.
Come on, tell something, say something.
Come. Now Omkar is there. Come Omkar. Come.
Omkar, you have to say 2 good lines.
She's from nephrology. Yes. Come. So what do you feel from your nephrology perspective? Because we are intensive, so what we have...
No, so it was a good learning experience. Like for us as a trainee, it was very good. Like we learned the basic management of main nephro cases, how it's managed in the ICU, which we normally are not able to see. So it was a good learning.
What was the best part of the last 2 days? What was the best part that you liked it the most? Like this was the highlight.
So the yesterday's hands-on training was good.
And what would you suggest to come in the future courses?
What do you feel that more and more things to be incorporated? In which area what more?
Should it be more case discussion rather than the theoretical?
The more case discussion which we had, the last case, rather than the theory, it would be better if we take a case scenario and then go into the theory.
So Santanu? Santanu is good for next time.
So firstly, I'd like to thank, from all of us, the organizing committee. The last 2 days were really helpful. And so touching on what you said, especially in the second half yesterday, the hands-on training that was there was really helpful, because that is not something we get to do on a day-to-day basis, especially as residents, because there's a lot of work that is usually going on. And the last case on rhabdomyolysis which Sir did was especially useful, because it runs us right from the time the patient comes, when we see the patient in the ER, to the patient being managed, what has to be done, how the patient has to be managed, and eventually how you conclude with the treatment. So I think that is something which really helps. So we did one topic on rhabdomyolysis. So similarly, other causes of AKI, like be it a pigment nephropathy or a tumor lysis syndrome, if we could cover those topics in detail as well, it would help us in our day-to-day practice when we see patients, and it help us to manage them more effectively than what we do prima facie before we get in touch with our consultants, like when the patient comes to us in the ER. So I think that is something that would really help us, and that is something which we can incorporate going ahead.
Yeah, about selection of speakers, were you satisfied with the selection of speakers?
More than satisfied, sir.
No, this is a very important feedback. I think we should incorporate more cases, like what he rightly told, pigment nephropathy and other very practical cases actually. Yes.
Sir, sorry to stop you there. Like the way you ran us through this topic, this is something that will stick the next time we come across such a patient. So if there are more topics that are covered like this, it'll be more helpful for us in the long run, and I think it'll help everyone, especially the trainees, more. So I think that is one thing which we could incorporate.
Yeah. Anybody, Pallavi?
Anybody from critical care? I think the outsiders, anybody can come. Doctor? Dr. Shreya. Dr. Shreya, you can come.
This is the first time we've done it, so next time will be better and bigger, I think. The aim was to put everything on practical basis, but it's very hard to do that, and we have some clear idea now that people believe practical ones are better rather than theory, so next time that will be the major thing. I just take the opportunity to thank the people from Apollo who are really great to do such a endeavor that we can do this course pretty well, I believe. I would ask you guys to fill up the feedback form. There are 15 responses out of 82 now. So take your time, go home, that takes 5 minutes, and open your heart on it, write whatever you want to. You don't need to put your name also. So we don't know who has written that, but at least your views are very important, so that we can correct things, make it better. So at least I want 50% of you guys to give a review of this, so that we can work on it, okay?
Oh, I have received few feedbacks in my WhatsApp. I will share with you.
Sure.
Yes, sir.
So it was a really nice experience, and as Omkar rightly said, that we need more of interactive sessions which will help us. Coming to the ICU intensivist part, so yesterday's hands-on was really good because the nephrologist will just come and write the orders and leave. It is the intention.
It is for you. Now the students are doing now. I'm not able to do that.
So we are the ones as registrars or junior consultants who are available in the ICU for the entire day, and to handle the CRRT machine, definitely it's not an easy task. And it was a really helpful session yesterday, because the problems that we face in our practical life, to call the technician and he is not available, and all those technical aspects were really nicely covered. Yeah, so that's it.
So who runs CRRT in your hospital? For CRRT? Or do you use CRRT over in your hospital?
Yes, so so I am practicing in Kokilabin Amhani.
So who runs the CRRT over there? You operate
nephrologist primarily?
No, the technician only operates
Who put the lines, who set the CRRT machine? Technician?
Yes.
And what is your role as an intensive care specialist?
So we just have to monitor the patients, and that's it. But the alarm keeps on ringing all the time, and so that's the time.
Probably if you proactively start doing it.
Yes.
In the CRRT part, you can install it. In our hospital, we from the intensive point of view, our students, they do it. So they know even the small technique.
Right.
So when you do all these things, probably it's much more prudent to change the setting.
Right. But no one really teaches us in our practice and our day-to-day practice that how to set up a machine, how to look at the small technical issues and everything. So yesterday's experience was really good. Yeah. Thank you.
I'll tell a secret. This is the only way you can intimidate your juniors. You can make them scared of it. So if you ask them questions about CRRT, juniors will never talk to you. That's the way we have learned. So initially, what is this machine? And the consultant will come and tell, this is what you don't know this and that. So that you learn that so that you can apply to your juniors to keep them
on Any one of you? Yes, please come to the stage. Thank you. Thanks. First introduce and from your
I am Girish Singh Baghel, sir. We have anesthesia and critical care team.
You are from which hospital?
Sir, that's what, sir. We have a critical care and anesthesia team, sir, which operates from Zahirabad, which is near Karnataka border, till Uttar Pradesh, sir, Gorakhpur.
Okay.
So we have 7 different hospitals situated at different places. So we'll be roaming all around. So, sir, my thing is 15 years back when we saw ventilators, sir. In my post-graduation, very few people were interested in learning because everybody was scared for ventilators. Same way, sir, what I expect out of this conference or the coming up conferences is that anesthetist or MBBS guy or a critical care specialist should not be scared of CRRT or ISD or SLEP, sir. That is first thing. And second thing, sir, not all the hospitals are equipped. In my center, sir, only one center is having CRRT. Rest of the 6 centers, we don't have CRRT. But we will get all kinds of patients, and we cannot shift one patient which are nearby the hospital also from one center to the other center, even though we know this patient requires CRRT. So in that scenario, how to handle with this Fresenius machine which is used for intermittent hemodialysis, how to use that for the benefit of the patient, that we should learn, sir. That is one thing. And practical aspects are when we are changing ventilator setting, after half an hour we are supposed to send APG. So if we are concentrating on changing pH, after how much time we have supposed to send APG, that we don't know still after this. And second thing is hemodynamically unstable patients comes. So what will be the settings of ISD if we don't have CRRT? And third thing is antihypertensives in management, and diabetes with hypertension with chronic renal failure. So all these kind of things, practical aspects, sir. So what I feel one day should be completely dedicated to hands-on training, sir. Yesterday we didn't have this peritoneal dialysis, sir. And we also didn't have this toxic removal, that cartridge, the activated carbon thing. Hemoperfusion. That we didn't have, sir. So one day should be dedicated completely for practical aspect, only then we'll be having a good time.
Yeah, definitely.
Yes. Thank you, sir.
Yeah. Actually, we didn't get the cartridges because the company personnel is not available. But I'm sure next time we'll get it. We actually have the plan to start hemoperfusion, so the hemoperfusion cartridges, hemo-adsorption circuits, and Mars machine. But it was not available. That is the reason we could not able to show you. But surely next time Tapas will.
Yeah. So guys, just a word of caution. This CRRT is a very beautiful therapy. It has its own role in a selected set of patients, but it's not available to everybody, and it's very expensive. Even in Apollo, to use it run it on a day-to-day basis, it becomes very expensive. So I think you have to use your resources very effectively. Trust me, the center where I was trained, there were papers like how SLED is equivalent to CRRT. You run SLED continuously, and in terms of anything, metabolic clearance, product volume clearance, and even the cost. See, abroad the cost is a major factor. When you run CRRT for so many hours, of course, there are cost implications. So you can run the same, probably most of the cases you can achieve the same thing with continuous SLED also. So, if you can't use CRRT, yeah, you can do almost the same thing with continuous SLED. So, so it's with the Ddavp machine. So low blood flow, low dialysis flow, gentle clearance, hemodynamic monitoring, inotropic support. I think it's possible to manage most of the patients. Now, touching upon PD, yes, PD is a very PD has its role. We did not talk about it. We don't talk much about it. It's it's becoming a forgotten treatment, but PD will come back. Again, as in the resource poor settings, PD will have a role, as an alternative to hemodialysis or CRRT. So, but yeah, next time we'll incorporate PD, acute PD. We are not doing, but we'll try to do it, and we'll try to incorporate acute PD in your curriculum next year.
Adding to sir, Dr. Valentine has shown also yesterday in one of the machine that where you can continue for the dialysis for 24 hours in SAT.
Yes. But yeah, of course, the PD we could have shown them. Yeah.
So, more questions than answers, more queries than the solutions. I think I would get these points from the 2 days course. And believe me, we started in the idea that we would have something for the very beginning to help the candidates, the trainees. But what I feel, and the brainstorming has been already done, today only I discussed with the speakers as well as the faculties as well as few trainees. So what we propose, and we have almost decided that the next review course, this is a ever learning, the learning curve is very steep. So we have already added how do I do. Just for the sake of understanding, there would be a session, how do I do? And the doctor just before told that hemodynamic instability condition, how do you manage something? So we would be combining 3-4 things. In ICU, it's not like the patient will be coming up with only nephro problem and sepsis problem. There will be also simultaneously neuro problem. So in that situation, all those tricky situations, there will be 2 or 3 conditions associated together. So how you plan your the advice, that part would be there. There would be another section, trainee section, where you would be allowed to ask any question related to nephrocritical care. So we would make all those sections in the upcoming review course for sure. And also there would be questions there would be a session, whiteboard session. So whiteboard session, it means that you would be drawing that thing rather than the PowerPoint. There will be no PowerPoint presentations. So these are something which we need to do. Yes, I accept there are many things we could have done, but yes, this is the first time. Always it's no, we have to learn from the things. So maybe in the next review courses, you would get the feeling of what we have actually left. Thank you.
And actually many of you had sent a feedback regarding the ECMO training program, because they also feel that this is also one of the areas that need to be trained. We are definitely discussing on that. So probably ECMO and transplant are the 2 areas. Again, we'll have to have one more session in the future, and that will update you in the group. Definitely. Anybody else?
Anybody who wants to share?
So I think with this, I conclude the 2 days, means 3 days session of nephrocritical care. The first nephrocritical care, session in Apollo Hospital, Navi, Mumbai. And definitely the future, I think, will be in touch with you. If such courses are happening next time across India, we'll send you the message. So thanks to all for attending this course from our department, Nephrology and Critical Care both. And hope to see you soon in the future. Thank you.